give us, myself and Nick, we will be listening to.
We're going to do the presentations, right? And I'm supposed to ask questions, but maybe ask set.
Sure.
Thank you. পড়াশোনা ওরা দুজনে প্রেজেন্ট করছে আমাকে আর আমি যেন অন্য জায়গাটা তোমরা দেখছি ওরা ঠিকঠাক প্রেজেন্ট করছে, ঠিক আছে? এবং আমি তো ওরা আপনাকে প্রশ্ন করবে এবং আমি দেখবো ওরা আপনার সঙ্গে কীরকম ইন্টারাক্ট করে, ঠিক আছে? আপনি এগুলো ধরে রাখতে হবে, এগুলো এখানে রাখুন। আর আপনাদের গরম ঠান্ডা যেমন কিছু লাগছে না, সকালে ব্রেকফাস্ট খেয়েছেন,
আউটপুটটা দিয়ে যাবে।
আর আপনাদের যিনি কথা বলা আপনারা বুঝতে পারবেন। আর ইনি একজন আমাদের যারা আমি যেখান থেকে এসেছি উনিও আর এরা তো ওই You're also students?
Yes.
So which year are you from?
Oh.
Which year?
No, sir, we are not students.
We are not students. You are first year one. You come and sit here. You are first year student. They might be, you need to learn from them, right? I probably don't need this today. Maybe we can hear me. But I think you're recording, right?
Yeah.
Yeah, so let's just do it. You can use that. So, who's going to present first? Introduce yourself, take permission from the patient, and tell them what you're going to do, and then present.
আমার নাম ডক্টর লাকি, আমি এখানে ডক্টর। তো আপনি যদি ঠিক থাকেন আমি আপনি মানে পারমিশন দেন তাহলে আমি জিজ্ঞেস করব।
Good. Very good. You can start now.
একটি নাম আপনার?
আমার নাম মোহাম্মদ আদারুদ্দিন।
আচ্ছা, কত বয়স?
33।
আচ্ছা, কোথা থেকে এসেছেন?
বসিরহাট।
আচ্ছা।
24
আচ্ছা, আপনার এখানে আসার কি কারণ? এখানে কি করে
আমি
আসেন?
যখন এসেছিলাম আমার হাতে পেটচাপের ইনফেকশন ছিল, তারপরে এখানে আসার পরে ব্লাডে ইনফেকশন হয় এবং ক্রিয়েটিনটা হালকা বেড়ে যায়। এখন বর্তমানে আমার পেটচাপে ইনফেকশন নেই, দেখা যাচ্ছে তারপরে রক্তের কোনো ইনফেকশন নেই, আর ক্রিয়েটিন 1.4।
আচ্ছা, প্রথমে আপনার কিডনির ওষুধটা কি করে শুরু হয় প্রথম থেকে?
Now, I'm more interested in what you just said, the urinary infection. Can you find out what symptoms did he have? How did he know that he had a kidney infection?
মানে কি সমস্যা হয়েছিল? কিডনি ইনফেকশন যে হয়েছিল, তো আপনি এখানে কি অসুবিধা নিয়ে এসেছিলেন?
আমি ট্রান্সপ্লান্টের পরে প্রথম সপ্তাহে এখানে চেক আপে আসি। চেক আপ আসার পরে পুরো রিপোর্ট দেখে ডাক্তার ম্যাডামরা আমাকে বললো তোমাকে ইমিডিয়েটলি ভর্তি হতে হবে, তোমাকে অ্যাডমিশন করবো, এটা তোমার আসলে চলবে।
আচ্ছা, শারীরিক কি সমস্যা হয়েছিল?
ঠিকঠাকই ইনফেকশন।
মানে ইনফেকশন যদি ডক্টর বলতো, কিন্তু আপনার কি অসুবিধা হয়েছিল? পেশাব করতে কিছু জ্বালা যন্ত্রণা বা অন্য ধরনের জ্বর বা কোনো অসুস্থ লাগছিল বা এরকম ধরনের কিছু হয়েছিল?
না, বারবার আধা ঘন্টা অন্তর পেচ্ছাপ হতো, আর কোথাও শরীরে বা কোনো কিছু
পেটে ব্যথা ছিল?
পেটে যখন আমি খেতাম, যখন খাবার খেতাম তখন আমার পেটটা যন্ত্রণা করতো, কিন্তু যন্ত্রণার পরে 5 মিনিট আবার যন্ত্রণা থেমে যেত। কিন্তু এখন বর্তমানে আমার কোনো যন্ত্রণা আর হয় না, আমি দেখা স্বাভাবিক ও সুন্দরভাবে আছে।
কোথাও পিঠে ব্যথা, জ্বর এরকম ধরনের কিছু?
না, আমার কোনোবার জ্বর আসেনি।
আচ্ছা।
So why did he have pain in his abdomen? Where was the pain exactly?
In lower abdomen.
Did he say that? ব্যথার একটা পাই হচ্ছিল
এই জায়গাটা
ওপর দিকে।
ঠিক এমন
ট্রান্সপ্লান্টটা কোথায়?
ট্রান্সপ্লান্ট এই জায়গাটা
তলার দিকে। তাহলে উপর দিকে ব্যথা হচ্ছিল, মানে খাওয়ার পর ব্যথা হচ্ছিল?
খাবার যখন খেতাম তার হাফ খাওয়ার সঙ্গে সঙ্গে হতো।
ভাত খাওয়ার সঙ্গে। What do you think? What are the differential diagnoses of a pain after eating?
এখন আর হয় না, আমার শুনলে স্বাভাবিক, কোনো অসুবিধা নেই।
Very good. So you might have had peptic ulcers. Is there anything else? Give me 5 differential diagnoses. Peptic ulcer disease, okay, fine. মাঝে মাঝে আমি একটু প্রশ্ন করব। Acute pancreatitis. The pain comes and then goes away after. Do you think that would be pancreatitis? Okay, it might be. Anything else? Yeah. Help her out.
Cholelithiasis.
Cholelithiasis,
Pain
yeah.
is on that.
On the left hand side, you got that right. Anything else? But it still could be.
From the maybe the native kidney has some infection.
Yes, the
What's
native
pain?
kidney is there, right? It won't fit with the exact temporal profile of the pain. You know, you eat and then you have pain. It doesn't fit that way. Anything else? No? Okay. Anything else you can think of?
Esophagitis, costochondritis,
Esophagitis or costochondritis. Yeah, that's a
local skin area herpes zoster.
Yeah, herpes zoster is something to think about, yeah. So, you know, when you're thinking about this, you're also thinking about what you're going to look for when you examine the patient. Now, I did want to spend some time on his symptoms because of two reasons. One, you need to put some importance whatever the patient says. Even if it leads into a wrong path and you don't get the right diagnosis or whatever it is, you're at least showing importance to the patient. You're at least acknowledging their problems. And that helps you to develop a rapport with the patient. It helps you with compliance. Right? Okay, carry on. Question for that.
Regarding I asked regarding the UK or some.
You carry on with the presenting illness.
আচ্ছা তারপরে কি হলো এখানে আসলেন ভর্তি হয়ে গেলে
এখানে অ্যাডমিশন হলো।
হ্যাঁ তারপর কি হলো
তারপরে ডক্টরের ট্রিটমেন্ট করলো, খুব সুন্দর ট্রিটমেন্ট করেছে। দেখা যাচ্ছে পেটচাপে ইনফেকশন এখনো আর নেই।
কদিনে ঠিক হয়ে গেল ইনফেকশন
ইনফেকশনটা 20 দিনে ঠিক হয়ে গেছে। তারপরে আমার হচ্ছে ক্রিটিনটা যখন হালকা বাড়ছে আর কমছে, তখন ডাক্তাররা হচ্ছে চেষ্টা করলো যে কীভাবে দেখা যাচ্ছে এই বাড়ছে কেন। তারা সঙ্গে সঙ্গে রক্তের আমার হচ্ছে রিপোর্ট করলো, একটা রক্তের রিপোর্ট করলো। সেই রিপোর্টটা করে রক্তের ইনফেকশন ধরা পড়লো। আমার 22টা আইভি দিয়েছে টোটাল, আর মেডিসিন দিয়ে দেখা যাচ্ছে রক্তের ইনফেকশনটা ওটা 20 দিনই কমে গেছে।
আচ্ছা ক্রিয়েটিন কত বেড়েছিল মানে
ক্রিয়েটিন যখন এসেছিলাম তখন 1.53 ছিল। তারপরে দেখা যাচ্ছে আস্তে আস্তে বেড়ে 2.04 হয়। তারপর ট্রিটমেন্টের পরে ওইটা কমে 1.8 হয়, 1.7 হয়, 1.6 হয়, 1.55 হয়, 1.5 থেকে 1.4, তারপরে 1.3। তারপরে ওইটা আবার হচ্ছে ব্যাক করে।
ছুটির সময় কত ক্রিয়েটিন ছিল ছুটি যখন হলো এখানে প্রথম
0.79।
আচ্ছা ওখান থেকে আপনার 1.53 তে ভর্তি হলো এক সপ্তাহ বাদে
অ্যাডমিশন হলাম এক সপ্তাহ বাদে।
হ্যাঁ
তারপরে এখানে ভর্তি হওয়ার 3 দিন পরে ওটা আবার বেড়ে 2.04 হয়। ওখান থেকে ট্রিটমেন্ট চলে, দেখা যাচ্ছে ট্রিটমেন্ট চলার যত ট্রিটমেন্ট চলে দেখা যাচ্ছে 15 দিন 1.8 থেকে 1.7, 1.6, 1.55 থেকে 1.4,
দুইয়ের মধ্যেই চলে
1.4 থেকে 1.3 হয়। ওখান থেকে এবার আছে আইভি চললো 22টা।
আইভিটা মানে চললো তার আগে কিছু হয়েছিল কিছু টেস্ট আপনি বলছিলেন কিছু ভাইরাস ধরা পড়লো
ব্লাড ইনফেকশন
ব্লাড কত কমে গেছিল
ব্লাড হচ্ছে আমি যখন ভর্তি হয়েছিলাম তখন 7.4 ছিল
হিমোগ্লোবিন
হ্যাঁ। তারপর আস্তে আস্তে শেষ অবস্থায় 4.6 হয়। তখন আমাকে দুটো ব্লাড দেয়, দিয়ে তখন 8.1 হয়। তারপরে দেখা যাচ্ছে ব্লাড না দিয়ে 8.3 হয়, 8.5 হয়, তারপর 8.7, তারপর 8.8, 8.1, 8.8 থেকে 10.3 বর্তমান।
এখন বর্তমান মানে কিছু ওই স্যালাইন দিয়েছে 22টা বলছিলেন
22টা আইভি
আইভিআইজি
Right, okay. Interesting. আপনি এত নম্বরগুলো মনে রাখেন কি করে? পর বলে যাচ্ছে।
আমি রিপোর্টগুলো দেখি
দেখিয়ে মনেও রাখেন। খুব ভালো, খুব ভালো। So, what did you figure out till now?
Actually, he had a UTI for
Yeah.
which he was admitted, but after that his hemoglobin also came down to less than 7 or 6, for which he required PRBC infusion. Along with that, he had been done some evaluation for that, and some virus has been detected for which
He didn't say a virus, he said another blood infection. Did he say virus?
He said
আপনার কি ভাইরাস ইনফেকশন হয়েছিল?
হ্যাঁ
virus he told earlier
Okay,
was.
all right, okay. Sorry, I missed that.
Sir,
Then-
Pratik sir will also be taking a case.
Yeah, Pratik, you could start with him. Somewhere, but does he have a place to sit?
Yeah.
And then IPIG was given around 22 per stand. 22 bottles of IPIG.
How do you know it was IPGMER? He didn't say that. আপনাকে কি ওষুধ দিয়েছিল ইনজেকশন ছিল? অত বলতে পারো না। ওটা অ্যান্টিবায়োটিক ছিল।
मैडम
Right. Okay.
मैडम
আমাদের মাইক লাগবে না, আমরা জোরে জোরে কথা বলি। So you can get the mic. Actually, then it will be confusing.
Actually, Mike will be a
Yeah, you know the mic will actually cause confusion because it will be, and then I can't hear myself. So I don't want a microphone. You can switch this.
Okay.
You come here. You stand here because I'll be asking you questions. This is your name. Rosalind. এনাকে চেনেন? ওর নাম কি? You couldn't know that was idea. You didn't say it. Right?
This systemic blood pressure was more than 160 millimeters of mercury. That time, he did not have any history of reduced to the history of shortness of breath, he doesn't remember any renal function test report from that period. He was prescribed 53 medication. He was not compliant of that. He used to visit doctor sometimes when blood pressure used to be around 120 mercury, but still he was regular on medication. He used to have on and off headache. For that he used to take Saridon tablet and painkiller from local shops. So with this, in 2015 he had dizziness and fall, followed by he was diagnosed to have renal dysfunction on that admission in a hospital. This he says that this time he had on and off leg swelling for 1 or 2 years. This during this time he did not have any history of convulsion, hallucination, or weakness of lips. He did not have any history of chest pain, palpitation, nausea, vomiting, or nocturia. This episode, his creatinine was around 8, and on USG, his kidneys were found to be shrunken. So he was told that he will need renal replacement therapy soon, and he was counseled regarding hemodialysis, and he has started on oral medications. So after 4 to 5 months, he was started on hemodialysis for his urine output was 700 ml in that time. First, left femoral non-dominant hemodialysis catheter was placed, followed by left radiocatheter fistula was placed. For the first 2 years, he received twice a week hemodialysis, and later it was changed to 3 per week. He had good appetite during the dialysis period. His weight gain used to be around 2 kg. He had few episodes of fever and chills post hemodialysis sessions. He had received total of 4 units of ERTC. He used to take regular erythropoietin and iron sucrose injections, and he had received hepatitis B vaccination during dialysis. On 8th of May 2008, he underwent live-related review compatible to renal allograft transplantation from his mother. Age of mother was 54 years with no known comorbidity. Blood group was O positive. Creatinine was 0.9 mg per deciliter. The patient had CMV IgG status was D plus R plus, and his CBC cross-match test was negative. He couldn't mention any other test which was done pre-transplant for immunological evaluation. He had no history of hypertension or blood transfusion intraoperatively. Induction agent was Bacilliximab, and he also received methylprednisolone pulse, and he was discharged with tacrolimus 2 mg BD, MMF 2 gram, and prednisolone in a tapering dose. So his discharge period was 1.1 mg per deciliter. was stable post-discharge only at
That was
only month of September 2018, around 4 months after transplant, he broke his shoulder and admitted for evaluation and found to have biliary tumor. This time he also had bicyclemia and his physical level was also higher, around 14 nanogram per deciliter. So for this bicyclemia, evaluation was done and he was found to have beta thalassemia renal, cadmium and as no cause was found and tacrolimus induced PRC was suspected and tacrolimus was stopped.
That's where you get the increase.
And cephalosporin was started. And ATD was continued. Isoniazid, ethambutol, pyrazinamide and levofloxacin. November 2018, he had one episode of UTI for which he was admitted, treated with antibiotic and discharged, and this time he was diagnosed with post-transplant diabetes mellitus and started on insulin.
Then you did the
In January 2019, his creatine was 1.2 milligram per deciliter. February, he had a creatine elevation from 1.25 to 2. This time C0 level was 241 nanogram per deciliter. So the average toxicity was suspected and cyclosporin dose was reduced. This time renal biopsy was also done because cyclosporin level was not very high, but LN features were normal and only immunofluorescence there were regular IPGMER deposits. So renal biopsy was reported that this might be a possibility of stage 0 membranous nephropathy. So in July 2019, this creatine was 1.8 after the reduction of the cyclosporin dose. In the meanwhile, he was continuing the ETT. After October 2021, he was COVID RT-PCR positive. Though he did not require any oxygen support, he was sent home isolation for that time, but his creatinine was 2.81 and his MMF was stopped and prednisone dose was increased when sending for home isolation. After when he came to OPD, his creatinine was 2.5 and MMF was reintroduced, and after that creatinine came down to baseline. His baseline at that time was 1.7 to 1.8. But in the 2022, his creatinine was fluctuating between 1.8 to 2.6. For this fluctuating creatinine, a renal biopsy was done in November 2022, which showed acute tubular injury and spike and holes patterns suggestive of membranous nephropathy. Though this time his 24-hour urine protein was less than 500 mg per day, and he was on cyclosporin and MMF. Anti-plaquenil also was done, that was negative. After this acute due to fluctuating creatinine, acute tubular injury, CNI toxicity was suspected, and cyclosporin was changed to everolimus. So after November 2022, he was on everolimus, MMF, and prednisone. But after starting everolimus, his creatinine was around 1.8 baseline. His proteinuria starts to increase, and it was 2.2 gram, then it was 2.24 gram per day. So June 24, a repeat graft biopsy was done. Plan was to give rituximab with membranous nephropathy proteinuria or just to stop everolimus if it is everolimus. So this time my EM was also done, and it did not show any features of membranous nephropathy, and there were only 10 to 15% food processing incident. So in October 24, he had proteinuria was persisting, and plan was to stop everolimus. This was happening. Then again,
Very focused. Reporting of the newspaper. So they're very focused on the problems of checking the patient. Otherwise, you cannot deal with it. so frequent changes in the immunosuppression of 3 5 6. So that's what the basic problem.
Basic problem is making rise of creative service in the background history. Making rise of creative since January 2025. So this last biopsy there was only patchy it is, so epidermis was stopped because of the proteinuria, thinking proteinuria is because of epidermis, and epidermis was reinitiated, and then since January 25 there was a rise of creatinine from 2.5 to 2.7 and admitted with 3.04 of creatinine. So this time he also did not have any reduced urine output, his no history of bacteria, urine, no history of fever, got graph pain. The same patient has been biopsied and received injections.
Without everything is taken. Okay, so don't mix it.
And creatinine is one
Don't check that patient and hypertension may cannot remember anti-hypertensive at the same time. From your perspective, you are telling the history like injuries, disease. So that's the doctor's perspective.
Actually, not completely we have included both the reports and the.
So whenever you tell in either in a patient's perspective or a doctor's perspective, then it becomes discussion.
Very good. It could be a hypertensive nephropathy. Unusual. Nowadays we don't see it very often.
Past history,
এখন
such.
কত বয়স?
46
46. অপারেশন হয়েছে কত সালে?
8 5 2008
Again, for the insurance,
বয়স ছিল।
Other than that, past history surgery of hemolysis was done in childhood. History of kerosene lead poisoning was done in childhood. Personal history, birth history, normal vaginal delivery, institutional delivery, no emergency admission, but that was not all childhood vaccinations were taken.
In fact, when you said, tell us from the beginning, you didn't start off by saying, oh, I used to have pain.
Family from around 10 to 20.
Then,
Smoker,
so
10 packs.
it's less likely that's a possibility.
And history of alcohol addiction was also present. Family history, 3 brothers, 2 sisters, no history of kidney disease in any
Reflux.
family member. Father died 3 years ago. And family history of tuberculosis present. Father had tuberculosis 3 years before that.
What else could it be? So, young age,
Action
presented
of
with
diagnosis.
high blood pressure, which is incidentally
Patient.
Pressure
and
high থাকে
creatinine of 1.6. So, she's always, what are the 3 things you told us?
28 26 28 পা খুলে যায়
And you said? You said something else?
So,
Just
tell about the history of hypertension.
so, young person, hypertension.
Kidney disease and
Hypertension is not there in the family.
That's a possibility, yeah. FMD.
So it is important because the points are you missed the treatment part. It is important. It has a 20 probably to a diagnosis.
Because of secondary hypertension, you have to
Probably I think it's a case of nobody suspected at that time of analysis. So for that reason, family history is important. So what the correlation with parental hypertension, essential hypertension,
Cause of gene. Don't forget, other global nephritis.
suppose one parent is hypertensive, what is the possibility of essential hypertension? Both parents are hypertensive.
So you didn't give a classic history before, but that's a possibility.
Parent is a family.
What else?
What's the part of the
Have you been reactive control?
like a type 2 diabetes, hypertension is also family.
So what are the conditions you see reaction?
usually
So let's say, not exactly presenting between the
Polygenic virus, like the type of diabetes, definitely family history. The
Brain
one parent is
usually they don't present
hypertensive, there is a almost 50% chance of becoming hypertensive. Both parents have hypertension, parental history when you get a patient at say 26, 28 years with hypertension, maybe a secondary cause. Homogeneity or secondary and hypertension. Hypertensive at the age of 25 and 55.
Maybe you don't see that, right?
There are more of primary cause of hypertension, secondary cause of hypertension, and in 50 there are more of essential cause.
No. Yes.
Less than 30 we generally should rule out other causes of hypertension.
What else?
But still, what is the percentage? Suppose at the
What do
age
you know
of
about
28 you are diagnosed with
genital
hypertension.
urinary
That
tract
part, how,
malfunction?
what is the possibility of having a benign essential hypertension versus a secondary?
So then,
You said about
Still 80% is
what
a
about
benign essential
other
hypertension,
stuff?
20%. When you use a 50 years away, it is a 95% 5%.
Yes.
So he was detected hypertensive at that time
There,
also.
not there, normal, one there, other one not there. Exactly. So don't forget all of
Renal
those.
dysfunction at the age of 2015.
almost
forgot when you-
36, 37.
And in 2008 and 15 no investigation was done. So 2015 সালে যখন অসুখ কিডনি অসুখ ধরা পড়লো তখন ক্রিয়েটিনিন কত
আমি
ছিল?
জিজ্ঞেস করছিল মনে হয়।
ক্রিয়াটিনটা সেরকম বাড়ে মান 5 পয়েন্ট হয়েছিল 3.5 পয়েন্ট থাকতো তারপরে শ্বাসকষ্ট হতে পর্যন্ত
18 সালে এসে দুম করে বেড়ে গেছে। কবার হাসপাতালে
18 অপারেশন হয়েছে তার 3 বছর আগে
ডায়ালিসিস
ডায়ালিসিস 3 বছর
15 থেকে 18 so he landed up in a ESRD of 2015 তাই তো almost.
ESRD 2016. After diagnosing within 1 year, he started to have receiving
So patient coming to the অসুখের origin is at age of 2008 developed a CKD stage 5 at 2015 initiated dialysis within few months or days time and got transplanted in 2018. But still at the tempo of the disease because your post-operative biopsy doesn't show any deficient neither is FSGS nor is maintenance nor is median. So it is difficult to identify it is and so what are the possibilities? If you consider it as a kidney disease, which started at 2008 and he landed up in the CKD stage 5 of 2015. What are the possibilities regarding etiology? I think it was a in 2008 and what are the PD at the age of 28, what are the common factors? OPT, you see the patient suspected coronary arthritis. It is IGNF at the age of 20. This is accepted. Clinical subset difference. Smokers, more of presentations and more explosive consistent chances of dissatisfaction. Other presentations at the age of 50, less theory, less explosive, that polypeptide is not that uncommon of If you get
আমার জায়গাতে লকডাউন হয় তারপরে আমি টোটালি আমি চলে আসি তারপরে দুদিন থেকে আমার কাছে ট্রিটমেন্ট করছে
যখন পিজি আসলো তখন ট্রেনিং
2.79
2.4 থেকে তারপর 2.79
79
তারপরে এখানে কি ওষুধগুলো স্টার্ট হচ্ছে কিছু
না ওটা আমার মনে নেই
প্রেসার কিছু খেলে না
প্রেশার তখন আমার প্রেশার থাকতো তারপরের অবস্থা প্রেশার থাকতো 210 হ্যাঁ 180 160 70 এর প্রেশারই থাকতো
হ্যাঁ, যখন ভেলোর আপনি গেলাম তখন ওষুধ খেয়েছি তারপর কোভিড হয়ে যাচ্ছে করোনা হয়ে যাচ্ছে তারপর পিজিতে আসলাম যখন পিজিতে আসলাম তখন প্রেশারটা কত ছিল
170 হতো 170 হতো কখন 180 হতো কখন 190 হতো 200 হতো
Yeah, this is very sad.
he was taking দুটো অ্যান্টি হাই প্রেসার দুটো ওষুধ খেতেন না
না আমার তো ওষুধ চলতো প্রথম অবস্থা চলতো 4টে
মেডিসিন ছিল
শেষ অবস্থা চলতো মোট 6টা আর এখন বর্তমানে আমার চলে একটা ওষুধের হাফ ট্রান্সপ্লান্টের পরে
ট্রান্সপ্লান্ট করবে 6টা
ট্রান্সপ্লান্ট আগে
আগে 6টা
6টা আর এখন বর্তমানে আমার একটা মেডিসিনের হাফ
যখন ট্রান্সপ্লান্টটা হয়েছে তখন ডায়ালিসিস হয়েছিল
আর ডায়ালিসিসের 2.5 বছর
কত
2.5 বছর
আড়াই বছর
2.5 বছর
যে ব্লাড কতটা লাগে মানে ট্রান্সপ্লান্ট আগে
ট্রান্সপ্লান্ট আগে 1 বছর আগে আমি একবারই ব্লাড দিয়েছিলাম
ডায়ালিসিস সময়
ডায়ালিসিস ওই চ্যানেল দিয়ে
মানে ডায়ালিসিস সময় কি
হ্যাঁ ডায়ালিসিস সময় একটা
তখন পেছাব কত
পেটটা ডায়ালিসিস হতো না
কত দিন ধরে পেছাবটা কম কম
পেটটা টোটালি হতো না প্রায় 2 বছর 3 মাস
যখন আপনি ভেলোর গেলেন তখন পেছাব নরমাল ছিল তারপর পিজি আসলাম তখন পেছাবটা নরমাল কত টাইম ধরে কম কম
ওই যখন ডায়ালিসিস শুরু হয়
শুরু হওয়ার 2 মাস পর থেকে ওর পেচ্ছাপ
বন্ধ
বন্ধ হওয়া
বন্ধ
শুরু হলো।
বন্ধ বন্ধ
আর কিন্তু যখন শুরু হয়েছিল তখন ইউরিনাল নর্মাল
ওটা 24 ঘন্টা থেকে শুরু করে কালচার থেকে শুরু করে যত পরীক্ষা আছে এগুলো সবই করেছে আমি 1 মাস ছিলাম
Okay, let me ask you something. I mean, it's very sad what happened between his first IgA nephropathy diagnosis and his dialysis. And obviously the coronavirus was a problem, right? He couldn't go out, etc., etc. So, what do you think could have saved his kidney or lasted a bit longer? Very good. That's the first thing. And the second thing is control of blood pressure. And the third thing is control of blood pressure. What else could we have done at that time? Which we couldn't because of coronavirus. More frequent follow-up, yeah, and then changes the medications as required. Anything else? With the knowledge that you have today, anything else? Like you got into help around.
we don't know the medicine actually he was getting
But what else would we have given to a patient, a young patient with IgA nephropathy after controlling the blood pressure well, which he might have required 6 medications, as you were saying. What else could you have given? The newer agents, which has been. Say that again. Finerenone. When do you think finerenone is proven to be beneficial in kidney disease? Do you think it's in IgA nephropathy? Where is it? That's interesting. So finerenone is a non-steroidal mineralocorticoid receptor antagonist, right? So it binds slightly differently, and it does help. Which condition in kidney disease does it help? In diabetes. And how does it help? So it doesn't only help the kidney, but also helps the heart. Yeah. So it causes cardiac and renal protection. All patients who are already on ACE. Remember, both in the Figaro and Fidelio study, 99% of the patients were on ACE or an R, right? And they had a decent blood pressure control, around 130. And on top of that, adding a non-steroidal mineralocorticoid receptor antagonist did reduce the cardiorenal endpoints around about 18%, right? So that's where it has a proven benefit, not in IgA nephropathy. So what else could we she was giving a hint. Say that again. Right. I think you're saying the right thing. Yes. Yes. I think though we've never done a study on IGNFRP itself, but if you look at the subgroup analysis from the data CPG study, the IGNFRP patients do get the same benefit as that or the non-diabetic. So yes, that's number one. Number two. No, nothing else. Then she will take over if you don't get it. No. Okay, you.
Just try to control the inhibitor and kappa.
Very
Not
good.
control,
Yes,
then you
it
can
is.
try for
Sparse. What is sparse?
It is also it is a combined
Combined drug, combination of
endothelin receptor
endothelin receptor antagonist and
angiotensin
receptor. Okay, very good. What else? Remember, it's an inflammatory disease. So there's some evidence published in Lancet a couple of years ago, which was giving another anti-inflammatory agent does help progression of IgA. We don't have any studies where it prevented end-stage kidney disease, but we have evidence that it actually decreases proteinuria.
so you can give budesonide.
Exactly.
Yeah.
So how is that given? What is budesonide? It is a steroid. So it's a steroid which releases very slowly and supposed to be releasing right down close to the terminal line. So that's supposed to help. And the endothelin receptor antagonist you didn't know anything about, right? So that's another agent which has been. And there's a whole host of other agents which are mostly anti-inflammatory being tested now in clinical trials. They could be either in the complement pathway or other pathways are being tested with IgA. So it's an exciting time for IgA nephropathy. But the first thing that you do is control the blood pressure. The second thing that you do is control the blood pressure. The third thing that you do is control the blood pressure. The fourth thing that you do is give them an ACE inhibitor. His blood pressure was not controlled. I think that was the main problem. It's not the lack of budesonide, it's not the lack of sparsentan. His blood pressure was not very well controlled, which is sometimes really difficult. You know, আপনি ছটা ওষুধ খেতেন না blood pressure? 6.
He told to me like that 2 medicine for blood pressure and others are different medicine.
আপনি blood pressure এর জন্য দুটো ওষুধ খেতেন না, ছটাই blood pressure ওষুধ।
প্রথম অবস্থায় আমাদের বাড়ি ছিল, কিন্তু এরপরে যখন আমি ডায়ালিসিস করতাম তখন আমার দুটো ছিল।
না, যখন সে আপনি বললেন না একসময় আমি 6টা ওষুধ খেতেন, ওই 6টা কি ব্লাড প্রেশার না, শুধু দুটো ব্লাড প্রেশার, বাকি 4টা অন্য জিনিস
না,
6টাই ব্লাড প্রেশার। নামগুলো বলুন তো, নামগুলো মনে নেই।
না আমার
রামিপ্রোল ছিল,
হ্যাঁ
রামিপ্রোল, টেলমিসার্টান ছিল,
ছিল
আর কি অ্যালকামিন নাকি বলে,
আমলোডিপিন,
অ্যালকামিন,
Arcamin is what?
তারপরে ওই
Clonidine. Okay. So you have clonidine, you have telmisartan, anything else? Metoprolol, bisoprolol, atenolol.
combination একটা দেখিয়েছিল
treatment in IPGMER, then you would have gotten prazosin as well.
Prazosin, prazosin ছিল,
And you would have got metoprolol because we have only metoprolol.
only metoprolol, মনে নাই।
2017-18 সালে
Name the calcium channel of this?
amlodipine stemlo
Stemlo ছিল। Name the diuretics.
torsemide ditor ছিল ditor
So he was in a combination of whole host of medication, but still the blood pressure was not very well. I mean, that sometimes happens, quite rare. I mean, I see that maybe once every 10 years. he's one of the unusual cases where blood pressure is not in control. There could be other reasons as well. Sometimes the drugs might not be available.
Ah. Oh, case presentation should Okay.
Third year, first year.
Carry on.
So now I would like to know, actually, Mr. Yadav, here, they will tell you what they do as a protocol after transplant. So here is our transplant system. She knows everything about transplantation, much more than I do. So can you explain it to her? How is a patient looked after kidney transplantation? So what is your protocol? So when the patient comes in, what do you do? What is done on the second day? What's done on the third day? What's done on the day they go home? Then when they come, how are they looked after? What are the measurements that are done when they come to the transplant? Good. You are on the transplant now. Do you want to start? Then she will help.
From
Okay,
admission,
go ahead.
what we do.
From admissions. Let's imagine he has come for a transplant today. What would you do?
So first, check the normal routine blood profile.
Check the routine blood test.
Lipid profile. Then
Don't use
Actually, we
abbreviations.
admit the patient 3 days prior to transplant.
Okay, so start from the 3 days prior to.
3 days. First day of admission is complete blood counts, then general function test, liver function test, lipid profile, urine RDMA, urine routine examination, urine culture and sensitivity. Then triple serology, HIV, HB, HCV.
Okay.
If the patient is on
So
You
HIV.
echo also, EAC and this renal artery Doppler also you do.
No, hang on. So the virology test you do on the day when they come in.
Actually, we have done already, but these tests are done again, repeated on and
But
this.
why do you have to repeat it? Why? Why do you repeat it? Because if you have done it like 3 months ago, do you think things have
Because
changed?
here in the dialysis centers, they are in dialysis for the last 3 months, then they will be getting again infection, which happens sometimes. So we.
So there is a transmission, possibility of transmission. Okay, sorry. We don't do it, right? Do we do it on the, we do hepatitis B and everything as well? I don't do it that way. Carry on. Then you do an echocardiogram. We don't do it. So why would you do an echocardiogram on the day of? Because we would have probably, the way we do heart
Actually,
test
sir,
is as
here when we do the transplant workup, and from that time that we do transplant workup, patient is prepared. From that time to patient admitted for transplant, there used to be some gaps because there will be road to meet and all. They will be fixed that they are cleared for transplant. Then there used to be some gap, maybe sometimes 6 months. So some tests needs to be repeated.
Some tests needs to be repeated. So my question is, I mean, Ria is a master of it. Ria, do you think what kind of heart workup? So we would normally do an echo, right?
Now that
So I think we would just do an echo, right?
So just an echo and ECG on the
ECG.
yeah.
And that's-
that only. ECG and the renal artery Doppler.
So why would you do a renal artery Doppler? What would you do with the result? It costs money. For us, it's like £200. Tell me your name again. Rosalind. Rosalind, why do you do it? Why did you do his renal artery Doppler? What were you looking for? And how? Because I think we don't need it.
We don't need repeat.
But even firstly, renal artery Doppler, you need a good person to do it. Somebody who's experienced. Because the kidneys are quite far away. So, you have to look at the kidney arteries. It's not very easy. And secondly, do you think he had renal artery stenosis? But that must have been investigated when he went to Vellore. Because he got an echo, everything done there. I thought that was for transplant work. Anyway, So you do a unilateral doppler. We wouldn't do it. Carry on.
Then some after these reports are available, we send for cardiology clearance again. Then cardio CTB's clearance.
So cardiology has to come and clear.
Yeah,
Even if the echo is normal.
Yes, sir.
Yeah.
We don't
we
do
have
it.
to take 3 clearance before again,
So
like
you want-
anesthesia,
okay.
CTBS and cardiology.
No, we
on
do
that
anesthesia clearance for sure.
Yeah,
But not-
we may have taken earlier also, but again we need to take these 3.
It all costs money.
Yeah,
It's not free. The cardiologist's time is money. Alright, okay, so when you do it. Huh?
Can I ask
Okay, you go ahead, sorry.
So from the time when he's called in for transfer, let's say he arrived on board, from the time he's called in for transfer,
Yeah.
arrives on the board, to do all the blood tests, echocardiogram, getting the clearance from the cardiology.
Yeah.
How long does it take until you
It
get
takes
all
1-2
this?
days.
Oh, this is talking
This is
about
living
that?
donor transplant.
Oh, okay.
This is not deceased donor.
No,
Don't worry, we're
no,
gonna
this
attack.
okay. And we have to start diagnosis and 2 days prior.
2 days prior, living donor. Well, we do. We do it on Friday. Our living donor transplant
We do it Saturday, Sunday. Sunday and Monday, and we'll do it every after transfer. And then CDC,
But you don't get a
CDC
level.
also
So you
will
won't
be-
get a level. If you're doing Sunday and Monday and he's getting transplanted on Tuesday, you then get to change it. The type of you don't get a level.
Yeah, we don't change. We according to his weight, 0.1 mg per kg per day, we divide this. We just add it.
So why are you starting the tachylomas before? Is it not because you want to get a steady level before he has the transplant, or is it just you're loading it?
How many days in your study?
I'm not 100% sure, but let's ask Riya. So Riya, when do we start the tachylomas?
So, protocol we do 1 week for patients who are on dialysis. We do 1 week. So if we do normally the living donation transplant on a Wednesday, so they'll start Wednesday before. But nowadays we start on a Friday, depending on the consultant.
Friday, Wednesday,
Friday,
4 days.
Wednesday.
4
So
days.
they have a dose on Friday, and Monday they'll come back for final cross match, and we do the level as well. And then coming in on Tuesday for admission, operation, and
So the logic is you're getting a steady state tachylamus level when the patient is actually going into transplantation. When the level is not too high, causing intrarenal vasoconstriction, not too low, i.e. not providing the adequate anti-rejection therapy. That's why we do it. So why do you do it? For all our deceased donor transplants, we do the tachylamus in a different way. So we have about 110 deceased donors and about 50 living donors, so mostly deceased donors. And we have to tell you what we do for our deceased donor transplants. No, it's not better. I'm just trying to understand what you're
So we
talking
keep induction also, but we will start 2 days prior.
2 days back. Okay, you tell us with
but in
the
this
deceased.
case, they are given obviously from before they go to the team.
Yeah, but we do, when they come in, what we do is, they're in the middle of the night, right? So we will give them a loading dose, which is twice the dose of the dose that we give. So for example, if somebody gets 15 milligrams loading dose, then we get 7.5 pp. After that, 7.5 milligrams per day. So the loading, we do give a loading dose, but double dose once. And we also, depending on what ethnicity they are, we change our dose. The reason is one of our previous professor, Professor Jim, spent 20 years trying to figure out what the loading dose should be. It took him 20 years to figure it out. And what he told us at the end of 20 years is that if there's a black guy, give him twice the dose.
Double dose. You give 0.1 mg per kg.
No, we get 0.75 milligrams per kilogram twice a day. But if you're black, you get double. Because in our locality, the blacks are usually the expressors. And people like me and the whites are not expressors. Usually. So this is, we are not doing a genetic testing each time. After 20 years we have figured that out. Okay, so carry on. So I'm trying to understand the logic of giving it on maybe you're doing a slow loading dose. Maybe that's what you're doing. You're giving on Sunday and Monday and Wednesday. Okay, carry on. Sorry I interrupted you. What do you do after that?
CBC also on the day of
So we do the same, right? We do the final cross-functional Monday.
On Monday of the week.
and a heparin analysis on the day before.
We do the same.
On the day, on the morning of transplant, we give the fat prednisone just 1 hour prior to transplant.
So you would give it in the ward?
Yeah, generally we give it in the ward and
We don't give it in the ward, do we?
you give in the OP.
Are we talking about like the loading?
No, we have prednisone.
No, it's in theater.
Yes, we give the yeah, we also give 500, but then we give in the ward, then receive the patients.
Vasilisa was given
Give it over.
Vasilisa was given during operation, but to temperature we give in the ward and then receive the patients.
I think that doesn't make a huge difference, right? You're probably giving it very close to the operation.
Yeah, yeah.
1 hour.
1 hour
Just,
before the operation. That's fine. So you've done that. Then the patient goes to who goes to the theatre with the patient? A nurse from the ward?
No, we first of all.
You go. Alright, what do you do? Why do you go there? What do you do there?
actually there
What use are of you at the theatre? No, it's a joke.
so more to the patient and to very nice.
Alright, okay.
And
You carry the perfusion solution.
there is
Oh, you
to be
just
there, but we
prepare that.
prepare that and we just monitor. And if there is something, some events going on, if patient develop hypertension, we just record those and
So you get changed into theatre dogs.
and their nurses and all must be there, their OP nurses. They also know.
Will a transplant nurse go into theatre?
Actually, we don't have a dedicated transplant nurse.
That's a problem.
That's a problem.
So who does your, so do you have a kidney transplant workup nurse?
No, we generally this first year when they have a posting, they only doing the transplant workup, and for the immediate post transplant is HDU is there. Their from urology part.
So they are transplant nurses?
Yeah, the transplant nurses are there. They know the what. Basically, they in these few years they know that what needs to be done.
Or needs to be done
our
after
yeah.
post-transplant. So there is no nurses getting involved with the transplantation before operation?
No.
Zero. So Chinese, Sindhu, protein. So how many transplant nurses do we have to look after patients before transplantation so that they know?
Alright, so in St. George's we have one transplant coordinator for the receiving, and then one who is the living donor coordinator, and there is another nurse who works 50% with the donor coordinator and 50% with the living coordinator. So doing all the tests, making sure, and then once they get activated on the list, the other nurse
Yeah, that's coordinators we have. After getting activated, then this further to meet and all, we have some local coordinators, but we don't have the nurse.
So are they nurses?
No, they are not
They're
nurses.
not
They are
nurses.
just a
So what are
coordinator.
they?
They will be coordinating with the.
What is their background? They are trained as a nurse?
No, they are coordinators like if there is some disease donor, if some cadaver is going to come,
So
then
that's
they will
nice.
be the responsible.
No. What are SNORs?
So the SNOTs, we have SNOTs like the specialist nurses for organ donation. So they usually based in ICU to talk to the family of the life
Disease donors.
Yeah, they come, they also coordinating. They are not posted in ICU, they are in the roto office, they will be like coordinating if there is some.
I think it's all, that guy yesterday, Roger, who does everything. We had an ICU doctor here yesterday talking to us. His name is Roger. Do you know him? He's a
I
fair
saw the child.
guy with golden.
Yes, that ICU.
Yeah, the trauma ICU. So we have got these specialist nurses for organ donation, right? Yes. So they are in the ICU, and when a patient is approaching, they go and speak to the family, and they liaise with NHS BT, which is NHS blood and transfusion. Then they get all the, if the family agrees, get all the data from the deceased, age, general sex, etc. Then they send it to the NHS BT. Shantashi, অনেক শুরু হয়ে গেছে। Do you know him? Did you do your MD here? Did you do your MD there?
The case আছে কেসগুলো ছোট ছোট এগুলো এমনি এখানে স্পেশাল
Ah, so can you just in 2 minutes give us summary? So this is your test. How can you summarize what we have discussed till now in 2 minutes?
This is a post-transplantation presented with early post-kidney transplantation. Presented with early acute graft dysfunction. He has a native kidney disease of IgA nephropathy, and post-transplant he had a UTI, following which he had a pulmonary infection, and he had some rising creatinine. So he was treated with UTI was treated with antibiotics and
organism was isolated or not?
yes, pseudomonas. That was treated. Then after that, after pulmonary was treated with IPIG, and now he is having the creatinine still increased from the baseline. He was discharged with creatinine of 0.79. Now his present creatinine is 1.3. Maybe it will be evaluated if he has a rejection or not.
এরকম করে স্পেশালাইজড লাইক এই সবই ট্রান্সপ্লান্ট কেস আজকে নাকি
During transplant.
সবই ট্রান্সপ্লান্ট তাহলে অন্য কেস আছে অন্য ইন্টারেস্ট
No, the interesting thing is that our discussion hasn't been around transplant.
The post-op, কদিন post-op?
Listen, Shantashi, listen. Sorry, we are batchmates. I can tell them.
আর আরেকটা কথা কোশ্চেনের তুই সারাক্ষণ এখানে নাকি
হ্যাঁ?
তুই এটা চার্জে আজকে তাহলে তোর সঙ্গে গল্প করা হবে
No, essentially. So what I did was I started off by asking you differential diagnosis of. We started with differential diagnosis of pain after.
প্রেজেন্টেশন ছিল তো এটা নাকি
No, so this time when you presented, can you tell us his presentation now? So when he presented at this edition, what was his main complaint? Increased frequency of menstruation and abdominal pain where? Left upper quadrant, right? And what were the differential diagnoses? We talked about it. One. She also said something very interesting which happens in post-transplantation. So you're going from the skin to all the organs here. That's how we start, right from the basic. Almost at an MBBS level. I think that's the most important thing. When a patient presents with their complaint, you need to listen to them. You need to figure out what could be the cause of that. You need to have a set of differential diagnoses. If you never have that and you jump into a conclusion, like he said, I had an UTI, you might miss very important things which can make a huge difference to his care and his prognosis. So we started from the basics, but now we're doing something very different. We're talking about the role of transplant assistants and nurses like Leah is on patient's care before and after transplant. We've just finished the transplant. So what happens after transplant? Who looks after it? So everybody goes to a high dependency unit.
Actually, there is a separate unit, but not having very much specialist.
So it's a normal
just as normal word in a separate.
So we do the same. We do the same. And then after that, and so the nurses there, are they only transplant nurses or anything?
Actually, they will take care of the this post-transplant cases,
Okay.
but they are also sometimes they are sitting
wards.
in the wards also.
Okay, so we do similar. And after that, so when the patient is discharged, how do the nurses get involved in their care?
Till discharge, as we advise, like urology residents also visit and urology consultants and plus nephrology both.
Do you do a ward round together?
Not together, but both give rounds.
So we do a ward round together every day. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. The kidney doctor or the kidney surgeon goes round every day together, 8:30.
Doctor মানে কি resident?
No, the consultant. Well, the residents are there too. So I think that's one of the things that really helps us. It doesn't happen everywhere, but it really helps us because you can take the surgical decisions and the medical decisions together, and also we learn from each other. Like if there's a swelling here, I also tend to learn, oh, this could be a seroma or it could be a hematoma, right? When to intervene, when not to intervene. I've kind of become aware of the surgical decisions by being with these surgeons for now a very long time, right? He has been there even longer.
Even the nurses know what they're going to say.
What is the usual microbacteria you get? Transplant UTI, pyelonephritis.
We get our normal ones like
People like
Escherichia coli. We do get sometimes pseudomonas. I've never seen parvovirus in the last 20 years.
Many
you
cases.
said
Last
many.
year saw two. This year I think is one.
Parvovirus was
Post-transplant.
कौन सा पहले?
Blood.
Santashila is not convinced.
Last year
এখন আমরা অনেক
দুজন ছিল।
সামো এখানে আমি দেখেছি আমরা একটা encephalitis syndrome patient we sent the CSF for a viral panel. You get a lot of parvovirus. Don't pay any attention to that. I don't know why.
Our patients too sometimes they will develop pancytopenia, sometimes anemia. Severe one.
Why should we be so common? I don't know, you tell me.
I think it's I'm not a transplant specialist. I'm a poor medicine person.
Yeah. But we in here actually we do see a lot of infections after transplant. Well, luckily,
Infections is the main thing. Patients die because of more infections.
no, I know we do get infection, our fair share of infection. Mostly they're surgery related and they're
Because E.
related
coli are
E. coli.
to
Yeah, they're usually
antibiotics.
resistant.
Or E. coli resistance.
No, we don't have. We do get occasionally E. coli resistant to it, but most of them are, and they get better with simple amoxicillin or augmentin.
We do not even think of those drugs again.
No, we do use them. And they work. We are very sparse in using our antibiotics.
That is why they're still sensitive.
We're very aware of that antibiotic resistance as a problem. So unless we establish an infection, or at least have a bug with the clinical infection, it's a huge problem. It's a humongous problem. If we run out of antibiotics, it will be a real problem. And I do understand that in India in particular, there's huge resistance. Yeah. No, I do understand that. I don't know what to do about it, but I do understand.
I have one Klebsiella pneumonia, pyelonephritis with septicemia, resistant to everything. From the cholesterol, starving to be with renal failure, undergoing dialysis. So now you want some electricity medical
Okay, let me ask you something. আপনি এবার বলুন তো এখন থেকে আপনাকে কি ওষুধ খেয়ে যেতে হবে? আপনি সব ওষুধ তো জানেন। এখান থেকে দেখান কোন ওষুধগুলো খেয়ে যেতে হবে এবং কেন? Let's see what he's understanding. your responsibility. You have choice, right?
everyone.
এটা কিসের জন্য? কেন খেতে হবে? কতদিন খেতে হবে?
ওটা এখনো পর্যন্ত বলা চলবে, কিন্তু কতদিন থেকে এটা বলা হয়।
You haven't told them? Alright, okay. And then, how does this work? Okay, very good.
এটা হচ্ছে লাইভ মানে তখন কম আর বেশি।
Very good. Excellent. Well done. How does this work?
এটা আপাতত বন্ধ,
এটা কি পরে খেতে হবে না?
ওটা ডাক্তার যদি অনুমতি দেয়,
অনুমতি দেয়,
report দেখে তাহলে খেতে হবে, না হলে বন্ধ করবে।
Very good.
ওটা হচ্ছে
How does this work? You need to know how it works. You look it up. R. So you've stopped the steroids, everything.
prednisolone খাচ্ছেন?
Baggy আর কোনো ওষুধ আছে? Sorry.
Steroid, I think he's admitted here, so it's given from here. Sisters,
না এইটা তো এইটা
he has bought this medicine, but other medicines I think given from the sisters. They,
Oh,
so
okay.
he doesn't
So he
have
doesn't
the
know, alright.
packets. He has bought here for this medicine.
কিছু কিছু ওষুধ আপনাকে সারা জীবন খেয়ে যেতে হবে হ্যাঁ ওইটা হ্যাঁ Do you stop them? He's not showing this as a lifelong medication. Do you normally stop
Actually,
this?
it was stopped. It was changed to everolimus. So afterwards,
So you're going to decide which one to continue.
so actually maybe given after the paroparasis,
You will restart this.
maybe restart it.
Okay, fine. So he needs to know that.
এটা হচ্ছে একটা হাফ
September is
What is it?
because of the light. This is
So this is isosorbide. It's not septic. This is a
Yes,
blood
thank you.
pressure. It's a blood pressure tablet. Blood pressure আগে সবার কি ছিল?
আজকে ছিল 110/70।
That's very good. Cool. So he's taking this one.
একের হাফ।
It's a combination of isosorbide and hydrolazine. Is that what you said?
Isolazine.
That's a blood pressure tablet. So he's taking that.
এটা ভর্তি হওয়ার 5 দিন পরে চালু হলো, যতক্ষণ না অনুমতি না দেবে ততক্ষণ বন্ধ হবে।
This is
more.
This is calcium channel.
Increase the T0 level.
ওটা কি খেতে হবে?
এটা খেয়ে দেবে যতক্ষণ দেখা কি মানে ডাক্তারবাবু না বলে বন্ধ, ততক্ষণ বন্ধ হবে।
কিন্তু এই ওষুধগুলোর কারণ
না আর একটা ভলগান আছে দুপুরে একটা হাফ।
কি বলে?
ভলগান
Volgan.
একের হাফ
So that might be Valgan
Valgan
cycle.
cycle.
একের হাফ
Okay, that's good. The only thing which is missing is protramadosol. Given from the hospital.
Valventa আধা না একটা?
এখন বর্তমানে হাফ খাইলো তো লেখা আছে।
And what about the omeprazole?
Maybe on some calcium channel blockers as well.
প্রথমে একটা চলছে
No, there is one here, Diltiazem.
So,
He's buying that
will
as
be
well.
given from the hospital, so he will not be having it.
যখন বাড়িতে যাবেন না ওষুধগুলো লিখে নিয়ে যান অবশ্যই আপনার খুবই মনে থাকে
না না লিখে দেয়, ও লিখে একদম ট্র্যাক করে দেবে, আমি লিখতে হবে না। এটা আবার বুঝিয়ে দেয় জায়গা থেকে টাইম হবে।
So let me ask you something. So he has had a living donor transplantation from his mother. So what is the likelihood that his living donor transplant will be working in 10 or 20 years time or 30 years time? If you don't know, just guess. No, guess. Oh, do you know? Well, she said something about T half in a half the kidneys, how long they last? Do you know the T half of a living donor transplant is? Did you guess? Do you think half the kidney lasts for 1 year? Half the kidney lasts for 5 years? Half the kidney lasts for 25 years? Half the kidney lasts for 50 years? So I've given you 4 choices. I don't know do last. I mean, what would you
What
say?
we normally say is, this is what this is like, for the living donor kidneys, they last about an average 21 to 24 years. Plus or
21 to
minus.
24 years.
And if it's a deceased donor transplant, it's about 11 to 14 years. So I just deduct it like that.
So the percentage would be periods for the disease and
So what is your date?
our data will be, I think, less than that.
Why? This is a very precious thing. A living donor transplant is precious. It should last for 21 to 24 years, 50%.
In our
Why?
hospital, we have celebrated our longest recipient who received a kidney from mother. This is the 55 or 56th year anniversary. Yes.
56th year.
From
Yes,
the
from the
we
transplant.
also have from 1990s. We used to have
So
some
30 years.
30 years. We have, but not
Not
every
very
year.
many.
But many patients get infections quite commonly here. And also, this we actually in our hospital we only have the CDC and this HLA typing. We don't have the other cross matchings also. So patients are generally not that affordable. Some patients do from their own, but not
So you
every
think it's all
patient-
because of the crossword?
Not also. Actually, infection is.
Yeah. So the question is, how can you reduce infections? If that's the most problematic. Proper hygiene at home. Yeah, very good. Anything else? That's very, very important. আমি বাড়িতে সব সময় পরিষ্কার থাকি।
আমার বাড়ির পুরো ঘেরা
Next. Maskটা পরে।
মাস্ক
ওষুধগুলো সব সময় খাবেন। এই ওষুধগুলোই আপনাকে টিকিটাকে ঠিক রাখবে। যেগুলো বলছি না সারা জীবন খেয়ে যেতে হবে ওগুলো বন্ধ করবে। কারণ নাইলে কিডনিটা রিজেক্ট হয়ে যাবে। Next. Now, how do you reduce infection? Compliance to what? You mean the anti-infection medication, like Valtrex, yeah, okay. But that won't be forever. When do you stop them?
We generally stop Ceftriaxone after 1 year and Velcan after 6 months.
We stop after 90 days organ and Zeppelin. So it's not 2 months.
We follow the 200
Do
days.
you have expensive Valtrex?
Yeah, it's pretty expensive.
তোর ভ্যালার কত দিন?
3 months.
90 দিন।
3 months. এখানে 6 months.
Actually, intermediate flexi maximum power type. Intermediate is generally we give for 6 months only.
Right, okay. Yeah.
ভ্যালার available না আমার hospital supply
Hospital sometimes it's available, sometimes কিছু আমরা কিনতেও হয়।
How it costs the healthcare system. Good. আপনার কিছু প্রশ্ন আছে আমাদেরকে বা ওকে ওরাই তো আপনার দেখাশোনা করে। প্রশ্ন আছে ওদের কাছে?
না প্রশ্ন আমার কোনো অসুবিধা হলে সঙ্গে সঙ্গে মানে যাই ম্যাডামের কাছে অথবা ডাক্তারের কাছে ওরা সঙ্গে সঙ্গে প্রশ্ন হচ্ছে যে কোনো টাইম 24 ঘন্টা এনে যাওয়া পরিষেবা।
24. Very good. Did you have any questions for me?
তোরা ওকে ইনফেকশন কমানোর জন্য কি এক্সট্রা কি করিস? রিডিউস ইনফেকশন বাড়িতে
What are the most important things we try and do is rationalizing expression. We do not, so for example, I was telling yesterday, we never give it a G. It's a very potent infectious agent, right? It can cause cytokine storm, etc. So we all follow a very standard protocol. We don't change our protocol according to the patient. We just keep the same. You know, one of our surgeons used to say, keep the protocol boring. Don't make it exciting, so that everybody gets bored of it. If everybody gets bored of it, it means everybody knows
So
about
for
it.
digital also you don't need
We just keep the same thing for everybody.
for digital what do you follow?
So for
Giving the same
Basically,
yes, so SLC method bread in operation. Then 4 days after the transplant, we give the second SLC. And then the patients are stratified whether they're low immunological risk or high immunological risk.
And then, if it is low immunological risk, which a lot of our patients are, we
stop the prednisolone after 7 days. So day 8, no prednisolone.
prednisolone, then steroids, 20, stop.
7 years.
And you got 2 doses of basiliximab, you got tacrolimus. We maintain the level slightly high, kind of up to 12, but then you drop the level to 5 to 8. Just maintain that. So we get very little infection. We get
এখানে
less
আমাদের ড্রাগ
CMP.
লেভেল গুলো হয়
ব্লাড লেভেল এখানে হয় না বাট বাইরে থেকে আমরা T0 লেভেল করানো হয়
And there was a while where we were actually doing a biopsy at 3 months and switching them from MMF to azathioprine to keep our cost low. Because azathioprine is very cheap. You can buy it like
চেঞ্জ টু এজাম every basis গুলো
yeah, you do. See that also helps. So I think the message is keep the immunosuppression very boring. Orbit, are you listening to me? Orbit, are you listening to me? I'm teaching them something which you never tell them. Keep the immunosuppression very boring. Do not change it. Keep it minimal so that everybody knows and everybody follows the same.
I probably teach them the same. I don't know whether they get my voice rightly or not.
But they were very good. She's only first year. But she's third year.
I know her well because when I was leaving, she was almost there, no? Yeah, you was there for 1 month. Yeah. So I have, and she regularly presents with me in that online class.
Right. So she presented very well, and she did her best. She very nice. And he is extremely good. He remembers his day-to-day creatinine.
Oh,
and the
that is
hemoglobin.
that is an incredible thing, Debashish. They might be illiterate. They may not be able to write their name even. They will
They know
come
their
with
background,
memory about creatinine is 100%. That day it was 1.58, madam. It's similar enough. 1.5. No, it was 0.55 and now it is 0.5. This much is the accuracy.
I mean, this is so good. I mean, you've got a human computer there who's giving you the levels right there.
If you ask 13 into 7, they can't answer. But they could, the double digit they remember.
No. Seriously, the way he tells us about his hemoglobin, I was so impressed. I was very impressed. Acha, hum
No,
jaye.
it to bhaloই sir.
Who's going to take him back to the ward? Are you going to? No. So, okay, can you
he'll inform me like what
Going for the ward. So they can go home. I mean, go to their ward.
আমাদের দেশে ইনফেকশন
No, infection বলতে transplant
আমি ট্রান্সপ্লান্ট নিই
acute medicine.
অ্যাকিউট মেডিসিন আমার এইচআইভি আছে
এরা কি acute medicine আছে না?
না, নিশ্চয়ই।
তখন কি দেখি?
কারণ ব্যাপারটা না খুব কমই আছে ট্রান্সপ্লান্টে ইউজুয়ালি ওরা নিয়ে আদারওয়াইজ এভরিথিং কামস ইন মেডিসিন কারণ আফটার 1 o'clock only emergency
কি অ্যাপোলোটা আমরা সবাই মিলে নেব দেবাশিস?
একটা
অ্যাপোলোর কেসটা বেচারি অ্যাপোলোর লোকটাকে এতগুলো বাচ্চাটা কই? অ্যাপোলোর বাচ্চাটাকে এতগুলো এক্সামিনার দেখে কি
কালকে জানতে বলছিলাম না যে টকিং অ্যাবাউট হেপাটো রেনাল সিন্ড্রোম they do not get admitted as a hepatologist they do not get admitted as a nephrologist
And in weak child,
Okay, cardiometabolic renal syndrome. They do not get admitted in cardiology. Cardio-renal AKI. They will not get admitted in ICU.
But they shouldn't.
They get not get ITU. They get admitted in the ward under medicine.
Exactly.
Cardio-renal AKI.
And also they need, what I believe for the cardiorenal medicine patients is that they have so many of them that they need to be managed by with the competence that is necessary.
আমাদের দেশে ওদের যেমন যে ইন্টিগ্রেটেড অ্যাপ্রোচ একসঙ্গে এতগুলো স্পেশালিটিস দেখবে ইট ইজ নট দেয়ার সো ইট হ্যাজ টু বি সামওয়ান হু হ্যাজ
Knowledge of it.
knowledge of everything somewhat knowledge of
But
everything.
that's the best thing. Then you don't need 3 doctors for one patient. You just need one
If you
doctor.
send the patient to 3 doctors, the patient will not get any treatment. তার কারণ একটা মেজর প্রবলেম কি হয় জানিস? হ্যাঁ, কার্ডিওলজি প্রেসক্রিপশন এন্ডোক্রাইনোলজি দেখবে না, সে তার নিজের মতো লিখবে। আলটিমেট যে প্রেসক্রিপশনটা যে কি হবে nobody knows. ওর কান থেকে কিছু ওষুধ খাবে, এর কান থেকে কিছু ওষুধ খাবে। তাই না? আমি একটা অ্যান্টিহাইপারটেনসিভ ড্রাগ দিয়ে নেফ্রোলজিতে পাঠালাম, সেটা মানে আননেসেসারিলি হয়তো চেঞ্জ হয়ে যাবে, সে কনফিউজ যে আমার প্রেসক্রিপশনটা ফলো করবে না, এটা ফলো করবে। আমি ওই জন্য বলি আমার ওষুধ খাবে না, চলে যাবো, একটা জায়গা থেকে ওষুধ খাবে, খুব মুশকিল। আর এখানে ওই হয় না, একসঙ্গে দেখে শুনতে পারি একসঙ্গে রাউন্ড হয় না, তো একসঙ্গে সবাই মিলে স্পেশালিটি ক্লিনিকে বসে পেশেন্টগুলোকে দেখবে, সেখানেই ফলো আপ। So the only way is that someone must have some knowledge, at least some knowledge about all the things. আরেকটা মেজর প্রবলেম হচ্ছে cardiologist, they are interested in intervention. They are not interested in clinical medicine. Heart failure চিকিৎসা করতে তারা উৎসাহী নয়। প্রাইভেটে আলাদা, সে প্রাইভেটে ভর্তি হলে পয়সা দেয়, এখানে না। All heart failure patients,
কোনো heart failure cardiologist নেই।
no, cardiologist, no heart failure cardiologist. সবাই ইন্টারভেনশন
সবাই।
ঠিক আছে, মাইন্ড ইট, মানে ঠিক আছে, হার্ট ফেলিওর there is no reason যে ইন্টারনাল মেডিসিনের পেশেন্ট ডাক্তার হার্ট ফেলিওর ট্রিট করতে পারবে না, ইটস নট লাইক। অনেক সময় সাপোর্ট দরকার হয়, সেগুলো মানে ট্যাকো দিয়ে
It is so if a patient comes in for infected heart failure, so let's say how would you treat that? So what would you start off with? She's first year. First year of post-graduation. Not first year of undergraduate. So how would you treat it? So let's say somebody has referred to me IPGMER Kolkata, has hypertensive heart disease, very thick heart, and then goes into failure with ejection fraction of 25%, and is admitted to hospital with fluid, with Dr. Mike. You are going to present to him with all the medications that you started short of that, clear bivagal crackers, JPL limited, and this one. CKD stage 4. Huh? Diary. What diary do you use? Cha or coffee?
চাকরি চা তো রে, চা ছবি রাখছিস, ফুল ডায়াগনোসিস। এটা হচ্ছে মেশিনের চা, তাই না? এটা মেশিন চা তো, এটা মেশিন চা, এই জন্য
মেশিন চা নয়, মেশিন কফি।
চা বললো তো,
ও বললেও তুমি দেখো না একটু।
চায়ের মধ্যে কফি, চায়ের মধ্যে একটু কফি গুঁড়ো দিয়ে দেয়, চা ফ্রি।
Okay, let's not talk about that. Whatever it is we're drinking, it's nice.
হ্যাঁ দিয়ে দেয়।
What diuretic would you give?
Loop diuretic. So let's name a loop diuretic and what dose will you give? Torsemide, furosemide. Do you use a lot of torsemide?
Torsemide in the OPD, but in the
Torsemide আমরা use a lot of torsemide
we
oral.
use in the
Really?
yeah.
Is
we
it the
use-
same price as furosemide? Because in UK torsemide costs much
আমাদের
more, so I
এখানে
never use it.
আমাদের এখানে তো আমরা যেগুলো
Supply
হসপিটাল
was-
সাপ্লাই আছে না সেগুলো আমরা পুরোটা প্রাইস দিই
So we need a hospital supply.
It's a hospital.
Okay, fine. Yes.
But
But there is no IV.
Actually,
now
torsemide
IV is only furosemide.
IV is only furosemide. So how would you
Acute
give
stage
the
is only
furosemide?
furosemide.
What will- how much would you give? In a patient in CKD stage 4 who's already on 40 milligram furosemide as an outpatient.
BP is not a problem. We can give 88 plus.
80 milligrams. That's a good dose. 80 milligrams intravenous. And then
Then
how do you monitor that it's working or not?
Weight loss is out of question.
Weight loss is out of question, okay? But
You
nobody's
cannot-
measuring
you
it.
cannot measure the
You
weight.
can't measure the weight. So anything else you can measure? Urine out.
That is the only thing you can do.
albumin is okay, then we not.
Yeah, albumin is alright. Let's say albumin. So you look at the urine output. And you know one of the interesting things that we
The
have
first
done-
drug is always one drug, that is oxygen. That
Yes,
is the
don't
drug.
forget.
It is not regarded as a drug. That is the first drug in all hypoxia patients. Oxygen, oxygen, and oxygen.
It's not our fault because I didn't say that she was hypoxic. But let's say he was hypoxic.
Acute LVA patient will be expected to be dyspneic.
Expected to be hypoxic. Okay.
Acute dyspneic.
So you monitor the urine output. The urine output is low, but you know it's low. So recently we have had quite a few diuretic studies in the last, I would say 4 or 5 years, or maybe a bit longer. And in acute decompensable heart failure patients. And what the diuretic studies have shown is that you do need to monitor and you escalate the dose in the first few hours of admission, not days of admission, because that helps with early discharge. And there has been a few studies. For example, there is the study which was published in the magazine by Jose Josie Martintel, and she clearly showed that monitoring that and monitoring urine output, making sure it's more than 100 to 150 ml per hour, and also monitoring the urine sodium, making sure it's more than 17 ml per liter, you can actually make a difference with sending them home early. You can send people home early, provided you monitor the urine output. That's a good thing, right? Because you don't want to keep people in hospital. In St. George's Hospital, anybody who gets admitted with acute heart failure, they are in hospital for, recently I learned, 16 days, which made me feel really sad. Because when we looked at our 319 patients over a median follow-up of 439 days, there were 667 admissions. 667. 439 days, 369. Huge hospital admission. They are sick. You know, their mean age is about 79, more than 60%.
Multiple comorbidities.
They are frail, their frailty score is high, they have hypertension, hyperglycemia, heart disease, and they have chronic kidney disease. But still, I think it's not very well. So we don't do very well. We actually don't do very well with treating heart disease. So that's one thing that you should do. What else would you start on day 1, day 2, day 3 for their heart failure?
But you haven't managed the acute heart failure yet.
You haven't finished managing the acute heart failure.
Because the patient is not having adequate urine output.
Yeah, then what do you do?
So the furosemide is not going to work in this group of population.
We may escalate the dose of it.
Yes.
If it's working, it's working then we see, and we give infusion also.
Yes, you can give infusion. That's quite common nowadays. I think Shanta should also have used it. Do you use the 24-hour infusion pump?
Infusions, but initially we always give bolus. Sometimes we will give the infusion, but studies have not shown a much difference.
There is no difference between, actually randomized control trials, there is no difference between bolus versus but there is a very small randomized control trial from Spain which has shown that infusions do But that's okay. I would ignore that study.
If
Just
holding over is too much and patient is not correct, then you have to give a scarf also. I see.
no, before that, any other diuretic would you use? So you said it's loop diuretic. Any other diuretic that you can think of? Metolazone. So where does metolazone work? It's not in the loop, right? Just after the loop. Yeah, and then sodium chloride to
In order to look at the blood pressure,
blood pressure.
very common is that the patient has a very high blood pressure. They stop taking their antihypertensive medications. Maybe that is the cause of that.
Exactly. And that probably happened to him as well. When he came in, his blood pressure was 160, 170, 190, up to 200. So you need to control the blood pressure very well. You know what is very interesting is that when we see blood pressure is such a thing, if you control it well, even if the patient presents quite late stage, kidney failure, heart failure, etc., if you control it well, they get a good time of good health before they require something else. Because blood pressure is a dangerous thing. It's quite satisfying when you can treat it.
We are talking about SGLT inhibitors, we are talking about GLP-1 analogs, but most important thing is still control the blood
I
pressure.
believe that. So in his case, what did he
And that
say?
is probably the most difficult thing.
The first thing to do is?
Blood pressure control.
Second thing to do is? Third thing to do is?
Very difficult. It's not very easy.
He required 6 medications for blood pressure. He was on a calcium channel blocker, a beta blocker, an ACE inhibitor,
We may all want to have
an alpha blocker, and central inhibitor. There's something else. There's 6 medicines. Processing, tell me something.
Amlodipine, amlodipine.
He was
Amlodipine.
Amlodipine.
Stamlo. He was on Stamlo. What is diuretic? Torsemide. And?
Oh, and there's Ocean is very
Metal.
I think for 10-15 minutes we always want to. Isn't it?
So it is difficult sometimes.
Yeah.
You need to make sure that it's
10-15 minutes we have
You
always
do some
gone to
urinary
PD
levels.
and came up and joined the
or
rounds and all.
admit them. Give them all the medicines.
Or
See
came
what.
up and joined us.
That's one way of ensuring compliance. Somebody gives it to them.
So do we have the round-the-clock dialysis facility? We have the patients. Severe
Yeah.
patients. Maybe already on
And
dialysis.
we were together very at IKEA clinic.
I have seen that.
And that day there were no, that day you had little more, I think 7 or 8 patients, and you were very
But
anxious
what
that
we're talking about,
we
the
have to
out of
see
the
8 patients today.
it's fallen out of favor. Unless it's
We together were going to IKEA clinic.
Because most
They
of the
have
randomized
IKEA.
clinical trials that have,
So they follow the IKEA
we
recovery.
tried with the small machine,
So,
we put the
when we were
it's a
going,
fluid of
then we
that didn't work very well. So
today
we realized that it
patients
costs a lot of money,
today.
it doesn't help us that much.
nothing.
So hence we try everything possible.
We had a lot of time.
Yes, we do occasionally take a patient.
Yeah.
Very, very.
And we were trying to I was
But
trying
don't
to
forget,
probe deep
you're
in
going to start the other GDT as
addictions.
well.
Yeah.
Guideline-based
Yeah.
medical therapy, right? And what are they?
Yes.
For heart failure? Very good. Everybody should give a bit of love. 2.
Enough to explain.
ACE inhibitor, very good. Or angiotensin receptor blocker. Or more and more we are using angiotensin receptor and neprilysin inhibitor. Next.
CKD patient
He
on
was telling
dialysis.
that he was
So
having
use
after
inhibitor
every fasting.
with low ejection
Yes.
fraction.
We do.
Yes.
We
And
do.
how did you derive
We do.
for genetic?
So you might say, do we have any very good evidence?
You have
We use ACE inhibitors in every right? In our clinic.
Creatinine was one side and it was
potassium is the main
recovering.
problem.
Potassium,
Yeah.
I know
Like
it's a
spontaneous
problem, but
recovery.
you can overcome that by giving some sodium bicarbonate, giving some
Yes.
fructose,
Yes.
whatever you can.
It
We
was
do have
1.3,
look at it.
1.4
Right.
when
And very much
we
happy
can
we
because
are
you see,
talking about
with our
milligram.
patients,
In
follow
my
up with
head,
the big
that's more.
to prescribe them and they don't turn up, they don't give the serum potassium, and suddenly they turn up with potassium hyperkalemia. That is a big problem.
And he was relating it to fasting.
real
That's
upset.
really
Yeah.
Isn't it? That must be a discussion.
With high BP
Yeah,
prefer
because that case
isolate.
haunted me quite a lot. And why a fasting?
That's isotopic
It's like Gilbert.
He
There's nothing like Gilbert in.
No, we do. I know
This is where unbiased
I know if you don't have it. Or what can you do? So, but at the same time,
But you opted for the
patient is compliant enough to come after 2 weeks.
undiagnosed CKD, young age CKD.
So what are the
That
other two? You
indication
just
of
said
biopsy.
beta blocker and ACE.
Sorry, but genetic testing.
Yeah, no, got the receptor antagonist.
No.
Next.
Hello.
ACE
Next.
with
The last one.
spironolactone is again a dangerous combination.
In heart failure. Sacramental valve yes, that's a good thought. Yeah, it reduces at least cardiac endpoint by 17% compared to
Dialysis
another
চলাকালীন চিলসেন রাইডার হচ্ছে ওনার একটা পাম্প ক্যাট আছে পাম্প ক্যাটে সিআরবিএস এর
Don't forget, you can give SGLT2 inhibitor in all patients. And now we have got 10 different types of
ও একটা
SGLT2
পাম্প ক্যাট থেকে
inhibitor.
কালচার পাঠানো হয়েছে
We have only one.
And now, it's gone out of patent. So AstraZeneca doesn't hold patent for dapagliflozin anymore.
We use
You
the
can say
person.
DAPA, there
তাহলে
are
দিওই না
online, but if also sometimes
Yeah.
We have
So
a
now you
separate
should
DAPA.
use DAPA for everybody.
This is in DAPA for everything.
DAPA is
10 milligram.
তো প্যারাসিটামল নাও বা কোভেরাল
Without
নাও
thinking much
it is
about it.
it is
Because
cytokine related issue.
you can give it in heart failure, you can give it in CKD, you can give it, the recommendations are up to a GFR, but you can give it in it.
প্যারাসিটামল দাও
Because they say you can continue to dialysis.
হ্যাঁ তারপর প্যারাসিটামল দিলে 5 মিনিটের টেম্পারেচার
according to standard.
So according to the study, so NICE guidance says for us, so GPs will never start
তো
dapagliflozin.
কোল্ড স্পঞ্জ করতে বলো
I would
আর
start because
স্মল
we have
অ্যাগ্রাম
multiple
দিয়ে দিয়েছো তো
decisions.
না প্যারাসিটামল
Discussion decisions there which the GPs have to follow.
ওয়ান্ডার
So we can
তাহলে আর কিছু
so we can
ওষুধ
start
দেবে না,
as GLP
cold
in
sponge
our
করো।
time.
জ্বর এসেছে জ্বর যেতে সময় লাগে
Or cardiorenal metabolic therapy, which we do on Thursday and Friday.
হ্যাঁ জ্বরের মধ্যে ব্লাড চেক করো
All patients.
We can start anything in anybody, literally.
What about fibrinogen?
Fibrinogen, so the NICE guidance is that the patient has to have a GFR more than 25, diabetic kidney disease, and proteinuria. Now we use it in No, that maybe I won't use because of the cost. It's like 28 pounds per month. So lifelong therapy would be expensive. Similar, very similar for us. So I try and use it less.
GLP-1 analogs are used.
So we do a cardio kidney metabolic clinic every Friday afternoon. So we have to use it. But what we do is we first do some dietary advice, some liver shrinking diet, some alternate day diet, some fasting diet, some
Only in
diet.
obese patients we use that.
So the nice guidance is
Non-obese diabetics you are not using with cardiac and renal issues.
you can. So the nice guidance is you can use GLP-1, GIP-1 agonist in anybody who has poorly controlled diabetes. Full stop. Then you have the guidance, you can use a GLP-1 agonist for the following conditions. The patient should have a BMI of more than 40 and 4 other comorbidities. If you have a severe restriction on using GLP-1 agonist,
But you can use that GLP-1 and GLP
only for diabetic.
only for diabetes.
Then the GP will prescribe. But if you're not diabetic, then you need BMI more than 40 because we can't afford it. Everybody has to be here. So only BMI above 40 and they have to have 4 comorbidities. But in the MDT clinic, we will do it.
Tell me, patients having that cardio metabolic syndrome, on an average, how many pills they should take?
So a lot of my patients take about 18 pills a day.
You are compliant?
So compliance is poor.
So it depends on how,
So you keep increasing the number of
No, now the other thing is, this is interesting actually. So the week before last on a Friday, I went to private care. So there was a heart doctor, a kidney doctor, a diabetes doctor, and we had two visitors, one from Australia and one from China. So there were six doctors, and we went through 17 patients. And we ended up stopping more medicines than starting more medicines. So we stopped all the medicines which does not prolong life. So all the actually vitamin D's, the medication which we felt patient doesn't need. Also, we took decision about patients not to be admitted in hospital and not to dialysis. So I think that there is a role of doing this, which is de-prescribing medicines, particularly in the elderly and the frail. Simplifying medication. Use combinations if possible. We don't have very many combinations.
We had two students left out. Yeah. Two students left out. Yeah. এখানে কেস পাবে না তাহলে তো তোমাকে আরেকটু আগে এসে কেসটা নিতে হবে কেস ঠিক আছে তাহলে ওই কথাটা শুনে যাও ওটা করিয়ে দেবাশিস finished or not? Yeah. Now the Apollo girl will present case.
Nice. Very sure.
Come.
She obviously doesn't have.
You have come with your presentation in PPT mode. Patients. Yeah. So PPT ta chaliye dite hobe.
Good morning, respected teachers. Myself, Dr. Sharni. I'm going to share a case which was actually a mismatch mayhem. So, so my patient, she was a 38 years female of the blood group A who developed end-stage renal disease as a result of autosomal dominant polycystic kidney disease, and then she was worked up and planned for a life-related renal transplant, the donor being the mother who was a blood group B, so they were incompatible transplant, and pre-transplant she underwent bilateral nephrectomy in the month of April. The baseline to accommodate new kidney space big kidney, so for the space match she underwent bilateral nephrectomy.
But why did you do bilateral? Why couldn't you do unilateral? Because you need space on one side, not the other side, right?
Any other indication? Why do you need to do a bilateral?
Uncontrolled hypertension.
Alright.
Anything?
Cyst infection.
Stone malignancy.
The reason I'm saying that, the bilateral nephrectomy comes with its problems. It remains, the patient remain in hospital for a very long time, they get malnourished, and I think unilateral nephrectomy is much safer than a bilateral nephrectomy operation. Myself, I don't know whether you guys agree or not.
And some amount of residual renal function in between the period that your surgery is over and your transplant is done. It's always helpful. In dialysis patients, even a residual renal function of 400-500 ml can help them not hitting the hospital in many occasions. Okay.
Was there any blood transfusion during this?
No history of blood transfusion.
During nephrectomy?
No history of blood transfusion. The baseline anti-B IgG titer was 1:64.
Sharmi,
Sir.
she's 38. Does she have children?
No, sir. She was married but was not living with her husband.
So did you do the IgM type?
IgG?
We do only IgG titer because IgM is restricted to the vascular space, so very amenable to removal, faster removal. So we do not check IgM, and it also does not correlate with the graft survival. So we only check IgG.
Okay. Suppose IgM is there, anti-ABO antibody, will it cause a graft dysfunction and rejection or not?
IgM is not correlated with graft dysfunction,
Yes,
only
it
IgG.
does. It is easy to remove, and so there is no need to monitor. But initial phase, you should do IgM, IgG both.
Next slide.
And this ABPKP was inheritance.
Inherited. She had a family history starting from
Paternal
her
inheritance.
paternal inheritance. Grandfather, father, herself, and her brother all had ADPPD. So, as a desensitization worker, for 2 weeks prior to the surgery, she was given injection rituximab 200 mg, and 10 days prior to surgery, she was started on tacrolimus 4 mg per day and mycophenolate mofetil 1000 mg per day. This was the initial blood workup, which was within the normal range, and pre-transplant tacrolimus level was also within the range 7.49.
So how many days before the transplant do you normally start the tacrolimus?
10
Because
days. We started 10 days.
10 days.
10 days before surgery. 7 to 10 days before we can start seeing tacrolimus surgery.
Yeah.
Most of the protocol says 2 weeks.
And did you actually explore possibility of somebody else donating the kidney who was not maybe incompatible?
Actually, mother was willing to donate, so
nobody else came forward
Nobody
with the
else.
same blood group, and there was no possibility to do a swap, Peter.
That is the thing we are going to launch now. It has not been yet. Small swap chains in Pratik's institute. Pratik and Dr. Rai has done, I think. But that is a manual short swap chain. Means two pairs. But it's not in West Bengal. Still the registry based, and that
It
will,
doesn't have.
yeah.
So
That will
only in
happen.
Pratik's hospital it happens.
Huh?
Only in Pratik's hospital.
No,
No,
always one
it's-
way. This is only one pair versus one pair.
One pair versus one pair. On counseling and manual exchange. Manual,
But here it is difficult because it is a patient who was O positive.
B positive.
B positive.
Patient was A positive, the mother was B positive, donor was B positive.
but this is the commonest situation we offered ABO incompatible, which can easily be changed to swap, compatible swap, because there are many who are A to B willing and there are many who are B to A willing. So this is the commonest situation when you can offer swap. And another problem of not having swap or convincing this is donor donation with very good outcome is we miss the cross-match pre-transplant immunological workup. We are lacking the HLA, high resolution HLA we are not doing, and we are not for every 3 monthly we are not enlisting the DSAs that, and we are not counting on PRA. So that way giving them a very comfortable match with the HLA matchmaker or something other is not easy. So convincing that your DD outcome will be as good as it is very close to living donor. No? But that happens because the matching becomes, virtual cross match becomes so perfect before, even if some family people would have donated, even better cross match is available through HLA matchmaker. That is not happening here. That's not happening.
But one important message is that if you have, as he was telling, you have a ABO compatible transplant is possible. That is always a preferable one compared to an ABO incompatible.
Because why? Why you prefer a swap or ABO compatible?
Because compatible has better survival, less risk of infection.
No. Induction, no, from where the thing originates, yes, you are right. I am going back to the origin again, that your immunosuppression load is much lower. That is why patient survival becomes better.
Infection less.
So always when we consider outcome, then we consider two things here, patient survival and graft survival. So about more HLA matched long-term survival is better. We are good at giving good short-term even against HLA mismatch. But if we want to give real long-term, we have to have HLA match. More HLA match, more good long-term outcome. That we are concentrating now. So that
difference between compatible and ABO incompatible, they are different for last 180 days in terms of rejection, in terms of infection. But beyond 180 days, it is equal or maybe slightly better compared to the compatible or diseased donor because of they have received the desensitization and so first 80 days are crucial and they are different, they are more risky.
She was still on your first slide, sorry.
So after this 2 weeks prior to desensitization, she was given 2 sessions of immunoadsorption with glycoside anti-B column, which was reused one time, and the pre-transplant anti-IgG titer came down to 1:4. This was the whole IgG and IgM workup, which was done till pre-transplant, and the pre-transplant IgG titer was 1:4.
You know, you showed your class level was 7.9. What level do you maintain around this time?
Pre-transplant, I'm not sure. Post-transplant, I'll see.
So what do you maintain post?
0 to 3 months, we generally, if the immunosuppression is with MMF and steroids, around 10 to 15, 3 to 12 months, 8 to 12, and beyond 12 months, 5 to 10.
Okay, thank you.
So how frequently do this anti-titer, anti-B titer during using a glycoside?
After immunoadsorption, 6 to 12 hours post immunoadsorption, we can check for the titer to check for any rebound.
Because ideally it is a single use one. You can use it up to 24 hours. So ideally you should do in every 6 hours time, and whenever it is your acceptable range, you take the patient to the OT. Okay. It's not that you are doing whole thing, doing that, and again repeating the column by washing. This is not ideal. You should do every 6 hours time.
Every 6 hours. So before transplant, she was induced with injection basiliximab 20 mg, 2 doses, and on 29th of May, she underwent a life-related ABO incompatible from B to A renal allograft transplantation. Although she had an uneventful intraoperative period, the post-op period was quite eventful. 12 hours post-surgery, she developed oliguria. Graft Doppler was done, which revealed elevated RI and an almost absent diastolic flow in the intrarenal and the main renal artery, although there was no renal vein thrombosis or perinephric collection seen in the Doppler. Donor-specific antibody was sent, which later came back as negative. This was the Doppler shown.
What is your practice of giving induction for ABO incompatible? Do you consider it as a high risk or a low risk?
ABO incompatible is a high risk transplant.
So then what is the rationale for giving a basiliximab?
Since we already gave her rituximab, studies have shown that if we also give antithymocyte globulin, increased risk of infection. So we tried to avoid ATG and instead also related, so we also tried to give.
Proponents of basiliximab, they say that you may land up in over immunosuppression and infection. And the opponents tell that it is a high risk, so it should give ATG. And your doctor will interpret this doctor finding.
Doctor finding elevated RI and almost absent diastolic flow. So mainly
within 24 hours, no?
Within 12 hours now.
So what is your interpretation?
So a form of hyperacute rejection, ongoing hyperacute rejection.
You tell one by one. Revealed elevated RI. What is the RI and what does it mean?
More than 0.7 would be indicative of elevated RI. So
What does it mean?
Flow resistance. It would be flow resistance. So that would be.
What are the situations when it can happen?
Uretary kinking can be one possibility there.
Resistance means this is the parenchyma is at fault. Maybe an ATM, maybe a rejection, maybe a CNI toxicity also. Anything can give rise to
anything that can have given a parenchymal insult. Even an edema, if the graft is handled too much, if there is lot of graft edema, it can also give an impression of elevated RI and if the RI is elevated and edema compressing the vessels, if there is lot of edema inside the graft, then also it can give a similar picture, which resolves over time, and it's a very difficult, confusing point, because the probability that you are talking of, or that is in our mind, that it is a vascular compromise, will lead to immediate operative or intervention. So which maybe wait versus intervention.
If this is the same picture of the same patient,
Yes.
we have shown that the absence vascular flow is concordant with the raised RI. So if you see, why are you comfortable with that picture and why are you not comfortable with it?
Diastolic.
What about the systolic flow? Which one is systolic? Which one?
The lower part
Suppose
is-
you have mentioned almost absence of diastolic flow. If it would have been almost absence of systolic flow. So what is the difference?
More flow resistance is indicative of absence of diastolic flow.
So it is concordant and it suggests the parenchymal disease.
Parenchymal insult.
And there is systolic flow is good or is not mentioned here.
Systolic flow is good.
It's a good. So we are comfortable. At least there is a vascularity inside the vessel.
Present.
There is no surgical cause, artery has not thrombosed, something which is in the physician's hand. Okay, so you did not tell the surgeon to come and open and reconstruct. The much more devastating things. Okay.
The DSA also came back negative.
So why did you send an ABO titer then, rather than sending a DS?
ABO titer was also sent, sir. I mentioned in the video. ABO was 1:2 post-transplant.
Pre-transplant, immediate pre-transplant titer
1:4.
Titer go back on.
1:4. And on the day, even on the day of transplant, we again sent, it came as 1:2. Again, post-transplant, we have sent, sir, it came as 1:2.
So one thing is that IgM should have been removed in once where 32 to 4 and it should remain in 4. It should not increase again.
Should not increase.
Go back.
So this was she underwent a graft kidney biopsy the following day. The report of which was suggestive of thrombotic microangiopathy. The back score was G0, PTC1, C4D2. These are the slide pictures which we have recovered from the histopathology lab, showing features suggestive of multiple microvascular thrombosis, suggestive of TMA.
Show us where the thrombosis you can see.
So the
Yes.
Yes. You see any endotheliosis?
Where do you look for?
I mean, it's not a very high bar thing, so I can't see very well. You might not be able to see.
It is TMA. From this biopsy, can you tell is a TAC TMA or a de novo TMA or a recurrent TMA or ABMR associated TMA?
with IPGMER, sir, other microvascular inflammation should have been present, but here only microvascular thrombosis, TMA is present, so probably it is not ABMR related, probably
But you are
could be
showing this C4D is
C4D.
positive.
C4D in ABO incompatible can be due to accommodation also, sir.
Accommodation doesn't happen within 24 hours. How much time it takes?
Generally 2 to 4 weeks, but can occur within 1 week.
So from C4D staining, can you give us impression whether it is APMR C4D staining versus accommodation C4D staining?
Generally, if it is accommodation, till C4D linear staining 2 can be due to accommodation.
In terms of distribution, it is mostly peditubular capillaries. Those are the strong staining compared to the less staining over the glomerulus, less staining the tubules. But in APO, wherever the antigen is expressed, there will be C4D staining. So it is diffuse, but not more than +2. It is quite prominent and it is not very patchy kind of thing. This suggests this can be an ABMR also. If this happens very early, what else this pathological thing you expect? It was a very early rejection.
Hyperventilation due to ABMR, due to TMA,
For that, what additional things you expect in the biopsy?
glomerulitis should have been present.
In the hyperactive rejection, what additional cells that you expect other than the lymphocytes in there?
Mononuclear infiltration, mononuclear cell
So
infiltration.
neutrophils.
And
Neutrophil
neutrophils.
comes into the play because it's a devastating process, immunological
Inflammation.
So it is TMA,
TMS.
not APM.
We were of the impression that it was not TMA. These are the lab findings. On the POD1, the lab findings were quite within the range, but from POD2, she had a significant anemia. The hemoglobin dropped from 8 to 5.7 with a drop in hematocrit level as well. She had significant thrombocytopenia. We had sent LDH, which also came as high. The anti-B titer was also followed up, which was initially 1.2 and later also not quite very high, 1:4, 1:16. She had to be transfused with packed red cells, and gradually the creatinine level rise, that is, she developed
How do you transfuse PRBC in ABO incompatible transfusion?
donor
Donor.
recipients that group matched.
If you blood coagulate plasma, then you can give a donor's plasma. This is a blood. This is a
Plasma is
recipient.
donor.
So it is better always to avoid such things because in hemolysis it can come out with, you can be out of this situation with other means also rather than blood transfusion. It is risky.
And the creatinine also showed a quite significant rise, that is, she developed delayed graft function, for which she had to be dialyzed as well. She had uremic symptoms, so we have to dialyze her. And clinically,
Just a minute, I missed the native kidney disease slide.
autosomal dominant polycystic.
Oh, sorry.
Autosomal dominant polycystic.
Sorry.
So another problem in the blood transfusion is that if you send the blood for the cross match, every time they will report there is a hemolysis and cross match is something because it is carrying all together is a donor's plasma in the patient's body. So this is a problem.
Clinically, when asked, she also complained of having frequent nightmares, and we also could see she having mild hand tremors. The tacrolimus level sent on 30th May, that is the day after transplant, came as 11.29, which was also within the range. Subsequently, as we thought that it could be a CNI-induced TMA, we had stopped the tacrolimus. She was given pulse IV methylprednisolone, and then she received 5 sessions of plasma exchange followed by IVIG post-flex.
So you have stopped the tacrolimus because the level was high and there were side effects like nightmares and hand tremors. So how the tacrolimus and TMA are correlated? Is it dose-related toxicity or idiosyncratic reaction?
Dose independent
It's a
toxicity.
idiosyncratic reaction. Reducing the dose is not enough. You have to stop the dose. And you received IV methylprednisolone. Why did you give IPIG for this patient? Because Plex was okay. You were planning to treat TMA and Plex is good. But why IPIG? You told there is no ABMR.
So, what else should you also send that before adding Plex to it?
DSA was sent on.
And also, I know other than DSA, you were thinking of her native kidney disease was ADPKD. We can no way relate it to any complement CTMA. So, at this age, her age is
38 years.
38 years. So, what may be the other possibility that she might have as a cause of TMA?
Since the basically ADPKD we did not work up for any complement disease, and that could be one. Recurrent TMA could be a possibility, but that was not shown.
One might be a TAC related TMA. One might be ABMR related TMA. You stopped TAC and ABMR related TMA. For that, you have told that the MVI portion was missing. So we are thinking that it might be TMA alone. Might be there might be 100 good reasons other than ABMR. So what else you would send? What blood test you would send to identify the possible cause of TMA before giving Plex?
Non-HLA antibodies.
does your ADPKD excludes a complement-mediated disorders? May not be the cause of the native kidney failure, but does it exclude the presence of any, because it is always the second hit, the genetic abnormality is there, and the second hit precipitates the.
It may be CTMA, it may be TTP as well. So, unless you send the ADAMTase 13 before, antibody to ADAMTase 13 before, it might be washed out by plaques. So, you might miss. Similar thing, it would be the Indian cohort shows a large number of antibody, anti-CFH antibody mediated, which might have a genetic also. Genetic deletion is also related. CFH-R1 deletion is also related.
Presence of ADPKD doesn't exclude.
So all these things you need to send because it has a lifetime very transplant.
With giving these plaques, what benefit are you expecting in these patients? Plaques, how does it beneficial for this patient?
It was we thought of tacrolimus-induced TMA and started treating accordingly. So first we stopped TAC, but we also started plaques to take into consideration that had it been an ABMR, ongoing ABMR
how does
also,
it help
it washes away the antibody and IVIG prevents further new antibody generation.
No, in any TMA, how plaques helps?
By removing the inducing
So it
antibody.
stabilizes what? The extrarenal factors. Your platelets get stabilized, your hemoglobin gets stabilized. So you get a patient for doing a say biopsy. Okay, but renal function will not improve with these plaques. But I didn't understand if you are not.
During plaques you can't do because on high heparin. During plaques you can't do biopsy. High heparin we use.
Yes.
Otherwise we can't do plaques. So after plaques,
Gap and then
yeah.
biopsy.
But rationale of giving IPIG is not clear until unless you are thinking in terms of severe ABMR and another important thing is so far our practice is concerned, we always give some amount of plaques in ABM comfortable transplantation pre-transplant because it is not about the antibody, ABM antibody, but it removes the complement. Complement is a big molecule. This is removed. So inflammatory milieu is low set. Whatever catastrophic event we got in ABM incompatible is with a low titer and no plaques. So it is always better to give one or is a hybrid kind of desensitization. You give glycosob and some plaques, remove the complement, inflammatory milieu, and the chance of rejection becomes less.
so the UK has stopped almost doing
We
ABY.
had stopped ABM comparable transplant in 2015.
They have moved on
Zero.
to swap.
Repeat since
Asian people, we don't reject much. But that's the Japanese result is so good.
Yes.
she did not show much improvement, so we had subjected her to a repeat graft biopsy, which was done on 5th of June, which revealed extensive cortical necrosis, and unfortunately, despite all efforts, she had to be done a graft nephrectomy.
So how many days this biopsy was?
So you haven't reached the cause of TMA.
We thought it was, we considered it to be a capital CNI-induced TMA.
CNI-induced TMAs are not such. We have always not such devastating. Sometimes it's only renal limited, and you don't find anything in the as you have found in the systemic. So I feel that there are other causes of it's not just TAC, not just TAC.
I feel a bit sad. I mean, was this a preemptive transplant? What was the GFR just before transplant?
Before she received,
Oh yeah, sorry.
So what is the thing you could have been done for this patient to save the graft?
For ADPKD, I prolong as long as possible.
A trial of eculizumab could
I
have
know,
been
yeah.
tried.
Because whenever you have diagnosed TNA
And this
pretty
is
early by biopsy,
complicated
and
course,
starting an
like
eculizumab
hemorrhage,
probably
cystic infection,
Could have-
would have saved the graft
because
for
economic
this
people
patient.
maintain 1 liter, 1.5 liter pill
You know,
before transfer.
sorry, is there anything else you could have done to save this kidney?
Yes,
Could have
exactly.
tried
Ask-
you could have
Sorry,
tried
indeed. I was talking to Orpita. What did she say?
You
So-
could have
so-
tried eculizumab. You could have tried eculizumab.
It
to
happened in
diagnose.
June and eculizumab became available in August in our country, so just 2 months.
20 this year, sir. This year.
This year from August
This year
onwards,
from August it is available.
it is available.
Otherwise you could have exported it,
Used.
but
Not used.
sorry, imported it.
Imported.
We could have tried.
This is eculizumab is would have been the best choice for this patient for taking such.
Yes. In meeting, Anuja was there. Anuja was telling that they no more use plasmapheresis. They start with eculizumab, even they get report little late. So they start with eculizumab, then discontinue if there is no result.
Eculizumab first.
Yeah, eculizumab first. It has become practice in US that whenever you find a TMA, eculizumab first, and then they.
How difficult is this patient to go to Proteus Hospital and get a swab?
In Pratik's hospital, he might get a ABY. Pratik does more ABY than swab.
A and B and their age group is very much match would have been found. This is not very difficult.
Not very difficult.
So, you know,
We have many pairs similar to him.
I think the learning point is, we try to, we have to get to swab. Everything else is expensive and everything else is all these questions and queries behind it. So it's better to try as hard as we can. Maybe we're not trying hard enough.
Yes, we are not trying hard ki ekdom hi try korchi na.
No, but it's happening. It's happening as an institute.
Yes,
It was much less.
but much less. I think
But it's more than
Pratik
eculizumab.
does 600 transplants a year. Huh?
No, but he's
এই
not
চুপ
doing.
করো, তোমার
ঠিক আছে।
তুই 600 তো করোই।
No, no, he's,
Actually কি হয় মানে
600 ট্রান্সপ্লান্ট
What-
করে
what-
কিন্তু
what-
তার
what-
মধ্যে হয়তো পেয়ার করলো এক বছরে একটা পেয়ার।
What is your experience
Hari,
with a patient
Apu.
like this
Acha.
in your ABO incorporated?
Manish is
No,
student.
basically the
Come Manish. Manish is from our college.
we do know you. We were asked.
Devashish. Manish. Her teacher. Either batch.
Jayantara has asked one question. How do we do for these patients? Actually, for a titer of 64, we don't do glycosol. Actually, our experience is only glycosol is not very good. And that may be the reason on UK also they are practicing only this is absorption column. They're not plasmapheresis. For a lower titer, the plasmapheresis is good in many ways. It is removes the titer, is a predictable lowering of level of the titer, and it also removes so many other inflammatory factors. So you can be slightly sure that urine will come on table and it will be there for at least first 48 hours, there will be no rejection. Okay, so one thing that is different, and another thing we
And
always need
Pratik, you
ATG.
can also tell Devashish the history, how you have come down on your pre-transplant immunosuppression. That would impress Devashish a lot because they are they're very fond of that, considering the patient survival outcome.
Initially, we used to give a 500 milligram rituximab, like 375 milligram per meter square. So there is lots of infection, pneumonia, and etc. So we reduced from 500 to 300, then 200. Now we're using only 100. We have
Good, very good.
And we just monitor the CD19 level. In many of the cases, it is always less than 5%, less than 1%. It
What
remains
do you need?
need more. Secondly, we don't, in a desensitization, we don't use IPIG nowadays, only do the plasmapheresis. One IPIG dose just to replace the immunoglobulin that has been removed in plasmapheresis, and then do the transplant. That becomes the cost. It's much cheaper if you don't use immunoglobulin.
And it's also less immunosuppression.
And rather we use ATG for
I guess.
And ATG also we don't use the we use low dose
low
ATG.
dose, only 3 milligrams per
Only
kg.
3 milligrams per kg, that too divided in 2 sessions. For 1.5 usually with the beginning, and then follow the platelet count and everything. ATG gives us one comfort that I feel that I can be whenever there is TAC related issues, I never hesitate to stop TAC for few days and then restart. Suppose this TAC TMA.
If
I have
ATG
to-
is there, you are comfortable.
ATG is there, I am comfortable to that I am saying that it gives me that benefit. And when I started first giving ATG at that point of time,
So you're talking about ATG in all transplants?
no, in high risk
In
transplant.
high risk. Sorry.
Yes. And Pratik would propose for even low risk that he has his observation kept for that. But
we have
I
done a head-to-head trial. One of my PGs done the thesis, ABO incompatible, ATG versus
ABO
Rafalon,
incompatible, right? Yeah.
and this is a basiliximab. So slightly rejection rate is higher in
Basiliximab. But Urpita is talking not about ABO incompatible.
No, all
just
cases.
high risk.
all cases, all high risk cases, yes, all high risk
But
cases.
we use induction for all patients.
You do
Yeah.
induction for ATG.
We do induction. No, not with ATG, but induction for all cases.
We use
All
basiliximab
patients.
also.
It has been observed that no induction, ultimately the long term effect, that is, you are ahead, one step ahead in good matching. You are doing four.
I guess so.
Yes.
Yeah.
But the difference is just like that just lies there. We are not matching it
So
perfectly.
that's why they ATG.
That's why.
But in Apollo they don't. They use basiliximab.
Yeah. No.
Do you use ATG at all?
Yes. Yes.
You do?
It's just before this IPTA meeting in September, I launched a Google survey that what are the inductions we are using, so it came universally from 70% of nephrologists
ATG.
that ATG, yes, Indian nephrologist is ATG.
Okay, that's fair
Because
enough.
another thing is now, if you consider the de novo TSA, chronic
Yes.
APMR, because it doesn't end with first 3 months.
Yeah.
It is a long term, because we have seen more
That
than
is-
50% patients they are developing
That I was
antibody.
going to mention that if you look at first when ATG was being used, though 2007-8 at that point of time, Sanofi used to give us monthly or 3 monthly CD4, and we had seen that the lymphopenia extends even up to 6 to 9 months. Yes. So this observation helped me in formation of a protocol in my mind that for any reason if I am to withhold TAC for 7 days, I should not hesitate if I have used ATG as when I am confused that whether it is a TAC related TMA or a BMR related TMA, and I am yet to get the information. I withhold TAC if I have given ATG. Yes.
How frequently do you see thrombotic microangiopathy in post-transplant?
We see, not that we do
Not
not
the
see.
high risk ones, but
Normal,
you do see a lot of TMAs?
no, not lot of, but
Not
we
lot
see.
of, but
Everyone has seen 1 or 2 in a year.
yes, 1 or 2 in a year we see.
We see. I don't know. Maybe our compliments are different.
What
See,
is
we
the
don't see that
antigen? I
often.
feel the lot of infection exposure, antigenic mimicry stimulates our immune system in a way
Now, why do you
that
bring
our
tacrolimus
Treg
then?
cells are not
If
in.
you ask any nephrologist in the country, they are aware of the TMA thing.
Yes.
Because everyone has seen.
Everyone has.
No, but then
And
you
the
shouldn't-
devastating
But then
consequence.
you shouldn't blame the tacrolimus for it.
No, we are not blaming. I am telling you that many a times tacrolimus had given us just a very limited period of time, only renal limited TMA. There, after that, we could use tacrolimus in lower dose or replaced it with cyclosporine. It's an idiosyncratic reaction, so not always that lower dose will kill.
TAC TMA don't need an effect.
Yes,
Most of the time.
by most of times. TAC TMA doesn't need it.
No, I'm sorry, I keep going on about this. The reason the 2 patients that was presented today both had bad infections. One had a miliary tuberculosis and the other had a pseudomonas and a weird infection called parvovirus, which I see like every 20 years. So infection is a problem. So maybe what is actually reducing your long-term survival is not the immunocompatibility or immune-mediated damage. It's the infection.
Yes.
For us, it's non-immune mediated damage, you know, hypertension and then the high cholesterol, etc.
And
So we are missing the point here. You are concentrating on make the graft survive from all immune harm for the first 180 days or so. But the problem is, what happens after that? Or during that time, how many infection episodes do you get? My question to you is, when you look at it vis-a-vis, you know, your immunosuppression protocol as opposed to infection-related problems, what wins? What is the major problem which reduces your long-term graft survival?
Not that every patient would get infection.
No, I'm talking about 100 patients. What do you see? You have to design a protocol which suits 100 patients.
What is important, that infection is quite prevalent. We see lots of infections. But in many situations, we reduce the immunosuppression. And the lands up in some sort of rejection and giving methylprednisolone, etc. Ultimate cumulative immunosuppression goes up.
Yeah, that's another problem.
That is another problem. So, for giving a lower immunosuppression we have seen is a more, suppose for hepatitis C patient, we used to give a basiliximab, we are not using a tacrolimus, we are using cyclosporine, but ultimately they landed up in acute rejection in the 2-3 months time and giving methylprednisolone to them, again going back
Nowadays
to
I am not using cyclosporine anymore, tacrolimus.
but we have used at one point
At
of
one
time.
point of time we used.
So chances of pneumonia, sepsis is much more. So cumulative immunosuppression goes up if you are on the lower side of immunosuppression.
In the beginning.
In the beginning.
So hit them hard first,
Right.
with ATG and everything that you can. I don't know. There is no right answer, Simon. You realize that, right?
So bilateral nephrectomy is a dangerous thing.
Yes.
You are fortunate that your patient didn't require any blood transfusion.
Yes. That is the main
and they come out with 1 liter of blood from the body.
You go to net and read on this. There are good articles. ওই আমি যেটা তোমার ওই সময় পড়েছিলাম, তোমার সঙ্গে যেটা মাস্টার ক্লাস নিলাম, তো there are good pro and con discussion. So you read that.
Reading a biopsy is difficult for us until unless it's a good stain, good microscope, good everything. But reading an ultrasonography and Doppler is easier for us. It gives you can point of care ultrasound. If you do with lots of information.
Lots of.
So it helps you with treating the patient because this patient has some sort of parenchymal disease on the day 0 or day 1. So your plasmapheresis would have been started slightly earlier because at that point of time you are expecting an accelerated active rejection. That is the first impression. So you start plasmapheresis maybe on the second, yes, and then might be some necrosis would have been prevented. Probably, I don't know. So
you said that ultrasound is so easily. So, Saini, your patient, who did the ultrasound and how easy it's to get an ultrasound?
We don't have a USG machine, we do perform it. But this ultrasound, we also called the radiologist to be doubly sure.
To be double.
Cost of patient suddenly you learn. It is easy because doing an ultrasound in a transplant kidney is very easy compared to doing a transplant patient in a native kidney. Doppler in native kidney.
And it's superficial and it's very well visible. You put the
Doppler in
probe in.
native kidney arteries, veins, according to the radiology, this is the most difficult things to do. Showing a good flow in a native kidney rather than flow in a transplant.
Thank you very much. Should we move on?
Yes, next.
We don't need a tea break, do we?
No, not need a tea break, but need some tea.
Yes.
I just have
Need some tea.
Oh yeah, taking
Just some more slides.
Yeah, 2 more slides. Yeah, go ahead.
Just 2 more slides.
Yeah.
So just about the peculiarity of our case, that since the basic disease was ADPKD, we actually did not think about any complement pathway, so we did not work up for that, which we should have done to avoid.
Bottom line is presence of ADPKD doesn't exclude
Rule
your
out.
genetic complement. That might
She
not be the
developed
cause.
the ASRD in 42, no?
38.
38. So is not only for ADPKD. So she a family history and all are by the age of 60 or 65.
Yes, sir.
But she only developed ASRD
Very early.
ADPKD के लिए आजकल तुम कुछ भी आगे नहीं बोल सकते हो, सब तरह का पेशेंट मिलता है, but
नहीं मिलता
here
है
तो हाँ.
but there is some different ना कि family history different than the sub patient.
Oh, she didn't have any pregnancy, so it was not tested. No second hit was there. Only second hit.
लेकिन pre-transplant complement pathway करना बहुत मुश्किल है इसमें. How can you take the hint of doing a complement pathway?
তো retrospective.
I could retrospective. Pre-transplant, I can't think of being a compliment for but as soon as it has developed, I should have said.
38 rejection over.
Before
Maybe
flex,
32, 33 more.
Look, we
So
can't
little bit different from the female history. So should we not think something? I'm not because आजकल तो हो रहा है ऐसे. So but can we think about that? This is my question.
No, but this is the part we don't explore
don't
much.
explore.
But,
Yes.
so,
We have actually asked the patient to sit.
Right. What's the next thing you want to do?
Okay.
What else we could have done? We could have tested for a non-HLA antibody, and we could have offered her eculizumab.
Yes, we could have offered it, which was available the next month.
So at least your thought process is matching with us. That is one CTMA we have missed. Every case teaches us something. Every case.
Thank you very much. Very good, very good. All right. What's next?
What's next?
Nick.
Yeah.
Tuberculosis complex. Is your slides ready?
Yeah.
Others are something with
Right. Nick is ready. John is supposed to chair.
Yeah, Joan sir চলে গেছে? ও চলে গেছে? স্যার চলে গেছে, খেয়াল করিনি আমি। স্যার তো এইমাত্র ছিলেন, প্রশ্ন করছিলেন।
আপনার তো আছে।
Your presence.
Oh, it's they sent it by email. It's yeah. But you found it.
Case presentation হলো
It's
tuberous
there
cases.
on the email.
তারপরে তো আর্টিকেল ওই জন্য আমি চেয়ে তারপরে আমি না এবার তো গেল
Tuberculosis.
হ্যাঁ 12:30 আছে চলে যাবেন কি কোথায় যাবেন স্যার বুঝা কালকে দেবেন
ওরা তো ভালো বলবে, ওটা রিসার্চের কাজ।
আরে চেক করবে আপনার সিজন
it is a Apollo monitor and IPGMER.
কালকে তো
Right.
আমি কখন যাচ্ছি দেবো
Oh yes.
আপনার কি
তোমাদের কি একসঙ্গে 10টা বিয়ে করে?
কি আছে
কপিডি করে? হ্যাঁ? সবাই কপিডিতে রেখে নিয়েছে। হ্যালো, বলছি আপনার তো এই সেশনটা চেয়ার করার কথা, আপনি চলে গেলেন। হ্যাঁ, এই যে টিউবারাসিনোসিস কমপ্লেক্স চলে আসবে। ঠিক আছে। আচ্ছা, হ্যাঁ, দেবাশিস was missing you. ঠিক আছে। তোমার তো একটা চেয়ার ছিলই। আচ্ছা, ওই চেয়ারে যেতে পারো, ওখান থেকে দেখা যাবে না ভালো। প্রতীক is chairing from here. So you open the door.
Sharing from the chat.
You start.
Cheering for the
So,
sister.
we are eager to hear from you regarding the disease. Don't see much, but
Yeah.
we see more in the
And
neurological
this is
part.
his research area.
Oh, that's nice.
Yeah.
That's another
Okay. Thank you very much. So, yes, I'll talk to you about tuberous sclerosis complex and what we do at St George's. This is my statement of interest as well, but the third in the series of our pictures shows just behind how our university has now become bigger by merging with City University. So we're St George's and City University, and so we have, when you come and visit us, we have a Tooting campus where we are at St George's, and we have a Clerkenwell campus in the original City of London, just up here, which is enormous. So George's is getting ever bigger. I think that's the nice bit of it. So what is tuberous sclerosis complex, or TSC? It's a multi-system genetic disorder, autosomal dominant in inheritance. It's relatively common as a genetic condition. It affects 1 in 6,000 to 1 in 10,000 live births. And worldwide there are about 2 million patients who suffer with TS. It can affect all races, genders, children and adults. And is characterised by non-cancerous or benign tumours that grow in the brain, the kidneys, the liver and pancreas, the heart, the lungs, the skin and eyes. And in the brain we get structural lesions including SAGAs or subependymal giant cell astrocytomas, subependymal nodules, and cortical tumors, and these can relate to a functional disorder, mainly epilepsy and associated learning difficulties. And so a third of our patients will have a profound intellectual impairment, and much of that is related to uncontrolled, poorly controlled paediatric epilepsy. But at the same time, around about a third have average intelligence and can have perfectly normal outcome, and indeed hold down normal jobs. For some of our patients, it's amazing to both have patients who have profound learning disabilities who are entirely dependent on their carers around them, to those who are chief executives and banking officers, etc., etc. So it can affect many people in many different ways. In the kidneys, we can get angiomyolipomas or AMLs, and around about 80% of our patients over a lifetime may suffer AMLs. Kidney cysts, about 35 to 50%, some of which can show malignant transformation in 2 to 3%, and there are around about 5% of our patients will have a TSC and PKD contiguous gene syndrome. That's because one of the TSC related genes and PKD are on the same chromosome, right next to each other. And they can have accelerated end-stage kidney disease. Chronic kidney disease, CKD, stage 3 to 5, so some 40% of our patients may suffer with chronic kidney disease, but just 1% will suffer from end-stage kidney disease requiring kidney replacement therapy. But kidney disease is the commonest form of death amongst our adults with TS. In the heart, they can have cardiac rhabdomyomas. In the lungs, we can get pulmonary cysts or leiomyomyomas. So these can spontaneously burst, leading to pneumothorax, and that is a not uncommon presentation in adulthood, and mostly in females. So we believe that the driver for pulmonary LAM formation is estrogen exposure. So males do get it, but much more rarely, and most of the people that do get it are female and post-menses and around pregnancy, where you have particularly high estrogen exposure. In the skin, around about 96% of our patients will have some form of skin lesion, and these include the facial angiofibromas, the adenoma sebaceum, and this is probably the most characteristic, end of corridor diagnosis that you'll notice. And we also get subungual fibromas. These can be very, very painful and grow underneath the nail bed and push the nail out to the point where our patients may ask for plastic surgeons to actively go and do an operation and remove the nail bed in order to relieve the pain. And we can also get these hypomelanotic macules or ash leaf spots that anywhere on the skin. And Schagreen patches, which are these thickened areas of skin, much like Schagreen leather. And in the eyes, we can get astrocytic hamartomas, which are growths on the back of the retina. Normally don't require any intervention whatsoever unless they affect the fovea. And then alongside all of this, we can get TSC-associated neuropsychiatric disorders, or TAND, and some 90% of our patients will be affected by TAND. TAND is an umbrella term, as demonstrated by the umbrella, which was coined by our psychiatric colleague from South Africa, Petrus de Vries. Essentially, as an umbrella term, it's including behavioural, psychiatric, intellectual, academic, psychological, and neuropsychological terms, but broadly explains that that preponderance of patients with ADHD, with autism spectrum disorder, with significant learning difficulties, with anxiety, depression, and how that affects their psychosocial well-being, and describes one of the major challenges in looking after patients with TS. The diagnostic criteria for TS, these, I suppose, in history, TS was described back in the late 1890s by as Bourneville-Pringle disease, and then Vogt's triad, which kind of identified learning difficulties, adenoma sebaceum, and epilepsy. But that realization that only a third of patients actually had all three of those features, and that actually there was this kind of preponderance of lots and lots of different features which constituted one disease, meant that we had to have clinical diagnostic criteria that kind of described what it meant to have TS. And so now, after several worldwide conferences around about 10 years apart, in 1998, 2012, 2021, we now have the diagnostic criteria which define definite TS, which is made up of two major features, or one major feature and two minor features, possible TS, one major feature, two minor features, or genetic diagnosis with a proven variant in TSC1 or TSC2. And those major features include the hypomelanotic macules, the angiofibromas, the ungual fibromas, Schagreen patches, multiple retinal hamartomas, cortical dysplasia, subependymal nodules, SAGAs, cardiac adenomas, LAM, and AMLs. But if a patient has LAM and AMLs, as in kidney and lung involvement, that is only one major feature. And so often we have patients with pulmonary renal syndrome, but no other skin or brain manifestations, and so they are merely possible TS, not a formal diagnosis. But we believe that those patients will have kind of a form fruste, so the common progenitor cells that are leading to kidney and lung development have been affected by a TS lesion, but other cells in the body have been effectively untouched. And so often it's those patients who, when you do a DNA test, we can't find the cause of the mutation. The onset of TS can happen anywhere during, obviously it's a congenital condition. Patients are born with this condition, but they manifest at various stages of life. Prenatally, we'll identify cardiac adenomas or brain lesions in utero. Early in childhood, at around about 5 years, we might identify childhood epilepsy or associated skin manifestations and retinal eye hematomas on routine investigation. Later in childhood, we might get the kidney angiomyopomas or liver angiomyopomas and pulmonary lab in late teenage. And then we might, in adulthood, identify patients by their skin manifestations, kidney manifestations, or just during routine screening with a CT or MRI brain. So at any stage, the patients may come through different clinics. They can see us through a geneticist, they can see us through an early neonatologist, might see them through a dermatologist or an ophthalmologist, might see them through a kidney doctor, urologist, or through a pulmonary physician. So they're presenting at any stage during an entire lifetime to lots of different specialties. So part of my role is really just to educate lots and lots of different specialties about this condition and to make sure that everyone is aware of it, because early diagnosis equals early screening equals potentially preventing people from progressing or preventing complications of the condition. So how does it affect patients? Everyone individually. As we say, it can be life-limiting. We can get childhood epilepsy with secondary learning disability and autism spectrum disorder, can lead to generalised developmental delay and that lifelong dependence. Can be life-threatening. TSC lesions on the brain, these sagas can grow and this can lead to acute hydrocephalus. And the TSC related AMLs, and this is what you will see more and need to be aware of, the possibility of those AMLs growing and leading to life-threatening hemorrhage. And the big number that I want you to remember is 3 centimetres. So an AML greater than 3 centimetres is one that's associated with enhanced risk of bleeding and which intervention would be appropriate. And of course, as a genetic disease, it can be passed to the offspring, so there's a 50-50 risk of passing it on. Those clinical manifestations of TS, I suppose just to reiterate that point, it can present to any and different specialists over a lifetime with a predominance of nervous system involvement and dermatological involvement and neuropsychiatric disorders, but the kidneys and urinary tract are involved in up to 80% of the time. It's a genetic diagnosis, so over the course of those many years since 1890, when it was described by Bourneville and Pringle, to the kind of late 1990s, early 2000s, where the TSC1 was identified, which encodes hamartin on chromosome 9, and TSC2, which encodes tuberin on chromosome 16, which account for most cases. So spontaneous mutations occur in 60% of the cases, and the rest are inheritable. But of course, if we drill down slightly further, we realise that there are some cases which aren't spontaneous, they've actually been passed down from parents, but with milder manifestations. So there's incomplete penetrance of the manifestations of the condition. So the 80% that are identified, we still have 20% of cases where there is no genetic mutation that's identified. What is it the cause in those cases? And I suggested that one of those potential causes is mosaicism. So if you do a whole exome sequence, or you just do 200, 300 reads of a genome or of the TSC1 and TSC2 genes, and you have a 2% frequency of mosaicism in your circulating cells, then you'll only get to maybe 4 or 6 reads in that 300 reads. Whereas if you do 1,000 reads, you'll amplify up the percentage mosaicism and be more likely to identify those the pathogenic mutations. As you can't do 1,000 reads on every single patient, that would be incredibly expensive and incredibly laborious. And And so there are a number of patients who we don't have that genetic diagnosis, and that is often in those patients who are more mildly affected, those with the pulmonary renal syndrome, or those with the those people who are less severely affected, who haven't been affected by childhood epilepsy, the ones that we often find we can't find a genetic diagnosis. And that's particularly frustrating because those are also the patients who are most likely to be thinking about having children, and who want to be reassured that they're not going to pass it on to their family. Yes, 75 to 85% of patients that meet diagnostic criteria for TS have a mutation in TSC1 or 2, 5% have a contiguous deletion in TSC2 PKD1, and therefore have this accelerated form of ADPKD. They have a higher rate of chronic kidney disease, a higher rate of end-stage kidney disease, and it's very difficult to prevent them from progressing from childhood. And so we'll often be having these cases, and I suppose in your clinic you'll be thinking of patients with accelerated ADPKD and autism spectrum disorder who are particularly challenging to think about transplantation or to think about dialysis in. We mentioned as well that high rate of high incidence of somatic mosaicism, which makes it so difficult to identify a genetic cause sometimes. So talking about TSC1 and TSC2 takes us on to mTOR, the mechanistic target of rapamycin, and the story where mTOR was extracted from this bacteria, Streptomyces hygroscopicus, which was isolated from Easter Island or Rapa Nui in 1964. It was identified initially by its inhibition of fungal growth, but then identified as an mTOR pathway subsequently, and leading to the creation of the generic mTOR inhibitors, sirolimus and everolimus, initially used as an anti-cancer agent and also as a transplant immune suppressant. The prospect of being able to completely target mTOR in our TSC patients was promising. So Hamilton and tuberin kind of form this complex, TSC protein complex, which then interacts with the Reb GTPase, which inhibits mTOR signaling and the cell growth pathway. And mutation in TSC1 or TSC2 therefore prevents this protein complex from forming, and therefore leads to unregulated mTOR or constitutive mTOR upregulation and increased cell proliferation and those benign tumours that you can see. So in theory, mTOR is going to block upregulation of mTOR and therefore block cell proliferation and ameliorate those benign tumours. And indeed, when we use mTOR on kidney angiomyomas, we see a decrease in size of up to 50% of reduction in AML size over just 3 months of treatment, a decrease in vascularity, most importantly, because we worry about the life-threatening hemorrhage, and over 6 months of therapy, well, it's actually a lifelong therapy. We're treating patients for a lifetime with this medication. Before TS, we had only surgical intervention or IR intervention, so we were just kind of going in and embolizing the kidney adenomas, and sometimes we still need to do that. But now mTOR inhibition has proven a really revolutionary treatment for our patients. With cystic kidney disease and accelerated chronic kidney disease, it's still blood pressure control and ACE inhibition. And with these renal, the prospect in 2 to 3% of our cases of having a malignant transformation, we're doing annual surveillance imaging for patients with TSC-related chronic kidney disease and discussing carefully about whether and when timely biopsy and surgical or interventional radiological intervention is appropriate. The EXIST trials completed in 2013 So this is EXIST 2 demonstrated a significant reduction in AML size with everolimus, which was sustained over 24 months, and also demonstrated over 5 years to be 5 years sustained treatment to be effective. But the next challenge, having identified a good medication which helps treat your patient, you've got to get funding for it because it's expensive. About £20,000 per patient is no small amount in a nationalised health funding service. So in the UK we have NICE, the National Institute for Clinical Excellence, which helps decide on what funding and which medication is allowed to be used for which particular patients. So it took a clear further 3 years of writing and lobbying our UK government to approve national funding for everolimus for our TS patients to help shrink their kidney angiomyomas and their brain sagas and their pulmonary lamb and refractory epilepsy. But now we have, this is the lifetime risk of getting various complications in TS. So brain sagas in 10 to 15%, kidney angiomas in 40 to 50%, symptomatic LAM in 5 to 40%, resistant epilepsy in 40%, disfiguring facial rash in 75%, TAM, TSC associated neuropsychiatric disorders in 90%. And now we have a proven treatment for 3 of those conditions, and we proven and funded treatment for 3 of those conditions, and evidence that the LAM, the facial rash, and possibly the TAND may be ameliorated with mTOR inhibition too. But practically, as we all know, as we were discussing in our cases, thank you very much, and mentioning mTOR inhibition during some of those cases, it isn't a side effect-free medication. We do get side effects, mostly in the first month, of mouth ulcers in 40 to 50% of cases, GI disturbance, menstrual disturbance, blood count abnormalities, hypercholesterolemia. Most of them settle after the first month. So for us, with patients with really severe learning difficulties, often tolerability is the most important, and therefore that feeling when you have autism spectrum disorder in a child or in yourself, it's important to feel supported, and we find that dose alteration, proactive dose alteration, can help with tolerability and therefore medication adherence. And this has allowed us to have really good success in treating patients with kidney angiomas, brain sagas, and pulmonary LAM. But with epilepsy, we found it rather more difficult because that is most where we can require relatively low doses of everolimus. We can get good shrinkage of the kidney angiomas. Epilepsy is more dose dependent, and as you increase the dose, you often get more side effects. So generally, we start patients on 5 milligrams rather than 10 milligrams we published with EXIST, and as this is associated with fewer side effects, and we're typically seeing patients in the first year on a 3-monthly basis, and then supported by a virtual clinic, and then over once we've got through that first year and made sure the patients are able to tolerate the medication, we'll see them typically annually with 6 monthly telephone consults. And we have to pace ourselves. This is a lifelong treatment, and we have patients who are coming across the country. I realise that across the country in the UK, there's only 700-mile long country, so it's relatively short, whereas today we've been talking about patients travelling for 3.5 hours just to come for their transplant follow-up. So it's an awakening to me to think about how much patients are willing to travel in order to seek good health care. But as a lifelong treatment for patients with severe learning disability, you have to think that you don't want to put patients off, you don't want to over-medicalise it, and finding ways of limiting the amount that they're coming to hospital, but at the same time keeping them safe is important. more UK guidelines on their way. So we have one TSE genetics clinic a month for diagnosis, which sees about 400 patients. We have 2 TSE renal clinics a month, which sees around about 150 patients on end or in addition treatment. And we have a 2-monthly regional MDT. But we're supported by an enormous team. The key person of which is Ria's colleague, Lydia, who's a TSE clinical nurse specialist, who helps hold it all together. And without a central coordinator for patients with multi-system disease who sorts out regular MRI scans of the brain, regular CT scans of the chest, regular kidney MRIs to exclude malignant transformation and demonstrate therapeutic response to treatment, then if you don't have central coordination, people get lost. They slip in their follow-up and may not continue to take their treatment. And the next time you see them, they're coming in with a severe life-threatening complication. So this is what holds the service together, is central coordination with a clinical nurse specialist. We also have kidney doctors, geneticists, neurologists, paediatricians, psychiatrists, respiratory physicians, interventional radiologists, neuroradiologists, neurosurgeons, but yeah, I was just going to mention a case just to illustrate it. This was a 31-year-old female. She was referred by a paediatrician to a clinical geneticist at St George's, first seen in 1993 when our clinic opened at St George's. The clinical diagnosis was made because she had infantile spasms, hypomelanotic patches, subependymal nodules on in utero scan, developmental delay, facial angiofibromas and kidney angiomyopomas subsequently, and she had severe learning difficulties, autism spectrum disorder, and needs a general anaesthetic for any procedures, including dental checks and blood tests. And she's living in supported living, and she's got a mum, a dad, and 2 sisters, none of whom are affected. So, to all intents and purposes, a spontaneous pathogenic mutation and she was the first one affected in the family. Her first scan since 2019. This is 4 years later, and what do we need to do? This is just illustrating the MDT. We needed to involve the support workers of her support living, neuroradiology to sort out a general anaesthetic MRI, the cleaning service, the family, cardiac investigations to do an echo test, radiologists, health and safety, the TSC CNS, the GP in a local hospital, Bellrock with a security system for the building, the anaesthetic team to run after her to give her general anaesthetic, the learning disability team to make sure that we're not doing anything too forcefully, and security to open the doors at the back of the hospital so it wasn't too much of a sensory overload for the patient. But what a day in order to coordinate one single scan for one single patient. And I look outside and see 700 patients, and I think, goodness me, what a challenge. So I mentioned the central role of the clinical nurse specialist. She's the main point of contact for care and coordinates surveillance, blood tests, locally and centrally, coordinates the MDT networks, and so much more. And as ever, our patients require, they're highly diverse, they're often highly anxious, bargaining, grieving, worried about their siblings, worried about their offspring, and we have a patient charity, the Tuberous Sclerosis Association, who offer counselling support, research funding and service support as well. And we have a rare disease collaborative network where we were just one of 2 centres in the UK. We've now managed to get 19 clinics across the UK set up and have regular MDTs to make sure that everyone's getting the same kind of treatment and the same approach to treatment. And that's been very rewarding to be part of helping to grow that. And there is a research arm at King's College London who are looking at the mTOR rare disease node. So TS is just one of the many mTORopathies that you'll have heard of. You'll have heard of Peutz-Jeghers, you'll have heard of lupus, of Cowden syndrome, of various other associated mTORopathies that are far rarer than TS. It's quite amazing. We go to renal rare disease meetings, and TS is like a kind of a dwarf orphan compared with ADPKD or with Alport syndrome. But we go to the mTORopathies conference, and we are the big brother when we go there. So we're the commoner of the rare diseases. But there are lots of avenues that we're following for research, and for the sake of time, I'll just say that we love involving everyone in our research, and if anyone wants to join us, then we're always happy. And then I'll just stop for questions, and there's that map of our ever-growing university, which was St George's, now is City St George's, because we're just the whole of London. Any questions?
So the first question is, we see these as a CKD or ESKD so less, so still you felt interested to be part of this research wing. What actually inspired you?
Oh, right. Well, that takes me down my path of my PhD. So I did a PhD in VHL, and looking at how hypoxia pathways are influenced by glycosylation. And having come out of my PhD with Patrick Maxwell and Margaret Ashcroft over at UCL, I joined, and my close colleague Chris Kingswood, who had run the clinic since 1993, and he has a personal drive. His daughter has TS, so he was inspired himself to set up the clinic and follow these patients up, and has been the main author of most of the changes in service over a lifetime, including that important bench-to-bedside switch of identifying TSC1 and 2, the mTOR pathway, and demonstrating that mTOR pathway inhibitors have that massive effect on kidney angiolypomas. So it didn't take too much to inspire me, having already had a background in looking at VHL disease and also involvement kidney lumps. I think that's probably the best collective term, isn't it? So,
do you think you are closely following up these patients for long years? So do you think that mTOR intervention had really benefited them, and in which terms they have benefited? So many diverse clinical spectra.
Yeah.
So even if one suppose neuropsychiatric domain has improved, or did such study or such observations had occurred to you?
So I think probably the biggest benefit is helping to prevent the need for regular IR or surgical intervention for kidney angiolypomas. So once you see a patient with growing kidney angiolypomas, 3 centimetres, 4 centimetres, 5 centimetres, 7 centimetres, 12 centimetres, and at some point they're going to bleed, and it's going to be a life-threatening hemorrhage, and so you have to take at least one opportunity to intervene. And in the past it was prophylactic IR embolization, with that risk of knocking out a bit of normal kidney each time. And they'll often require at least 3 or 4 interventions over a lifetime in order to prevent bleeding. And in others, you'll have patients whose kidneys are completely replaced by AML. And so you're really looking macroscopically for any functioning kidney tissue. There is still stuff there because the creatinines are 100, 120 and stable, and as evidenced by the fact that most of them don't progress to end-stage kidney disease apart from the contiguous gene patients. So that biggest change is a patient with severe learning difficulties planning their IR intervention, and now no longer having to do that. the cost, you have to get them used to taking a lifelong expensive medication, which they'll get side effects from for the first month, but if you can go relatively low dose, then they can be side effect free for a lifetime and not require any further interventions. And that's massive. That's for both learning disabled and non-learning disabled patients alike. So yeah, it didn't take too much to inspire me, but it does require an enormous amount of support.
And radar-based studies, we have seen in IGAN, the radar-based publications, how they have transformed our view about IGAN. That IGAN is a slowly progressing disease. Only 50% do have ESKD incidences. But that has changed through this radar that the UK had published and the information reservoir.
Yeah.
So do expect that similar
Well,
valued information would come out about this.
Yeah, I sharpened my teeth with IgA nephropathy and found it's taken a long time, hasn't it, from the days of MMF. We are now starting to see some fruit for the labour of identifying the cause. Again, another form of glycosylation, aberrantly glycosylated IgA, but I think we will still see further developments in treatment. And for TS, we're seeing more developments in treatment. What we really need is a drug that does all the good stuff and none of the bad stuff. And hopefully more targeted mTOR1 therapies are around the corner. So, yeah.
And what you were talking about, bench to bedside, is always...
That's always inspiring. But I think a major challenge when you're dealing with a rare disease is getting funding and coordinating enormous, the required randomized controlled trials in order to demonstrate their work, and also make it rewarding enough for our pharmaceutical companies to fund. And that, I suppose, is the foundation of why a large mTORopathy community is important, because in order to get it funded, you need to have enough patients who are going to be affected. With rare disease, the common problem is there aren't enough people affected to make it worthwhile. So, yeah. Anyway, I could talk for a long time about this. Are you sure you want me to?
Yeah, but rare disease RCTs are impossible unless there a nationwide registry exists.
Yes.
And you conform to a common treatment protocol, and then you add up or minus any intervention to look at the RCT outcome.
Yeah. Well, I suppose should I ask you a question? Where I do know there is an Indian TS community, but is mostly surrounded in Delhi, and Delhi is just one minor city in India.
I'm not aware of.
But I mean, yes. To what extent is there TS awareness and
you
structured
people are globally
treatment?
mapping the TSC communities.
Might have been, just as we started out with 19 TS clinics in the UK. To what extent is everyone else following suit, and to what extent can we help others to follow suit? Because of course, for you, we haven't got a solution to the contiguous gene syndrome. They will have accelerated end-stage kidney disease due to an accelerated form of ADPKD. But the others, if we can avoid IR intervention, then that would be massively cost-saving. mTOR inhibitors are coming off patent pretty soon. They should be widely available, so they will become more affordable. So then you're looking for reasons why we can't have a networked approach.
Thank you.
So just as soon as the diagnosis is made, they are put on these mTOR inhibitors.
No. So the indication for treatment is, as ever, you're going to have restrictions according to funding, but of course, underlying all of this, we believe that everyone would benefit from mTOR inhibition because they've got unregulated mTOR upregulation. and but there's the restrictions for treatment. So
Starting from early childhood, whenever the diagnosis is made.
yeah, so strictly speaking, we're growing kidney angiolypomas, refractory epilepsy, or brain sagers, which are greater than a centimetre and growing, are all indications for treatment. And with the brain sagers, you can completely avoid neurosurgery as a result of treatment. And that's a massive benefit. But I think the first thing to do is to make sure that people are aware of it. So in order to do that, you have to make the diagnosis and then get them scanned. And the first thing is being clinically aware of it. So yes, looking out for the facial angiofibromas, but that's not only a proportion. If you see on the scan kidney angiolypomas, think, what else do I need to scan for? Because I'm unchaired, obviously. Oh no, I'm not unchaired. Anyone can tell me to stop, but I'll keep on talking. Any more questions? But May the 15th every year, TSC Global Awareness Day. So I'll talk again on May the 15th.
Of which one?
May the 15th of every year is Global Awareness Day. So just put it in your diaries. But make your diagnosis any day of the year. Okay. Sure. Hand over to our next speaker. Who's our next speaker?
Our next speaker
is...
It's a journal club.
Ah, okay. Have you got slides?
This is Koshi. Yes.
Hello everyone. My topic is the evolving research landscape in kidney transplantation, a bibliometric overview. I am Dr. Kaushik, Senior Resident of Nephrology, IPGMER SSKM Hospital. So before going to the main discussion, I want to tell you that what is the bibliometric analysis? It is the quantitative data analysis to study research output, impact over a field, focusing on trends, authors and citations and collaboration networks. So it is mainly focusing on the trends and its collaborations and citations. Unlike the systemic reviews usually compile the studies to answer a specific research questions, and the meta-analysis combines the result of multiple independent studies that have examined the same relationship and intervention to produce a robust conclusion. Now, before my first presentation is on a journal, that is a bibliometric analysis of the most cited journal articles in kidney transplantation, Rawasde et al. It was published in Curious on 25/4/2023. The objectives of the study was to analyze the most cited articles in kidney transplantation using bibliometric analysis, highlighting the key trends, authors, journals and countries. Actually, there was few softwares like VOS Viewer, the Cites Bibliometrics. They have used these softwares to analyze the study, the methodology, the data sourced from the Scopus database, and they have used the search items using the terms kidney, renal, transplant, donor, recipient and procurement. All articles up to the query date on December 21, 2002 were included as per the Scopus database, and citation count analysis to determine top 100 most cited articles in the field. So I have already said that they have used the VOS Viewer version 1.6.18 and also used the Microsoft Excel from Office 365. Mean citation between different subgroups using the ANOVA test were used for comparison, and all statistical analysis are done using the R statistical language. Now, whenever they have put on the search items, they are up to 2022, they have found the 68,271 articles, up to which, from which they have included the most cited articles. The most cited articles are 100 in number, and they have excluded one because this was on the psychiatry based research, and they have included finally the 99 articles, up to which the types of documents were 92 are articles, 5 review, conference paper are 2 and editorial 1. So using the GSBR software analysis, they have found that most cited authors are the top 5 authors have they have named Cassis KBL, that they have produced 5 articles, and that lots of citations. Notable institutions were from the Medical College of Wisconsin.
Can you refer that where Cassis KBL works, where Opal G, Vincent F, and IPGMER Kolkata? These few I can remember I had read articles. Have you read what are the fields where Cassis KBL contributed? No. He contributed mostly in the donor-specific antibody, the immunological, transplant immunology related issues. And Opal G also more in transplant outcome and transplant immunology. And Vincent F. IPGMER Kolkata is more on epidemiological. He has shown many, he has written, he or she, might be, she has been part of, most probably she, has been part of many many cohort analyses, many epidemiological data, bringing onto the observational association based relations. These observational association based relations are very important in clinical context, because that inspires your RCT, that inspires your more robust studies. The observational association cannot give you that this is the cause, but it gives the association, and then you can probe deep into the cause of the thing. Inspires your research.
So accordingly, Ojo also did the same. He always analyzed the European database, the ETA database, and these articles are very highly quoted. And Flavio Vincenti is an immune therapy guy. He's the one who
There are many Vincentis, so I remain confused. I become confused that who F. Vincenti is.
This is Flavio Vincenti.
Yes.
But Bart Kaczynski did a few which was cardiovascular.
Achha.
Like putting on weight after transplantation. There was a few things which are, and also cardiovascular workup. So maybe those 5 articles, one might be cardiovascular. We never know.
Notable institutions: Medical College of Wisconsin, University of Virginia, University of Florida. So publication trends: the most articles published between 2000 to 2005, and a significant decrease in publications noted after 2015. Citation trend shows peak activity in 2000 to 2005, reflecting a strong research focus on transplantation at that time. Here are the most top cited journals. On the top, the New England Journal of Medicine. These are the American Journal of Transplantation and Kidney International. The top cited countries, of course, the United States. They are on the top, producing the 57 articles with maximum citations, followed by Germany, Canada, United Kingdom, and France. So the conclusions of the study is the bibliometric analysis highlights the most impactful studies in kidney transplantation, and the KDIGO clinical guidelines are central to kidney transplantation research. The United States remains a dominant contributor in the field, and continued focus on improving patient outcomes and understanding the transplant rejection. My next topic of discussion is the clinical research in renal transplantations, a bibliometric perspective, a half century of innovations and progress. So here in this study, more than 1 lakh research items were screened from January 1973 to October 2022 using the Web of Science core collections. Initial studies on the Scopus database, but next one is the Web of Science core collections. and that these are the topic search items, mostly based on the kidney transplantations. Among the last articles, they have collected the 200 articles based on the citation counts to represent the most impactful research in renal transplant. The datasets was analyzed to identify trends in research focus, publication patterns, gender representation, and global collaborations. Manuscripts were then further divided into the pre-millennial and post-millennial periods. So from 1972 to 1999, that was the period 1, pre-millennial period, and thereafter 2000 to 2022, it was period 2. So there was always a selection bias because there are heterogeneity of the publications for 50 years. So they have collected the articles, the first datasets of 200 articles, and at 2-year intervals. So there are 25 intervals, and at each interval they have collected the most top cited articles, top 8 articles with highest total citation. Now then they divided it into the qualitative and quantitative analysis, and further division into pre-millennial and post-millennial articles. So this is the quantitative and qualitative data analysis, the distributions of the top articles regarding the countries, then the institution, then the publications, and the further divisions into the pre-millennial and post-millennial. Here we can see the pre-millennial, the top 5 main topics. In the pre-millennial phase, based on mainly the outcome studies were focused, but in the post-millennial, the outcome studies as well as the registry-based epidemiological studies were also used. In the pre-millennial stage, they have the most of the articles were focusing on the infectious disease like CMV, BKV, etc. But in the post-millennial phase, the immunosuppressive drugs, they are mostly focused, and after COVID-19 it was seen that most of the studies mainly focusing on the COVID-19 pandemic and its impact on the renal transplantation. So these are the flow line chart. It is showing that the diamond shape, they are actually showing the articles produced at the 5-year interval, and here we can see the flow diagram, that is the immunosuppression from its initial use to the current use, and whenever the new drugs have been applied, they were always the main topic of discussion, and the previous ones become gradually obsolete or lesser focused. So the citation trends over time, research
so,
on...
Kaushik, if you take the trouble to analyze this one, that when discovered, when we talked about, when maximum number of articles came out,
Ma'am, here
you can see the earliest discovery of the steroids in treatment of transplantation. Yes, as immunosuppression. And there was a plethora, and the plethora reached maximum in between 1993. You can remember not only in the transplant phase but also in the autoimmune diseases, steroid related articles came up in that period maximum.
So the citation count for landmark studies in immunosuppression shows their clinical significance, and I have already said that after COVID-19 pandemic, most of the transplant studies, they focused on the COVID-19 and its impact. The geographical distributions, authors from 21 countries contributed the 200 most cited papers. The United States again leading its publication, followed by France, Canada and Germany, and the collaborations between countries such as US, Germany, Spain and Netherlands has been the integral to advancing the research on renal transplantations. The most influential journals in this study is New England Journal of Medicine, and followed by Transplantation and American Journal of Transplantation. The focus of research in this journal spans clinical outcome, immunosuppression and registry-based research. And I have already told it, but the immunosuppression has evolved through multiple paradigms, shifting from corticosteroids to MMF, CNI and mTOR. The landmark RCTs have been pivotal in shaping the current treatment regimen, such as 2008 Pascal et al. Trial on everolimus, and immunosuppression continues to be the central research theme, with ongoing studies focused on reducing drug toxicity and improving graft survival. So this Sankey diagram, they are showing the flows of in the pre-millennial and post-millennial phase. We can see that in the pre-millennial, before 2000 year, the most of the studies, the topics are outcomes or outcome based, and there was mostly on the infections and the gradual progression of immunosuppressive drug. But in the post-millennial phase, the registry-based outcomes supervene, as well as other factors on the transplant, that immunosuppression, risk factor, immunology, they are also focused, but most focus on the immunosuppression and drug. So this is the gender representation in research. Before pre-millennial, at the pre-millennial era, the males were predominated. The study actually shown the males were predominant as the first author or last authors. But in the post-millennial phase, the female distribution, though males are again dominating, but females are gradually improving as an author. So female representations now rising. So this shift toward the greater gender equality in academic publishing continues to gain the momentum. So I have already said it. The future outlooks, the future research is expected to focus on the precision immunosuppression, personalized treatment regimens, and the integration of system immunology, xenotransplantation, machine perfusion, use of stem cell therapy play a critical role in the next wave of innovation in renal transplant, and gender and diversity equity, as well as addressing global disparities in transplant availability and outcomes, will continue to shape the field. So key takeaways from this study: the renal transplantation has evolved through significant advances in immunosuppression, clinical outcomes, and collaborative research. The bibliometric analysis highlights key trends in the research focus, with major contribution from US institutions and leading journals like NEJM, and the future of renal transplant research in precision medicine, advanced immunology, and emerging technologies like xenotransplantation. My last presentation is on the relationships between the microenvironments and survival in kidney transplantation, a bibliometric analysis from 2013 to 2023 that is published in Frontiers in Immunology, and it was the first journal who have mostly focused on the in the microenvironment, immunological microenvironment after kidney transplantation. So to explore the research trends related to immune microenvironment and survival in kidney transplantation, and 865 articles they are collected and they are studied between the 2013 to 2023. So the data source here again, Web of Science core collection and tools used: US Viewer, SiteSpace, and Microsoft Excel. So there are a lot of words, but mostly I am trying to say that the topic search, they have used the cytokines, chemokines, etc. Along with the kidney transplantation, they have used these words for search terms. The analysis focus on the research trends, geographical distribution, citations, and co-occurrence. So using these terms, they have found that 2057 articles, out of which they have collected finally the 865 articles for further study. So in their study, they have found the publication trends. The study increase in publications related to kidney transplantation and immune microenvironment over the past decade, and significant growth in 2017, followed by continuous steady increase in publication. This is the geographical distribution. Here, the China is leading regarding the publications on the immune microenvironment and kidney transplantation, followed by USA, Germany, Netherlands, and Japan. And it was seen the top institutions were from the China, that is the Nanjing Medical University. So the hotspots, the macrophages and their role in kidney transplant rejection, TGF-beta and its influence on allograft fibrosis and survival, and antibody-mediated rejection. These were the hotspot research topics in this trend. So the top cited articles reference related to transplant immunology, macrophage involvement and cytokines, and citation burst. That means the one article that was having the multiple citations, that is called the citation burst, that is seen from the papers 2015 to 2021, particularly around TGF-beta and macrophage research. The literature with the strongest citation outbreak is the Banff 2017 Kidney Meeting Report, revised diagnostic criteria for chronic active T-cell mediated rejection, antibody mediated rejection, and prospects for integrative endpoints for next generation clinical trials. This is this article is having the citation outbreak. So from all these analysis or all the scrutiny, they have gathered some information and focus on the macrophage as the promising therapeutic targets for clinical transplantation, and more research and more interests are going on in the publication trends as seen. And also there is also the focus on the TGF-beta, which is having the one of the important role. It's regulating the graft survival. So elevation of TGF-beta will predict the graft survival in kidney transplant patients. So these are also the most important trend. And ultimately the cell-based therapy to boost the immune tolerance and reducing the immunosuppressions, these are among the recent trends as found in this study. So
only the regulatory T cell. The mesenchymal T cells are also getting older in this aspect. Research is renewed. I was giving search that regulatory T cells. It is the basic science, and I was attending the ESOT meeting. At least in the kidney basic science paper, there were 10 among the best abstracts chosen from there. And there are at least 10 research papers submitted work on regulatory T cells from various countries.
How are we inducing Tregs now? How can we use T regulatory cells in practically in transplantation?
We can't.
But they are becoming one of the chosen target to modify the things. I believe, suppose whatever I have seen in my clinical experience, in context of lupus, Treg cells will be very, very important area to consider some new therapy or intervention. Transplant tolerance and acquisition might be. But I believe it will be 100 years job and none of us will see that.
Well, it's the casualty of all
but
many of
in lupus
the
we can see
antibodies we're using in cancer as well, isn't it? So we're getting we're knocking out the Treg compartment in cancer treatment and getting a secondary TIN.
Yeah, might be, but that's not under my clinical purview.
No.
Clinical and theoretical and reading around the immunosuppression issues gives me this input that among the autoimmune diseases that we see in nephrology, this is one disease where Tregs would work. Targeting Tregs would be a very, very important therapy point. Actually, from clinicians, basic researchers has to take this point, then work on, and then bench to bedside should happen. That is not happening.
Kaushik, why is this gender gap still persisting?
Sir, actually gender
it's all blue, there is no yellow there in your slide.
And it's global.
Yeah.
It's global. I was writing.
No, but
I
let's
was,
listen to Kaushik.
Let's listen.
Why do we still have a gender gap? Why is it not 50-50?
I think, sir, it's improving. In the next few years, this gap will be reduced. I think so.
You are hopeful?
Yes, sir. I am always hopeful regarding this.
And the other thing is that, look at this cutting edge research, right? Nanjing University, China. Where is India?
I have gone through this article, sir. Actually, regarding Indian status, it is very low.
Wow.
And up to the among the 200 articles, I have seen only one article was most cited.
Why is that? What are we doing wrong?
Probably, sir, I think that we should have more investments or infrastructure regarding this analysis.
Good point. More part of GDP should be spent on academy. We spend. I was reading a GDP analysis some days back, Devashish. China almost 7%, 6.9 or 6.7. India is very low.
Even less than 2%. Apparently,
So
we couldn't spend the money.
unless that part of GDP is spent on.
Who the person who want to work in this area, they don't still as a they don't get any opportunity to work. Because of that, they are left or other subjects. This is the main point.
There you will find several Indian authors in those from
But
not from Nanjing University but from Harvard Medical School.
Oh,
The
yeah.
published research Indians are there.
Yeah, but they're not in India. What about the xenotransplantation?
Why is that there? Yeah.
I was so excited to hear from was it Massachusetts? They're doing they did their first three.
Which died after 3 days?
No, they're still alive.
Oh,
There's been
sorry.
6 months.
Yeah.
Not the prisoner. No.
Sorry, what?
Xenotransplantation.
So why is that not in your list?
Xenotransplantation, we are knowing the technique.
Yes, there is one Indian. Yes, Tatapuri. Tatapuri is son of one of our nephrologists.
Yeah.
Bashish Tatapuri. He is there in the xenotransplant group.
Yeah.
No. What we're trying to say is that why is that bit not in your list? But I guess you're looking at immune microenvironment, right? So it may not be included.
This was you included it in your last talk, xenotransplantation.
Was it in the top 100?
It was in the second talk.
Actually, sir, most of the studies here, they are data taken from up to 2022. So
after that,
xenotransplantation things came after that. But there are 1 or 2 articles are included, but not properly
No,
focused.
xenotransplant things were being published because several models were being experimented and they were being published. But this very successful xenotransplant that came from NYJ, that was not published before 22. But xenotransplant related things were several primate models, several other models, those were being published. Those were being published from 2015 onwards. I took a lecture on xenotransplant in last I saw. Then I had made a good research into this. So then I saw that the articles were there because people were trying it with preclinical models for a long time. And several preclinical models.
Yeah.
Modifying number of genes or edit. The gene edit numbers were also changing in the the gene edit models, and why this not this primate model, why in shipment, that also took a lot of time to.
No, thank you very much, Kushi. That was very enlightening.
Thank you.
We never thought about journals this way. Tomorrow. So now we have a presentation from
I think he had done a good job. Kaushik. And rather than reading out an article, because so many articles are there, but we can't make it. Yeah.
all articles.
Yes.
Right. What are you going to start?
Good afternoon, respected teachers, my seniors and my colleagues. I'm Dr. Aviruddh Datta and I'll be talking about experience of working in a team that actually brought out a newsletter. So this presentation was originally supposed to be presented by Dr. Mayuri Trivedi madam. She would have been a much more appropriate person, but I would try my best to do justice to this topic. So in essence,
Mayuri is also an alumni of this institute.
so I'm again thankful to Dr. Apida Madam and Dr. Mayuri Madam for giving me this opportunity in joining this editorial team. So when we look at nephrology education today, thanks to all these free open access medical resources, education in nephrology or even in any other subjects have actually broken through the barriers of books or traditional journals, and they have crept into various interactive platforms, be it a tutorial, be it a microblog, blog or a visual abstract, or be it simply hashtagging on specific topics. So this actually has enhanced, what it has done is it has removed the geographical barrier through the knowledge spectrum. It spreads very fast, it's real time that whenever an article is coming out, it's immediately updated, and it gives you a very targeted communication that particular niches which you target, where you want to inform a particular group or a group wants a particular set of information, they get that particular information very fast. It actually helps to build up a community around a particular focal point of information, that a nephrology community which would focus on a specific targeted group, like it would work on transplant, so they can follow a particular group like Paris Transplant Group and get the best of the updates. And it also is a multimodality interactive experience, and it's ever changing. So there is continuous innovation in these models which actually are building up, and thanks to AI, newer and newer generation, newer and newer ways of getting this information are coming up. So this again is a very simple comparison it was again AI generated using a software called Claude, that how the adoption of interactive modalities like newsletters or social media or other visual interactive platforms like Visual Abstract have increased from 2010 to 2025. And if we look at this comparison, it has significantly increased. So where does the position of a newsletter is? Actually, when we look at a journal or an article which is published in a scientific journal, it goes through very stringent, rigorous parameters. It has very stringent protocols through which it has to pass. It can be at times very difficult to access if it's not free. And also at times for students like us or younger students or residents, it can be difficult to approach or understand. Social media, on the other hand, is very free, interactive, gives you a lot of information in a very engaging way, but the only problem is it's not reviewed. So the authenticity can be a trouble. And also there is no per se archival value. It can be, again, you can put it up, you can take it out, so there is no way of long-term storing it. So newsletters in that way maybe come in between, where you have the security of being peer-reviewed or your stringency is managed, but it's much more interactive, much more engaging. You can make much more information or updates in a very engaging or interactive sort of way, and also keep it stored. And that's why probably a combination of newsletters and social media can be a very engaging way of maximizing the learning. So as we were discussing about this, the newsletter in a nephrology education is a need for the hour. And when we look at the Indian subcontinent, almost in all these 4 zones, near about 2,500 nephrologists are working, and every year near about 400 new nephrology residents pass out. So our field is an ever expanding field. However, when we look at Indian Society of Nephrology, the official journal was mainly Indian Journal of Nephrology, which was the official outlook or the official publication. So there was a need for, identified need for a unified platform for ISN members, where we could share the updates or our insights or our academic work in a much more easy sort of way, which could be very easily accessible. So this actually gave rise to the idea of formulating a newsletter, and the kidney columns was formed. The logo and the highlight and the tagline was generated by the editorial members, and this is the official newsletter which comes out from the Indian Society of Nephrology in a quarterly fashion. So our first edition came out in May of 2023, and the editorial team actually was distributed uniformly so that all the zones have uniform participation in forming a editorial team which would actually look after that. Just briefly talking about the segments, in the first edition which came out, the idea was that the editorial team members would invite senior consultants or senior professors who are working in a particular specialty or a particular set of disease group to get the updates from them, to get some engaging materials from them, and then we would modify or generate an abstract about it and publish it in the newsletter. So articles by the consultants, a very solid and a very constant part was a residents' corner, in which the residents would actually talk about or give description about challenging cases they have faced or cases which they found very interesting. And to keep the entire discussion interactive, we had a constant segment of quiz and crosswords, which again, and finally this being the crosswords and the quiz obviously were always based on the theme. So every article or every segment of newsletter was based on a particular disease, and that particular disease would be covered by the articles from the consultants, as well as the quiz, as well as the crossword. And to keep the members updated from what is happening in Indian Society of Nephrology, all the updated messages would be a constant part. So just the editorial process and the workflow in this was, the team used to meet, discuss, decide about a topic which would be much more relevant, and after that we would resource out or we would fan out to search for contents about the newest articles which are coming out, and take consideration about Indian articles which are coming out in that particular journal, and approach the authors in that particular segment that whether they can give us some kind of material or some kind of, what I would say, précis about what they have done. And also we would collaborate with other residents who would like to contribute materials like visual abstracts or the cases, and after that, after the review of that, it would go for a final publication. So the main challenge which we used to face in this particular phase, that whenever we are working with a multiple team members or multiple people, there is always a problem of following through the deadline, and also have to have a clear-cut communication. So a multi-pronged approach and an advanced planning and multiple meetings, team meetings, actually helped us to keep a very clear-cut path. So I had a good fortune of working with this newsletter in 3 ways. When I was a resident, I was looking after the resident section as a resident editor, and I was mainly communicating with other residents in the same group, collecting materials from them or asking about cases from them. And then once I passed out, I was not a member of the editorial team, but I got associated or was continuously associated as a contributor, and then I was again invited back as a junior editorial team member. So the idea behind formulating a resident section, which principally was to actually engage more and more participation from young residents or young nephrologists, to increase interaction between all these members, so that they would know that someone else like this, someone has seen a case like this, so other people would interact, to motivate them to work further and update themselves, and to give them a platform to showcase their creativity, at least whichever they are not, even if they are not nephrology related, and also to increase awareness. So working on this section, actually it helped me to develop a lot of network, and in this developing this network, media platforms like WhatsApp and Telegram was very crucial, and I am very thankful to my colleagues Dr. Gopamboj, Dr. Hardik, Dr. Pallavi, who had actually developed a very good platform of young nephrologists, through which I could actually collect a lot of material and communicate with a good lot of other budding nephrologists. And again, this was again a good platform to highlight the interesting cases. Our exposure to visual abstracts. Visual abstracts are nowadays a very key part of any kind of good RCTs, to give you the summary of the information in a very crisp sort of a way. And a lot of programs like Nephrology Social Media Collective, they work on skill enhancing in young nephrologists on how to engage others or how to develop a visual abstract, because it's a time-taking skill process. So this particular platform actually promotes, or what I would say, we invite young members to draft any kind of a visual abstract, give a try, and then we try to correct it and slowly it has also helped me to hone my skills in developing visual abstracts. Like this was a visual abstract done by another resident in South India regarding the fungal infections in SOT patients in South Asia. And apart from nephrology, it was a platform for any kind of a creative thought any resident would feel free to share. Like residents thought about having a successful transplant, a poem which he wrote, or any kind of a cartoon, whatever the resident would like to highlight or show. And this again also worked as a platform to show solidarity and make a stand whenever there was some kind of injustice towards the resident doctors or doctors. Like we had a very gruesome incident happening in Calcutta. To highlight that particular thing, we kept the entire presentation minimal, and this art form which depicted the particular incident was again contributed by a resident, and we used this to deliver a message of solidarity. When I was a contributor again, I got the opportunity of engaging with senior consultants. I wrote about role of sparsentan as well as on how ISN had helped me in growing up as a nephrology fellow. And coming last to my role as an editor, where I currently am working, and I mainly work on designing and the appearance, creative appearance of this particular newsletter, and it has helped me to showcase my interests. Like this newspaper is something which was a part of my childhood. I grew up, I was getting the newspaper almost daily at home. So our initial presentations of or the appearance of a newsletter, of a heading would be like this. But I worked on it, tweaked a bit, and I developed something which would look like this. So whether it gives you a nostalgic view of a newspaper. So after that, we also have worked on engaging two other segments, like the biostatistics, which is very difficult, at times can be very challenging. So something in which we can make it much more user friendly. So a segment known as StatsGyan was added, and nephrology is intangibly related with the patients. So the patient's perspective is also very important for a nephrologist to know, and that's why we set up a segment known as the patient's perspective, in which ESRD patients as well as other particular renal transplant patients get a platform to highlight their experiences. So far we have 10 volumes which have come up, and we have journeyed from this appearance to this. And initially when we were having around 20 printed issues, which is again subscription based, but it's free. It's free of cost, only you have to apply for a subscription. We currently have more than 150 subscribers for which we have to print. Our engagement in Twitter, we have an official Twitter handle which has increased significantly, and people do acknowledge. Any positive feedback feels good. We are currently trying to go green, and we are trying to limit our paper publications, and we promote digital subscriptions only, where we freely dissipate our newsletters through all the medias and the WhatsApp groups, as well as whatever the social media platforms ISN has. And our future direction is mainly to engage more and more global reach, to corroborate and participate with, engage with other societies, and also to form a very democratic leadership. There is this particular role of our editors are rotating, and we keep very transparent meetings so that we are not per se stagnated with any kind of direction. So this has been a very good learning experience for me in terms of developing my communication skills, to help me generate whatever editorial sense I have been able to develop, has helped me enhance my teamwork and networking skills, organization skills, and also it stimulates me for continuous learning. So that gives you a good lot of satisfaction. So with this, I would like to conclude, and I'm again thankful for this opportunity and giving me a platform to highlight my thoughts regarding this. This QR and this URL is for the official site, if anyone would like to go through the newsletters. Thank you.
That's so good. That's really nice. Oh, can you put the QR code back?
Yes.
what happens when people come of age? Do they and become senior? Do they just leave it behind?
So so far we have actually, when I was a resident, when I passed out, I got removed from the team. Actually, two other people joined in, and then people show interest. So it's on a voluntary basis. So they ask for people if they are keen to participate, and once they participate, we have a rotating role. So currently we are a 8-member team. And we are supposed to hold that post for a particular role for around a period of 2 years. It's just 3 years old, so that rotation has not happened. But mainly there are 2 chief editors, Dr. Mayuri Trivedi and Dr. Sanjeev Nair, and the 6 of us are junior editors. So hopefully once this year crosses, then probably there will be a shuffling of the roles. And new other people from the
Mayuri was telling me that she now wants to give the responsibility to someone else.
There will be a rotation of the role.
And then you'll be senior Indian starting apology numbers.
Hopefully, let's see.
It's excellent. I think in an age of social media, trying to engage your peer group in your learning, in your interpretation is a real challenge. People have a concentration span of the length of a TikTok video. And anything longer than that, then the nuance is lost. So you have to make incredibly, for all of our patients that we talked about who are so complicated, and each of our short cases was not a TikTok length video, it becomes very complicated to get one's head around. So finding ways of engaging it so that everyone is enthralled, as we were talking about, speakers who could enthrall us for an hour with no slides.
It looks very nice, and it actually fits on my screen.
So that was the
It's automatic. So any screen it'll fit like that.
So that modifications we did for the last issue. The last issue was designed by me. Prior to that, it was being done from Nancy.
No, I'm sorry, I was just showing totally that it really fits into the screen very well.
I think I have seen the last issue, membranous nephropathy one. This one I have not shown. This is the membranous nephropathy one.
There is something about membranous nephropathy.
Yes,
it is about membranous.
Yes, usually I see, have a look at the kidney columns.
And it looks like an old newspaper. I don't know about the Statesman, but it looks like an old newspaper.
So that was the theme which I wanted to highlight.
Yeah, that was also in my
and
dad's house. That was a regular thing that used to come.
Oh.
See it? Don't like this crossword very much.
And page 3, the editorial and the editorial's side articles, those used to be very rich for language learning and content writing. So my dad used to ask us to go through that page.
Oops. It's very good. Well done. It is actually very nice.
I do like how it all fits on one screen.
It's just
yeah.
You don't have to go like this.
প্ল্যানটা ভালোই হয়েছিল অনিরুদ্ধ, হ্যাঁ বলার জার্নাল আর্টিকেলের সঙ্গে এটা একটা জুড়ে দিয়েছিলাম যে এটা তোমাদের ভালো লাগতে পারে। Ria, you have started understanding Bengali. My last sentence was in Bengali and Ria nodded.
Come up, like my batchmates are there, my juniors are there. People actually develop this skill. Only thing we have to be interested, because something which we push through, we learn as we go.
Yeah.
This was not something I was fluent in maybe a year back.
It's yes, having the next generation, inspiring the next generation is something you're constantly having to do at every rate. So all of my colleagues who are retiring are saying, oh, who's going to take this on?
Probably we are going to finish.
No, we have to have lunch.
Yes, you will. No, talks are finished. Ria's job is to be done.
Oh yeah. Ria's talks are
Lucky and Anybody of you? Nick wants to see the ward. Vivek, you may accompany.
So we'll go and see the word in 5 minutes.
Yes, yes.
Before lunch.
You come back.
While lunch is
I will
First time prayer
look at your nurses assembly here and
yeah.
I will do that, and after that I will not take lunch.
Yeah.
I will leave
Yes.
because of this puja event. I may be excused today little early.
Yes.
Because if I go, I can help my mother-in-law in cooking. Yeah.
Yeah.
She turned 80 yesterday.
Oh, wow.
Yesterday I entered with cake.
Yeah.
Yeah. And 8 candles to celebrate her birthday shot.
There should be flexibility. In other words, part-time work. Right, so what's next?
Next is lunch.
Next is lunch.
And after lunch, the nurses session.
Is Ria ready?
Ria is getting ready. Yeah.
Should we quickly have lunch and come back?
Ria, sure. Ria, join us in lunch.
জানি না আমাদের কারোর সঙ্গে দেখা হয়েছিল স্যার সরি আমি 3 বছর আগে এসেছিল হয়তো আপনারা কেউ দেখেও থাকতে পারেন আরেকটু শরীরটা রোগা মতো ছিল হয়তো শুনতে পারবেন
ডক্টর পাল ছিলেন বোধহয় তখন
3 বছর আগে
হ্যাঁ ডক্টর পাল ছিলেন
প্রফেসর লিকে পাস নিউরোলজিস্ট
হ্যাঁ ওনার সঙ্গে দেখা হয়েছিল ওনার ঘরেতে হ্যাঁ না মনে আছে আর আপনাদের সবার সঙ্গে দেখা হয়েছিল আর একটা ঘরে একটা সরু মতো ঘর।
হ্যাঁ সরু মতো ঘর ওইখানে নেই কোথাও
আপনি ছিলেন না তো এনারা ছিলেন না সো আমি একজন কিডনি ডাক্তার মেইন যে আজকে আপনাদের সঙ্গে কথা বলবো সে হচ্ছে রিয়া রিয়া হচ্ছে আমাদের নার্স আর আমার পেছনে রয়েছে আমার আরেকজন বন্ধু আমাদের এই হাসপাতালের ডাক্তার নিকে নিয়ে তো আমরা ওর যদি কিছু দরকার হয় হেল্প করবো ইত্যাদি কিন্তু আপনারা যা কিছু শুনবেন ওর কাছ থেকেই শুনবেন ও শুরু করার আগে আরেকটা জিনিস বলে নিই যে আমাদের হাসপাতালের সেট আপটা কীরকম আমি আগেবারও বলেছিলাম এবারও বুঝিয়ে দিই তো আমরা হচ্ছি ছোট্ট একটা ইউনিট লন্ডনের সাউথ ওয়েস্টে আমাদের হাসপাতালটা বড় কিন্তু কিডনি ইউনিটটা ছোট হাসপাতালটাতে 1100 বেড আছে কিন্তু কিডনি ইউনিটে মাত্র 18টা আছে ঠিক আছে মেল ফিমেল দুই মিলিয়ে ট্রান্সপ্লান্ট হয় 150 থেকে 180টা তার মধ্যে 50টা মতো লাইভ ডোনার বাকি সব ডিসিজ ডায়ালিসিস আছে আমাদের ওই 18 বেডের পাশেই একটা ছোট্ট ডায়ালিসিস ইউনিট ওখানে 6টা স্টেশন আছে দিনে 3 বার করে ডায়ালিসিস হয় এখানের মতো অতগুলো স্টেশনও নেই আর দিনে 4 বার করে ডায়ালিসিস হয় মাঝে মাঝে হয়তো রাত্রিবেলা ডায়ালিসিস দিতে হয় যদি কেউ অসুস্থ থাকে সারা হাসপাতালে এবং অন্য শুধু অ্যাডমিটেড পেশেন্টদের ডায়ালিসিস তো রিয়া আগে ডায়ালিসিস নার্স ছিল ও তখন ওই ডায়ালিসিস ইউনিটে পোস্টেড ছিল ঠিক আছে ওটা হলো ডায়ালিসিস ট্রান্সপ্লান্ট তো বলে দিলাম ট্রান্সপ্লান্টের আরেকটা জিনিস আমাদের আপনাদের সঙ্গে একটু তফাৎ আছে সেটা হচ্ছে যে আমরা যখন ট্রান্সপ্লান্ট করি পেশেন্টরা সোজা অপারেশন থিয়েটার থেকে ওয়ার্ডে আসে ওয়ার্ড থেকে যায় ওয়ার্ডে ফেরত আসে আর কোথাও যায় এরিয়া বা অন্যান্য নার্সরা ওদের দেখাশোনা করে কোনো আইটিইউ নেই কোনো এইচডিইউ নেই কোনো বিশেষ কিছু নেই যেরকম কিডনি ওয়ার্ডে সে কিডনি ওয়ার্ডেই ফেরত আসে ঠিক আছে সেটা আর একটা জিনিস মনে রাখবেন কারণ আমাদের এখানে একটা আলাদা ওয়ার্ড রয়েছে ট্রান্সপ্লান্ট এইচডিইউ আছে আমাদের এইচডিইউ নেই এক নম্বর 2 নম্বর হচ্ছে যে আমাদের হ্যালো ও দে নো সরি 2 নম্বর হচ্ছে যে আমাদের সার্জনরা এবং সার্জিক্যাল নার্সরা নার্স তো একই রকম সার্জনরা ডাক্তাররা আর নার্সরা একসঙ্গে ওয়ার্ড রাউন্ড হয় সব ট্রান্সপ্লান্ট পেশেন্ট প্রত্যেক দিন সকালবেলা সোম, মঙ্গল, বুধ, বৃহস্পতি, শুক্র, শনি আর রবি 8:30 থেকে 9:30, কখনো 10টা, 10:30 অবধি। সুতরাং সব ট্রান্সপ্লান্টেশনকে একসঙ্গে সার্জন এবং নার্স এবং ডাক্তার থাকে। তাদের সুবিধা হচ্ছে কি, তারা বুঝতে পারেন যে কোনো হঠাৎ রোগীটা যদি খারাপ হয়ে যায়, যেহেতু রোজ দেখছেন, বুঝতে একটু সুবিধা হয়, তাড়াতাড়ি সুবিধা হয়, সেইটা একটা তফাৎ। আর কয়েকটা জিনিসের তফাৎ আছে, যেমন ধরুন ইউরিন ক্যাথিটার। তো আপনাদের ইউরিন ক্যাথিটার কদিন থাকে পেশেন্টের? আমাদের 3 দিন, তৃতীয় দিনে বের করে দেওয়া হয়। পনেরো দিন। কদিন? 3 দিন না 5 দিন? 5 দিন। সেটা আমরা একটু তার ক্যাথিটার তাড়াতাড়ি বের করে দিতে চাই যাতে ইনফেকশন হয়। আর আমরা যে ইমিউনোসাপ্রেশনের ওষুধগুলো দিই সেটা আমাদের থেকে একটু কম। যেমন এখানে আমাদের ATG দেওয়া হয়, আমরা দিই না। Did I get that right? You give ATG, right? Which of? For deceased donors, right? For deceased donors we give only Bacillus. সেটা একটা তফাৎ, ঠিক আছে? আর তফাতের মধ্যে আমাদের ডায়ালিসিস এবং ওয়ার্ড, মেল ফিমেল সব মিলিয়ে 18টা বেড এবং ডায়ালিসিস সব একসঙ্গে। সুতরাং নার্সদের দৌড়দৌড়ি করতে হবে এবং নার্সের কস্ট কভার করতে পারে। যেমন ধরুন ডায়ালিসিসে কম লোক হয়ে গেলে আপনি ওয়ার্ড থেকে একটা সিস্টারকে ডায়ালিসিস পাঠিয়ে দিতে পারবেন, এবং ওয়ার্ডে যদি কম হয়ে যায়, ডায়ালিসিসে বেশি লোক থাকে, সিস্টার খুবই কম হয়, ওখান থেকে এখানে সরিয়ে দিতে পারবেন। সেইটা একটা ভীষণ ভালো জিনিস, কারণ সবাই একটা ফ্লোরে একটা জায়গায়, বুঝতে পারছেন? সেটা একটা ভালো জিনিস। আর একটা জিনিস যেটা বুঝতে পারছেন তফাৎ, সেটা হচ্ছে যে আমাদের যে পেশেন্টরা ট্রান্সপ্লান্টের আগে দেখে, তারা নার্সকে অনেক বেশি দেখে ডাক্তার থেকে। ডাক্তারকে হয়তো একবার দেখলো, নার্সকে হয়তো 4, 5 বা 6 বার দেখলো, এবং যখন ছুটি হয়ে বাড়ি যায় তখন হয়তো ডাক্তারকে কম দেখে, নার্সকে বেশি দেখে। সুতরাং নার্সদের এক্সপিরিয়েন্সে পেশেন্টদের থেকে, পেশেন্ট ম্যানেজারদের বেশি থাকে, এবং কিছু কিছু নার্স প্রেসক্রাইবও করতে পারে, যেমন প্রফেশন ইত্যাদি, বল বদলানো ওগুলো করতে পারে। সেটা একটা বিরাট কথা, সেটা হয়তো বুঝতে পারবেন ও যখন বলছে। Priya, hand over to you. I have kind of introduced you, but you can introduce yourself.
Okay, that's fine. Thank you. So good afternoon, everyone. My name is Surya, and I'm the lead nurse for renal transplant services at St. George's Hospital in London. We have the next probably 2.5 hours this afternoon, so I'll give a brief introduction of myself so you get to know me a little bit and why am I here, what I'm going to talk to you about. And we have 5 topics to cover, and motivating patients in the context of engaging them in their transplant workup is one of them. So, first of all, it is truly an honor to be here, to be with you today, and to be invited in the ISN TTS conference here in Kolkata. So it's a great privilege for me to share our experience in London, in the UK, and hopefully you can pick up something from this afternoon. So we're gonna make it like welcome. An interactive one. If you've got your mobile phone, later I'm going to ask you, we have a QR code you can scan, and we'll do the Mentimeter in between the sessions. There's no right or wrong answer, it's just for us to know what you practice. Okay, so as I said, this is our first topic, and the aim of this is to explore the barriers that patients face, as well as how we can motivate them. And if motivation is effective, what are the benefits of it? So, as I mentioned, I'd like to introduce myself first, because in order for us to motivate our patients, it is obviously good to know, to understand what motivates us as professionals. Sorry, technical difficulties.
Yeah, can they ask questions in between? Would you mind?
Yeah. Yes.
যদি আপনাদের কোনো প্রশ্ন থাকে সঙ্গে সঙ্গে জিজ্ঞেস করে নেবেন আমি এবং ওরা যদি বুঝতে অসুবিধা হয় আমি বাংলা থেকে ইংরেজিতে ট্রান্সলেট করে দিতে পারবো।
Right, so here is my career journey. I have started working in St. George. So originally I'm from the Philippines. I arrived in the UK in 2000 when I was 23. And so you can guess my age. Yeah, so I arrived. Oh, sorry, how do I use the pointer?
Pointer.
Oh, there. Okay. So yeah, so that's me under the arrow there. There were 28 nurses that arrived on that day from the Philippines, and there's 4 of us who were employed in the renal department at that time. So before we have, even though we're registered in the Philippines, when we get there, we're not considered as registered nurses. We were paid at band 2 or like a HEA. I don't know what's the equivalent here, but it's the healthcare assistant until you complete the adaptation course. So there's a 6 months period where we have to complete the assessment, competency assessment, until you get the registration to the NMC, which was before the UKCC. So that's the nurses professional regulation. But I completed mine in 2 months, and I was one of the first 2 nurses who have completed it in a short time and registered as a nurse. So that's I am there. After 2 months, when starting in 2000 as a registered nurse, and I progressed my career after that. In 2002, I became a senior staff nurse, so 2 years after, and then in 2005, I became the junior sister of our renal ward, and then 2007, that's where my journey started in the outpatient, the renal transplant area. So that's a pre-transplant where I have been a transplant coordinator for 11 years. The first 6 years of that, it was concentrated more on doing both donor and recipient workup. And in 2013, I have taken on a secondment post, an opportunity for 6 months to lead a project. So I was the education sister. AKC is what we call for the pre-dialysis patients. So that's the clinic, that's the team that look after the patient before they start dialysis. So I was the education nurse then, and I embedded the patient decision aid project along with Dr. Shrivastava at that time for half a year. And then following on to that, I went back to transplant clinic as a transplant coordinator again, but this time focused on the recipient workup. And that led me to having more time in doing projects that are related to the recipient workup. So like leading quality improvement projects, doing audits, what could our workup do better to help our patients and streamline the workup pathway as well. And then, there we go. In 2017, late 2017, I was asked by the service to help the post-transplant team. So for the 11 years, I was on the pre-transplant side, and then I was asked to help the post-transplant clinic to manage it. So supposedly for 6 months, but I ended up for 2 years. And then after that, I also here, I also led, developing and establishing the nurse-led clinic for transplant follow-up in the community. And then in 2019 until now, I am the lead nurse. So they created this post, which is the lead nurse for renal transplant services. So that's leading and managing the whole nursing transplant services at St. George's. So that covers the pre-transplant and the post-transplant team. And I was one of the first 2 nurses in St. George's to have completed the Chief Nurse Research Fellowship. And that was in 2022-23. And last year, I don't know if Prof.
No, I just no.
Okay.
I also wanted to just mention, Mia has 2 little daughters, right? They're not little anymore, they go to university. So whilst doing all of this, managing a busy life as a mother, etc., you can see how much Ria has achieved. I'm really proud of her. She was the British Journal of Nephrology Nurse of the Year last year, 2024. It's not just that. The Chief Nurse Fellowship, she did a postgraduate certificate in research as well, which she doesn't do, which hurts my feelings a little bit. So she's not doing much research, but she could. She could do some research as well, right? And all these audits has really helped progress our pathways. For example, our cardiovascular workup pathway was very long, and she shortened it so that people get the workup much quicker. She developed personal relationships with cardiologists, cardiology technicians. She would go there, she would stand in front of their room till they gave the date for the echocardiogram, till they gave the date for their angiogram. She made sure those things happened. And as she developed more and more initiatives, more and more personal connections, more and more all of these audits showing how it helps the patients, the service developed. So I'm really, really proud of her. Thank you.
Thank you, Prof. In 2022, I was also asked to, like a contributor for the renal, that's a long one, RSTP. So it's what's the Renal Service Transformation Program. So it's a national program where I was asked to help with streamlining the transplant workup pathway. I love doing pathways. They call me Miss Pathway in our clinic. Yes, and also a transplant collaborator for the London Kidney Network, and the nurse representative for the UK Kidney Association post-transplant, post-kidney transplant guidance group. And from last year, I have been appointed as a national co-lead for the transplant community of practice under the Association of Nephrology Nurses in UK. And also one of the core groups of the Philippine Nurses Association. And, oh, this is not moving. My screen is not moving.
Yeah, it's moving.
No, not here. Okay. Okay. Okay, so moving on. With the experience that I've just mentioned earlier, this has opened opportunities for me to lead quality improvement projects and enhance and explore my clinical academic career, leading these different quality improvement projects that Professor Banerjee have mentioned earlier. We've submitted abstract, which has been accepted and presented to different renal meetings from local, regional, national, and international meetings. That included the ISN Frontier meeting in Japan, where our poster was awarded one of the top percent ranked poster award at that time with a golden ticket there. And I've also had a couple of publication as one of the first authors along with Professor Banerjee, and this was published last year, and this was last June, where I was invited as the first Filipino recorded speaker at the UK Kidney Week. Okay, so sorry for the intermission. So this was the BJN, or British Journal of Nursing Awards night last year when I was when I received the gold award for the renal nurse of the year. And this was my publication last year as a BJN winner. And every time I'm invited to do a talk, share my experience, I always want to, at least if I could inspire one nurse, I would be very happy. If I can inspire everyone, that's even better. So I have written about inspiring nurses to lead on quality improvement projects to deliver excellent patient care. And so I've introduced myself. I will just introduce my team as well with you. So as I mentioned earlier, I lead pre- and post-transplant team at St. George's. So that's me there on the top, and that's me with my Navy uniform. So for the pre-transplant, we have Sindhu, who's our recipient coordinator, Janice, who's our living donor coordinator, and Rojin, who works between the two sisters. And they have Ronali as their clinic assistant. And then for the post-transplant, so patient after they've had a transplant, been on the ward, and then discharged, we see them in our transplant clinic, post-transplant clinic, and that's Chrisma, who is the manager or the clinic sister, and Shiva, who is the senior staff nurse, with Babs, who we call her Mama Babs. She's our mom in the clinic, and she's our phlebotomist. We also have HCA, or healthcare assistant, and Lydia, who is our receptionist. It's a very small team, but everyone has got specific roles. So if one is away, especially for the nurses, we can't just get someone from the staff bank to cover it, unlike on the ward. So usually I cover the nurses when one is away, or we help each other. So what does our service provide? So we do the assessment and coordination for the coordination of tests for patients being considered for donor and recipient workup or recipient transplantation, activation of patient on the transplant waiting list, and then monthly surveillance for patients potential for transplant, and we also do the review of the donor workup, organizing live donor transplantation, donor follow-up, post-transplant follow-up. As I mentioned, we have a whole team who follows up the patients post-transplant. We could provide continuous education and support our patients for give them emotional and psychological support. This is my role in a nutshell. I'm not going to bore you with all that, but that's not all of it. And right, so now let's focus on motivation. Professor Banerjee has given a good introduction of like how I've come to this far of my career, and I could say that I am a really motivated nurse. Doesn't matter if I'm an overseas nurse, especially at that time. I worked my way up because I love what I do, and I'd like to help our patients when I was a coordinator, to help them get on the waiting list and get transplanted. And if we're motivated, we'll be able to motivate our patients as well. So why does it matter? Well, motivation matters because it directly affects engagement. When patients are motivated, they're likely to attend their transplant workup assessment or transplant workup appointments and getting on the waiting list sooner rather than later. And of course, when they are motivated, it leads to they get listed on the waiting list faster, and ultimately better outcomes for both in terms of the survival and quality of life. But it's not always easy. Patients do have barriers that we could consider in their transplant workup pathway. And some of these are patients who doesn't fully understand what are the tests for and why are they needed. Other that may have fears or misconception about the transplant process itself. And many deal with practical challenges. Say, for example, transport, work, family responsibilities that make it harder to engage. And there is one that is, very simple, but it can be used as empowerment, which is an education. So when we explain things clearly to our patients, even in simple words, these help them empowered rather than like being overwhelmed with the information. It also helps if we get their family involved and to have a supporting network when they get home. We also should encourage patients to ask questions for open discussion and give them education. Like for St. George's, we run a quarterly transplant information program. So this is an evening of education where we invite patients and their relatives and potential donors to give them education. I'll show you some pictures. There are some pictures there later about that program. I have also created this leaflet, which is sort of like a checklist for patients being considered for workup. There's a donor version of this as well. So when patients referred for workup, the transplant coordinator gives this, and it has got a simplified version of the 18-week pathway to tell them exactly from the time you were referred, what to do next, and what to do next. That will help them know where they are in their workup. The middle part of it are the list of tests that they're going to do. Not everyone will have to do all of these tests. It depends on their stratification. But we will highlight the ones that they need to do, and then we ask them that when they get home and they receive the appointment letter, to put down the dates here, and then once it's done, to tick on this side so that they know, oh, I've completed all my tests. What's the next step? Let me call the nurse. And here, we've got the contact number of the nurses as well, so that they are empowered. They know where they are at their workup, and they can contact or text the transplant coordinator, and the transplant coordinator do the same thing. So that, and I've also put a picture of our other leaflets that we give to our patients so that they are, giving information helps them understand what they're going through. And there was a QR code given earlier. So if you scan that QR code, that is this. So this is our, it's a booklet. It's about 67 pages.
Yes, it's here actually.
Yes, so that's our
scan code.
yeah. At the moment, it's only in English. And all this information, we also give them like information about the immunosuppressions that they will take, ureteric stent removal after the transplant, give the information about urinary tract infection as well. After transplant is very common. And on the top here are information about when they're called in for transplant and expectations about the deceased donor transplant that they may get. So, what are the strategies to motivate the patient? So, I put down here personalized education session. What it means is that, of course, we know our patients. When you talk to them, you know if they're grabbing everything. Some patients are techie, IT tech. You can just ask them to scan this and you can read it at home. Some patients will probably need a paper copy of the information sheet. So it varies. But for us nurses, we know our patient, and you can tell whether they're engaging or not, or maybe it's too much information, then you stop. You don't give all the information at once. So we tailored it according to the patient's needs. Now, for us, when the patient is referred for transplant workup, the coordinator rings the patient and start the workup. So with that phone call, we gather information, assess the patient, and find out what tests they need to do. So we explain and tell them. And if, say, for example, language is a barrier, then the coordinator can arrange for a face-to-face appointment in the clinic, and with the presence of an interpreter. But sometimes there are someone at home who can help them translate whilst on the phone, and we can do that as well. So giving them regular updates of the progress of their workup is another strategy to motivate them. Celebrating milestones. So say, for example, they've completed all their cardiac tests, which sometimes is the longest test to get. So giving them a ring or texting them to say, oh, now you've completed it, the next step is this. So just to have that engagement with them. And we can also share some success stories of other recipients that could be, give hope and inspiration to other patients. And of course, it's always about partnership. It's not just us telling them what to do. It's to have that relationship and trust, that compassionate and empathetic communication to get their trust and believe in what we do, so that we can have that patient staff or patient-nurse relationship. And the role of the team, so just have to drink. So the role of the team, well, as we know, motivation is not down to one person. It's not down to one nurse or one doctor. It's for the whole team. There's doctors, nurses, transplant coordinators, psychologists, dietitian, pharmacists, even social worker. Everyone works together in order to have that engagement, keep that patient well informed, so that they will engage with the workup or with the care that we provide. And we always say be approachable. I've mentioned that we have we've got a mobile phone for the coordinators where the patient can just text, because sometimes they don't want to pick up the phone, but they will text. So they can text, they can ring, and vice versa. The nurse uses that as well as one way of communication. Some patients prefer if you send them an email, aside from clinic appointment letters. Also providing emotional support and practical support to patients. That will then create that belonging and trust. And if motivation works, then you get better engagement in the transplant workup. They get listed sooner rather than later. They will be engaged more in their health, so they'll probably attend all the appointments. If they miss, that could be because of something important, and they would just ring and say, oh, I'm not able to make it, can we rebook it on another day? And if we have that motivated patients, then we have greater satisfaction with care, and vice versa. The patients are happy and we're happy, everybody's happy. So just to take away, I've mentioned earlier, motivation is from education, empowerment, and partnership. Regular updates and encouragement is very important. And we know that patient engagement improves outcomes. And a motivated patient is an active patient, informed and hopeful patient. So if we close this topic, motivation is the spark that turns intention into action. Okay, so if I could please ask you to take out your mobile phone and we'll just scan if this will work.
So you have some mentimeters?
Yeah.
উনি একটা মেন্টিমিটার স্লাইডটা ব্যবহার করবেন, তো আপনারা যদি কিউআর কোডটা করেন তাহলে উনি যে প্রশ্নগুলো করবেন তার উত্তরগুলো দিতে পারবেন, মানে সবই ওখানে থাকবে, কেউ বুঝতে পারবে। এই কিউআর কোডটা নয়, ওখানে একটা নতুন ওয়ান, এটা কি?
This one. Okay, so for our first question,
No, hold on.
I'll just read it.
It's taking some time.
First question is, what one word comes to mind when you hear patient motivation?
লিঙ্কটা ক্লিক করে দিন।
Remote use. আমরা একটা
স্ক্যান করে একটা লিঙ্ক আছে, লিঙ্কে ট্যাপ করে দিয়ে এই মেন্টিমিটার বলে যে পেজটা আছে।
আসছে তো কোশ্চেনটা বললে এখানে
Sorry, give me 1 second.
ওখানে যেটা শো হচ্ছে সেম কোশ্চেন।
Scared when they hear patient motivation.
Yeah.
Oh, okay,
Number is
yeah,
also
yeah.
saying here.
Well, look, 2 out of 11 responses.
2 out of 11 responded.
আরো বেশি রেসপন্স মাত্র 2 জন রেসপন্স করেছে।
Okay, so what one word comes to mind when you hear patient motivation?
Scared.
Scared. What does ES mean?
Very scared.
Extremely scared. There's no right or wrong answer, just one. Oh, the scared is getting bigger. There's 2 of them scared. I mean, when we were talking about patient motivation earlier, what are the things that sort of like that you can relate to patient motivation after the discussion? Education. Perfect. Yes. Yes. Education about patient. Yes. So we've got 5 people who answered now. I'll do a countdown so we can move on. Education. Education. So I think you got the message that in order for us to get our patient motivated, we can do this by giving them education, giving them information. Because even if you put ourselves into their shoes, if you don't know what your condition is, you're scared. And how can we break this feeling of scared and fear? It's to get that information. And it's not just by one person, as I said, it could be the nurse, the doctor, the rest of the team. But because we as nurses are at the front line and always there next to our patient, then we can help them. Yes. Okay, let's move on. The next question is, which of these is the biggest challenge in motivating patients for transplant workup? You can just choose one and then we'll see. So we have lack of understanding, fear of the process, complex medical requirements, family or social barriers. We've got someone who said it's family and social barriers. There's no right or wrong answer. Actually, all of these are biggest challenge to the patients, but then we'll see what you think.
Fear of the process.
So I guess with the fear of the process, as we said earlier, if we educate them, if we get them involved, give them empowerment on their workup process, or even not in the transplant, just on any of the care, then you get their engagement. We had someone earlier in the case study where the patient knows all his creatinine creatinine levels every day. It's just amazing. We were talking like even the point. What was it? 1.72, 1.73, even the point they remember. So this is really good. And you did that. You connected to the patient. They know. Because if they know where they are at, then they will participate with the care. They will know, like, okay, I want my creatinine to go down. What do I do? The nurse says I should do this, then I will follow this. So you get that relationship. Okay, we'll move on to the next. What's one thing you will do differently better, or to better engage patient engagement after today? Just one word, type it in, and anyone?
I think there's a little lag between
Oh, go
the
with it.
response and the mentality. It takes a bit of time. Here's your response, education.
Yeah, I can hear your response, but it's not going there. Which is good.
It's education.
Yes. Okay. Shall we skip the mentimeter? Because
All
it's
right.
gonna.
I'm sorry.
No, I'm just thinking because it's gonna.
Look, teach patient.
Oh.
So it
Okay.
takes you time to come up.
So teach the patient, education motivation. Yes, okay, I'm happy, you got the message. Right. Are we okay? Do you have any questions on that? If not, we'll proceed to the next topic.
কোনো প্রশ্ন কারণ? No.
No? Okay. Oh, look, some more on the more answers on this question number 2.
I was saying it just takes time.
Yeah. It's not coming out. Right. Sorry. It is. To our next topic, which is what and why vaccination in renal patients. No, we just good. It's moving now. Yeah. Okay, so renal patients and those with advanced chronic kidney disease, patients on dialysis, and post-transplant are at much higher risk of serious infections. And vaccine-preventable diseases in this group of patients often lead to hospitalization, complications, and worse outcomes. So using vaccination as a preventative strategy is both clinically beneficial and also cost-effective. With the declining kidney functions, immune dysregulation occurs. And after transplant, immunosuppressive therapy further suppresses the immune system of our patients. So as a result, vaccine-induced immunity may be weaker. So the timing and the vaccine type becomes critical. And we must remember that live vaccines are generally contraindicated for immunocompromised patients, such as post-transplant patients. The ideal window, so timing and frequency is very important because the ideal window to vaccinate is before the patient becomes immunocompromised, ideally in late CKD or pre-dialysis. For transplant candidates, we try to complete the vaccination before transplantation if possible. And different vaccines have different schedules and booster intervals. For example, influenza is every year. Hepatitis B may require multiple doses. Pneumococcal vaccines, like usually every 5 years. And again, because of the timing, if we're gonna give live vaccination, we aim to do it before the transplant or before the patients get immunosuppressed. So now we'll review the key vaccines that we should prioritize for this group of patients. And these are aligned with the data from the UK, from the kidney.org and CDC recommendations. So let's start off with chickenpox or varicella. So for adults with advanced CKD or on dialysis, 2 doses are recommended, and it's given between 4 to 6 weeks, 4 to 6 weeks apart on people who meet this criteria, all of the following. But for our transplant patients, we don't advise this. Why? Because it's a live vaccine. So we've mentioned about the timing earlier. So if the patient is considered for transplant workup, and we've seen that the VZV IgG is negative, then we will advise them to have vaccination first before they get activated on the waiting list. Again, they will get the 2 doses. And for COVID-19, there's an update, guidance in 2024 to 2025 for our group of patients. And if we look at age 12 and older and hasn't had any COVID vaccine during the pandemic time, then these are the recommended frequency or doses for the patients. Do you use 3 of this formulation, or what did you use when for COVID? Is it vaccine?
Covishield and COVID-19.
There were 2 different vaccines, but the Covishield and Covaxin.
Okay, so none of these 3. Okay, these are UK based. Okay, so I'm not going to dwell on this much, but it says that, say for example, someone who's had one dose, say for example, of Moderna vaccine, then these are the guidelines, and so on. If they had 2 doses, then that will be the guidelines. But if these are the vaccines that you don't use this vaccine, let's move on. Seasonal flu, we mentioned about influenza. So patients who are with advanced CKD or on dialysis, then once a year dose is recommended. Again, for transplantation, we mentioned it, that yes, they can have it, but not the nasal formulation. Again, because it's live vaccine. They can have the injection. Hepatitis B, for CKD and patients on dialysis and immunocompromised, then the advice is 2 to 4 doses. For dialysis patient, it could be more. And this is just an example of our local protocol at St. George's. If the patient's given Pendrix, that's 20 micrograms, they will have it on 0, 1, 2, and 6 month interval.
Here, can I ask a question?
Yes.
Who here gives the vaccines to patients? Here in this unit? Is it the nurses? এখানে vaccine গুলো কে দেয়?
Who gives the vaccine to the patient?
কে inject করে?
Dialysis patient, for example. So the next one is HPV. So patients with CKD and or kidney failure, 2 to 3 doses are recommended for people up to the age of 26. Now the actual number of doses recommendation depends on the age of their initial dose. For people who are 27 to 45, may also be candidate, but they have to check with doctors. For the patients who are immunocompromised, such as transplant patients, we give 3 doses for the age up to 26, regardless of the age during the initial dose. Again, this can be considered depending on their doctors. Measles, mumps, and rubella. Similarly, for CKD and patients on dialysis, 1 or 2 doses recommended with at least 4 weeks apart, but they have to meet all these criteria. If patient is a transplanted patient, then we don't advise this. Why? Again, because it's a live vaccine. So they need to have this. If patients consider for transplant, we need to advise them to have this done before they get activated on the waiting list. Pneumonia. So there are two different formulations for this. So again, for the advanced CKD patients, patients on dialysis or immunocompromised, they can have either the PCV or the conjugated one, which elicits T cell and generates better immune memory as compared to the polysaccharide. So let's just pick this up, for high risk patients or immunocompromised, the recommended schedule may include giving the conjugated version first, followed by the polysaccharide after the defined interval. And so if they were given the polysaccharide, then they'll need to have it again after 5 years. For the RSV or respiratory syncytial virus, it is recommended for everyone who is 75 years old and above. However, if they are over the age of 60 with advanced kidney care, on dialysis, or at a transplant, they are very high risk for severe RSV disease. So they could be discussed with the team. And second to the last, we have the herpes zoster. So for CKD and dialysis patients, 2 doses are recommended, given on 2 to 6 months apart for 50 and up to the age of 50 or older. And if they are under 50, then they can be candidate, but they have to discuss with the doctor. For transplant patients, we give 2 doses recommended 2 to 6 months apart. And last but not the least is the Tdap, or tetanus, diphtheria, and pertussis. So so our patients, the 3 groups, the advanced kidney, advanced CKD patients, dialysis patient, and transplant patient, 1 dose recommended, plus a booster every 10 years. Okay. So what are the special considerations in transplantation? We mentioned that live vaccine is a no-no. So vaccinations such as MMR, varicella, and nasal flu are not allowed unless they've had it before the transplant. And whenever possible, complete this before transplantation. So timing is important. And after the transplant, we still do recommend them to have boosters such as COVID-19, pneumococcal, and influenza. And for herpes zoster, the non-live vaccine is preferred, even in those patients who are immunocompromised, as the efficacy will be lower. what are we going to do to implement the vaccination program for our patients? So one suggestion is to maintain a vaccination audit and registry. For St. George's, we use our renal database to enter every time the patient have vaccination, so you'll get the records that you can easily audit in the future. Or you can use a checklist. For patients on dialysis, you probably have on your like the daily group or the patient record every time they get vaccination, or for transplant patients, also on the workup sheets. Again, providing education is important. You'll hear a lot of education because us nurses, we love educating our patients. So educating during when they are in CKD clinics or before dialysis. And I don't know if you have, you can use a reminder or recall system, like text system to tell them you will be due for your next vaccine on this time. So that's another possible thing. And also collaborate with the primary care, vaccination centers, and the pharmacy. So these strategies improves the uptake and reduce missed opportunities. There's always challenges to all these things. So again, one could think about the vaccine hesitancy or misconception, not just from patients, could be from the healthcare professionals, because sometimes when we believe oh, I don't want to have COVID-19 because my neighbor had a heart attack and this and that, and sometimes unconsciously when we're talking to the patient, it comes out oh, my neighbor. So we're passing on information of personal belief, and even though we wanted to have vaccine, so could be as I said, misconception or hesitancy. Some logistic issues like scheduling, vaccine availability, the cost, and clinic coordination. Reduced vaccine response needing boosters and supplemental doses, timing conflicts in terms of transplantation scheduling. As we mentioned, there's 3 vaccines I've mentioned that should be given before they get the transplant. So recognizing this helps preempts and mitigate them. We're on the last part. So to summarize, vaccination is a cornerstone of infection prevention in renal patients. So it's better to begin early before they start dialysis or before the transplant. Use the full complement: influenza, pneumococcal, hepatitis B, COVID vaccine, shingles, and Tdap, or tetanus, diphtheria, and pertussis. Live vaccines is a no-no for transplant patients or immunocompromised. Strong system like having audit, checklists, records that we can help patients, and patient education are vital. And of course, nurses and the MDT play a crucial role in ensuring vaccination completion. So let's prioritize vaccination as part of the renal standard care, and just a reference list of all the suggested recommendation as we discussed. Okay, thank you. Shall we skip the Mentimeter? Yes? But can I just ask, what will be the takeaway for this topic? What's one thing that you remembered from our just a brief discussion into that? Is vaccination important? Yes.
Education,
Perfect.
Education, motivation, and vaccine.
Thank you. You summarized it.
That's the slogan of the day.
Yes. Okay. Now let's go to the next one. Sorry. Okay. Now, this Topic is my baby. Right. Okay. Maybe I can stand. Oh, maybe I'll go. Okay. So I've mentioned before that I was a transplant coordinator working up donors and recipients in my previous or earlier on my career. So the next topic, as I said, it's my baby, is the transplant workup for recipient and donors. I'll also cover a little bit about kidney sharing scheme. So this is what we have in place at St. George's. So the first one I can't see. To some of the doctors, we've learned that we don't have transplant coordinators here. And the first year doctors are the one doing the workup. Yes.
Might change.
It might change.
Why not?
Yes, that's fine. It's okay. Maybe just on the next topic. Okay, sorry. Every time we change the presentation, we have issues on the IT. So this is what we have in place at St. George's. We've got an 18-week pathway where I'll show you the simplified version. I showed you the simplified version for the patient, because obviously you don't want to put them all the long and detailed one. It's going to complicate things for them. So when we give the pathway to patient, we made it even more simplified. And we have an e-referral, which I helped develop in St. George's. So e-referral, so that means the patients who are considered for transplant workup are referred through our online documentation or the electronic patient records. And I have managed to link it with our Tableau reporting system. So any information that has been entered there, so say for example, on the form, it says which clinic are you referring the patient from. It could be from PD clinic or pre-dialysis clinic or dialysis clinic, and then who's referring and so on, what's the GFR. So whatever you input, we can pull out the data and review it, and we can do a quick audit and find out through our IQIP system and Tableau reporting. And we have high rate of preemptive transplant listing. What is the next one? Oh, the transplant decision documentation. So on our renal database, when it's called CV5, but when it was CV4, I have recommended or suggested to have the transplant status on top of the, when you're on the first screen, patient name, date of birth, hospital number, and then at the end, which clinic they're from, and the transplant status. So whether they're on workup, they are active on the list, or if they're not yet considered for transplant, then that part will be blank. And that will trigger an information like to a clinician to say, oh, this patient doesn't have a transplant status, hasn't been considered for transplant, let me see. And when they are assessing the patient, they can see, oh, well, I think you can be considered for transplant. So the doctor will then refer the patient through the electronic referral system, and the patient will be starting transplant workup. That's sort of just way of.
So can I ask a question? Do you actually have an electronic patient record? You probably don't, do you? So you use paper records. So what Ria is alluding to, let me just give you an idea. আমাদের সমস্ত পেশেন্টের সমস্ত কিছু ইলেকট্রনিক থাকে, মানে প্রথম যখন পেশেন্টের এটা খুলবেন, রেকর্ডটা খুলবেন, যেমন ধরুন আপনি গুগলে গেলেন বা যখন রেকর্ডটা খোলেন, তাই প্রথম পাতায় সব যত কিছু ইনফরমেশন থাকে সেটা খুব জরুরি, কারণ ওইটা দেখেই আপনি বুঝতে পারবেন পেশেন্টটা ডায়ালিসিস আছে না ট্রান্সপ্লান্ট আছে না সিকেডিতে আছে। ও যেটা বলতে চাইছি যে ওই পাতাটাতে যত ইনফরমেশন খুব জরুরি ট্রান্সপ্লান্টের জন্য একটা পাতায় থাকে। সুতরাং যখন ধরুন আমি দেখছি পেশেন্টের রেকর্ড দেখছি, দেখেই বুঝতে পারবো যে ট্রান্সপ্লান্ট ওয়ার্কআপ হয়েছে, শেষ হয়েছে না চলছে, কোন কোন জিনিসগুলো বাকি আছে। ফলে যেটা হয় সেটা হচ্ছে তাড়াতাড়ি পেশেন্টের সঙ্গে কথা বলতে শুরু করে দিতে পারে। নাহলে তো যদি সব কিছু পাতায় থাকতো খুঁজে 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 বের করতে হতো। সেটাই রিয়া বোঝাতে। এবং রিয়ার জন্য যেটা হয়েছে সেটা হচ্ছে রেফারেলগুলো। যখন ধরুন আমি একটা পেশেন্ট দেখছি, প্রি ডায়ালিসিসের পেশেন্ট, ঠিক আছে, তার সঙ্গে কথা বলছি ইত্যাদি, হঠাৎ আমার মনে হলো আচ্ছা এই পেশেন্টের তো কিডনি ফাংশন এখন খুবই কম, এই তো ট্রান্সপ্লান্ট শুরু করা হচ্ছে। রিয়া যেটা করেছে সেটা হচ্ছে আমি একটা জিনিসে ক্লিক করলাম, সেখানে বলছে পেশেন্টকে রেফার করো।
I can show you a screenshot, you can see it later.
Yeah.
I'll show you what it is.
ওটাতে তার সঙ্গে সঙ্গে আমি ওইখানে বসে থাকতে 15 সেকেন্ডের মধ্যে পেশেন্টটাকে রেফার করে দিতে পারি ট্রান্সপ্লান্টের জন্য। তখন যেটা হবে সঙ্গে সঙ্গে রিয়া এবং সিন্ধু যে আরেকজন ভদ্রমহিলা থাকেন ওখানে নার্স, ওরা সঙ্গে সঙ্গে তার পেশেন্টের ওয়ার্কআপ শুরু করে। কখনো কখনো হলে সেই দিনই ওয়ার্কআপ শুরু হয়ে যায়, যেদিন আমি পেশেন্টকে থাকি। সেটাই সব থেকে বড় কথা যে ডিলেটা থাকছে।
Yeah, so before we had the electronic referral system, as Professor Banerjee mentioned, the referrals come through in either like a telephone, the doctor will call me, Professor Banerjee will call me, Ria, I'm seeing this patient, can you start the workup? Yes, Prof, start the workup. But sometimes they will put it on the clinic letter, so say they've seen the patient in the clinic and they will copy me in to say, when I was a coordinator, they'll put down like, I will refer this patient to the transplant coordinator to start the transplant workup, and then you get a copy of that letter. But I've done an audit about this, like how long does it take for that letter to be dictated, to be typed, and to be sent to me. We've done an audit with that, and it took like another 11 days. And comparing that, if the referral was through telephone or face-to-face, say for example, I was walking on the corridor, I saw Prof. Banerjee, Ria, I've seen the patient, can you start the workup? Okay, I'll just write it in my hand, I'll start the workup when I go back to the office. Or sometimes when I come back to my office, there's a post-it or a paper note on my desk, patient and hospital number, start the workup. So it's very informal, and it's so difficult to do an audit. So in 2021, we have launched this e-referral system that helps us with the process as well. Okay, moving on. So yeah, I mentioned about the transplant decision, and these are all the MDTs. We love MDTs. We have so many MDTs, like our lives lives an MDT every day, every week. So we've got, for the pre-transplant patients, we discuss them every month with the consultants and the pre-transplant team. We also have a weekly network transplant MDT where we discuss patients who are a bit complex for transplant or donors who are complicated, and also the live donor pair who are being considered for transplantation. We have a quarterly cardiorenal MDT. Professor mentioned earlier that we have good relationship with the cardiac team, because when we've done that audit, we found out that the cardiac tests are the ones that takes a long time, and for this to have part of our assessment protocol and our pathway, we managed to reduce that, and we have discussion for patients who are high cardiac risk assessment every quarter. For the post-transplant patients, we also have a post-transplant MDT. For our living donors, or even after donation, we have a weekly donor MDT. And lastly, I mentioned earlier that we run a quarterly transplant information program. This is going, but this is not.
নেফ্রোলজিস্টরা থাকে, নার্সরা থাকে, জুনিয়র ডক্টররা থাকে আর যারা এই ছেলে টাইপিং করে
Yes, I can't read it, so I'm coming.
সবাই মিলে
I'm lying.
একসঙ্গে 6-7টা পেশেন্টকে কমপ্লেক্স পেশেন্টগুলোকে বেশিরভাগ সময় ইন্ডিভিজুয়াল ডিসকাশন করা হয় যাদের কমপ্লেক্সিটি থাকে না তারা
Okay, let's try. Okay, so the aim of the transplant workup for donor and recipient is obviously to ensure that they are fit for transplantation, and for donors that they are suitable donor for to donate the kidney. That's fine. Okay, so what's the role of the transplant coordinator? So you can see that's the transplant coordinator having links with all this department, all these people. It's quite complex. So that their role is for patient education. Again, patient education is the theme of the day. So we've got, they educate the patient, evaluation, sorry, that's, it's not going. Okay, so patient evaluation, that's to see if they're suitable for transplant, education and counseling, wait list management, pre-transplant preparation, communication and collaboration, post-transplant care, emotional support, advocacy, ethical consideration, and staying updated. Thank you. This is not talking, and I can't see. Yeah, this doesn't go. So where does the referral comes from? We've got the nephrology clinics, also patients from advanced kidney care clinics. So for us, we call it advanced kidney care. So those patients who are pre-dialysis. So before they start dialysis, we have a separate clinic. So that's what it means when I say AKCC or advanced kidney care. There is also okay. So I mentioned from a dialysis clinic or the ward, and as I said, the patients are referred through our ID referral system. And when when they're at stage 4, that's the time they get referred for transplant workup. Once they've completed a workup, say for example the GFR is still 17, we don't activate them. We only activate when it's 15 and below. This is like a picture of the e-referral that I've mentioned. So this is what it looks like. They have to complete which clinic they're from, whether it's to start the workup or just for the teeth only. Remember the teeth transplant information, or is it just for education, the GFR? So all these informations that we ask them to complete, we can pull out the data and do an audit. Right, so this is a simplified version of our transplant workup pathway, and the next to it is the transplant workup sheet. So here we'll just go through quickly. On the top, when the coordinator receives the referral, then contacts the patient and start the workup. The RTC or the renal recipient transplant coordinator requests the test and informs the patient about it. And once the test has been done, she'll get all the test results, review them, and then pass it on to the nephrologist who has requested, who has referred the patient. If the nurse and the consultant's happy with all the tests, then the workup is completed. The nephrologist will now do a referral for the patient to see the surgeon before activation on the waiting list. We call it PTA, pre-transplant assessment. And the patient seen by the surgeon at the PTA clinic, and the surgeon will decide whether or not the patient can be activated on the waiting list or not yet. If they're satisfied with all the test results, then the patient will be activated and the workup will be reviewed every month. However, if the surgeon thinks that, oh, okay, no, I need another test, I need a CT scan, say for example, or we need to refer the patient to hematology just to get a plan, if they've got any hematology issues, then that would happen first, and then we'll decide whether or not we can support for the patient to be activated. These are the tests that they will do. Everything here on this left side is essential for everyone. So we do X-ray, ECG, the hepatitis B, C, HIV, CMV or cytomegalovirus, VZV, EBV, and measles. Remember I mentioned earlier, if we've seen that the VZV or the measles, say for example, are negative, so before we get them active, we'll advise them to have vaccination. Essentially, we need to obviously to know their blood group. We do tissue typing, 2 sets, 1 and 2, initial and confirmatory. This part here will depend on the patient history. So this, on the top part are the cardiac tests. So depending on their age, I'll go through that, I'll show that screen in a minute. And the patient details and risk factors also very important because that will help us to know what tests they need to do. I'll show that in a minute. And we also ask them for their cancer screening. So national cancer screening, cervical smear, for example, for anyone who is 25 to 64 age, females, and mammogram if they're 50 to 70 years of age, and FIT test or bowel screening for 60 and above, male and female. We also look at their antibody level, and remember I've mentioned about the adding the vaccination on their workup sheet, so that's an example. We write down if they've had a COVID, how many doses, and so on. So that's that. That's a simplified version, but you've also seen the more simplified version on the leaflet that we give to the patient. This is the real deal. It's a complex one, and you wouldn't give this to a patient because it's too much information. But that's the whole pre-transplant workup pathway, which is good. There we have it. Okay, and I mentioned about the cardiac test. So we use this as a guidance of what tests we'll ask the patient for the cardiac screening. We stratify them into 3, minimal risk or negative risk, if they are 40 and below, and they have no diabetes, ischemic heart disease, CCF, or congestive heart failure, or peripheral vascular disease. So if there are minimal risks, they only need to do echo and ECG. If they are low risk, so patients who are 40 to 60, they will have a different test. We'll ask them to do the exercise test, so it's running on a treadmill, but they have leads connected to them to see how the heart activities while they're doing the exercise. And the next one, so exercise test and echocardiogram. If these 2 are all good, then we can then refer them to see the surgeon. But say for example the echo or the exercise test is positive, then we'll ask them to do a dobutamine stress echo. So what it is when the patient is lying down, they will inject a medication called dobutamine, which will then make the heart pumps as if they're exercising whilst lying down, and they'll do the echocardiogram, so to see if there's any abnormality on the heart. So it's looking at the anatomy and the function of the heart, 2 in 1. But a patient is considered cardiac risk, if say for example they are 60, or if they are diabetic, or they've got history of ischemic heart disease, so it's or. Anyone, they're considered straight away. It's not they need to have 2, or they need to have 3, or they need to have all. So any one of these, age over 60, diabetes, ischemic heart disease, CCF and PVD, they're considered high cardiac risk, and they'll do straight away DSP. And what's next? Oh, if they have history of angina, we don't start the workup. We go back to the doctor who referred the patient and ask them to refer the patient to the cardiology. And once these tests are done, patient's been seen by the surgeon, we don't stop the tests there. We review them every month. For patients who are on workup, active, or suspended on the list, we review them. So that's what we call the surveillance or maintenance of their workup. It's just to ensure that when a patient is called in for transplant, there's nothing that will stop them from the operation. You don't want to put their hopes high. They got a call to say, come to the ward, we've got a kidney for you. And then by the time they get to the ward, the consultant look at the workup sheet, echo is not updated. This is not up to date. So, and then you ended up having for the patient to wait, because if it's in the middle of the night, you either have to request an urgent echocardiogram, or say, for example, again, if a patient did say that they've had a recent incident, they went to A&E, they've had or some cardiac event, then that won't get them through transplant that evening or that night, because we have to investigate it further. So that's why it is important to review their workup every month, because anytime, even if say you review them today and tomorrow they went to A&E, we won't know. So communication between the team, the coordinators look at the ward list to see if there's any of the patient active on the list actually an inpatient. So that happens every day, just to see if there's if they see, oh, this patient is active on the list and on the ward, what's the reason? Okay, there's just putting a line in, so it's fine, they can remain active. When we say we repeat the cardiac test, if they are minimal or low risk, we repeat this every 5 years. If they are high cardiac risk, then we repeat it every 2 years, but we discuss them. Remember the cardiorenal MDT? So we discuss them there first, and then we proceed to what test they're going to have next. This is another diagram for our vascular protocol. That's also part of the workup. So, tissue typing. I was asked to talk about the HLA tissue typing and antibody samples. So, again, for every patient being considered for transplant, we require 2 sets of tissue typing samples. That's the initial sample and the confirmatory sample. So, it's not us, it's the lab's requirement. They want to make sure that the first sample that we send, so we're looking at patient's DNA, the tissue typing HLA A, B, or DR. This is what they're looking, and they want to make sure that actually that second sample is for the right patient. So we do send that 2 occasions for every patient. And after that, when they are listed, we don't send them again unless we're instructed to, but we will just require the 3 monthly antibody samples for patients who are active on the waiting list. So what happens, say for example, we've got this sample for patient in January. Let's say January 10, we've got the sample. So that sample is valid for 3 months. So February, March, April 10 or April 9 is valid. If a patient is called in for transplant, let's say March, end day of March, so that sample is still valid. What will happen is that they will contact the lab, and the lab will say, we've got the sample for this patient, we don't need the patient to arrive in the hospital and do the final cross-match. So they will start the cross-match whilst the patient is still on the way to the hospital. So by that, it reduces the time of delay getting on the way, getting the transplant, because to do the final cross-match, it takes about 4 to 6 hours in the lab. And once we know that there is a kidney available and we contact the patient, it could take, up to probably three hours until they get to the hospital. Like, obviously you have the shock in the system, trying to find out who's going to take you to the hospital, and so on. So again, on education before the transplant, we tell the patient this, like, you have to prepare a bag, like, for maternity. Someone who's in labor, who will be in labor pregnant, prepare your maternity bag, get ready, so when you called in, you just grab it and go. So that's sort of like discussion. So what will happen if, say, for example, the patient's sample on the lab is out of date? So that will cause a little bit of delay because they will not use that sample for the cross-match. They will have to wait for the patient to arrive in the hospital. So let's say that's 3 hours, 4 hours. And then the patient will be seen by doctors, nurses, taking bloods here and there, observations. And then that sample will be taken to the lab. That probably another 4 or 5 hours from the time of the phone call. So that's 5 hours gone, and then you'll do the cross-match test, which will take 4 to 6 hours. So that's 11 hours could be an average before you get the result and proceed with the transplant. Obviously, we want a negative cross-match result. So that's why it is very important to have an up-to-date monthly samples in the lab. And say one would ask, what if the patient wasn't called in for transplant? What are they going to do with the sample? They're not going to put it in the bin. The lab will use it to see their antibody level. So if the patient has got negative anti-level in 3 consecutive months, so that's 3, 6, 9 months, they will add that patient on the virtual cross-match list. So virtual meaning if this patient is called in for transplant, they will check first the virtual cross-match. Okay, patient number 1, oh, this patient has got 3 negative samples, and therefore in virtual cross-match, they will do like just on paper, the tissue typing, the HLA type of the donor, and then the recipient, and just matching it on paper without doing the 4 to 6 hours wet cross-match. So we didn't waste anything there. It will be used as well. Okay, so I've mentioned about the virtual cross-match and the wet cross-match. Obviously, wet cross-match is when the actual bloods, donor and recipient bloods are mixed together. Virtual, they just look at the paper. Okay. Any questions in that? Pardon? Rina? No? Okay, maintenance on the list. So we mentioned that once the patient has completed the workup, one of the nurses will review the workup every month of the active patients. So review of workup monthly. If, say, for example, the hepatitis B is due, so that's every 3 months, we check that. So if that's due, then she will check. If the dialysis team has done that, if the patient is not yet on dialysis, it's valid for 6 months. And then arrange the 3 monthly blood samples. We also have our consultants seeing their patients in their clinic, so whether it's a dialysis clinic, PD, or pre-dialysis clinic, and they also look at the patient's suitability for transplantation. And for patients who are greater than 50 and above,
or patient with high BMI of 35 and above, or if they have polycystic kidney disease, we review them, well, the surgeons. The surgeons review them every year. And then you'll say, oh, how about if they are less than 50? Or they don't have any of this, how often they're reviewed? So we review them every 3 years for now. Okay. Some psychological preparation, we mentioned, like, you know, being on the waiting list can be very stressful for our patients. The average, you know, they could be waiting for 2 to 5 years. Some patients are very lucky. 1 week after they get on the list, they get a call. And the call, we call it the call can happen any day and any time of the day. It could be in the morning, it could be in the afternoon, or 2 o'clock in the morning. That's why we advise the patient to make sure that if they do change their contact numbers, to let us know so that we won't spend like 3 hours trying to contact a wrong number. Yes, you know, preparing them about the success and failure of transplant. There's nothing that's 100%, but for St. George's we've got a very high success rate. For patients who receive a deceased donor kidney, we give them quotation of 95 to 98%, that it could last up to 10 years, 10 or 11, 14 years, but if they get a kidney from a living donor, then the success rate is obviously higher. It could last 21 to 24 years, and we give a quotation of 98% for the first year. We also give them information about potential complications after transplant. And some patients says that they feel guilty about waiting for someone to die to get a kidney. So having that conversation with them is also important as part of the preparation. So I grabbed this from our UK registry, just to give you an idea. The gray bars are the number of transplant that has happened in this financial year. So this is 2024-2025, so April 24 to March 25. That's the number of transplant, that's the number of donors, and this is the growing number of patients waiting to have a kidney transplant. This is just a quick comparison for the amount of donors who come forward as a to be tested for kidney donation, but you can see that the number of donors who have donated on each year is very small. Why is that? Well, some patient, one recipient can have 5 donors, or it could be that the donor are not medically suitable. We have a very detailed, meticulous workup for donors because we want to make sure that they are fit and healthy to donate the kidney. So yeah, talking about the living donor coordinator's role. So as you can see, similar to the recipient coordinator, these are all the people that they try to link to in order to get a donor to donate the kidney. So similar role as the recipient. And what's the benefit of the living donor transplant? So we know that this is provides superior quality of kidneys, superior patient and graft survival. I've given the quotation earlier, and the success rate. So the flexibility of the transplant date. What does it mean? Because if we've got a live donor, we can plan it as to when we can do the transplant. Some donors, say for example, if they're teachers, they said, oh, I can only do the operation during the school break. Or say, oh, we completed the workup, but my donor is planning to book a holiday going to, say for example, in France at this time, so we try to avoid that date until they come.
they're ready. So it's negotiable. It's negotiable. Negotiable. But we also look into if they're pre-dialysis and say, okay, the GFR, say for example, is just there 11, 12 and maybe having some symptoms already, then you don't want to wait until 6 months and maybe having that discussion between the donor and the recipient and just giving them they need a transplant sooner rather than later. So as much as possible, we try to, especially if they've got a living donor, we try to have the transplant preemptively and not after they've started the dialysis. Okay, next. Preemptive transplant is possible, I've just mentioned that. And obviously, yes, it avoids long wait and unpredictable waiting time for compared when they are on the transplant waiting list. So similarly to the recipient, we have our pathway for the donors and also the workup. It looks the same, but it's different tests. And you can see that there are more tests for the donor compared to the recipient, because these are individuals who are coming voluntarily. We want to make sure that we go through everything. Anything that flags up red on the result, we look into it further, because we don't want for them to have, say for example, to risk their own health by donating a kidney. And what are the options for the living donor transplant? So it could be directed. So we have the ABO, so blood group and tissue typing compatible. Tissue type, yes, compatible transplant. Or if they are incompatible, I know from the discussion this morning you do the ABOI here. And also there's some arrangements on manual kidney swap that's happening here as well. So I'll share that information what we do in the UK. So if they are blood group incompatible or HLA incompatible, previously in St. George's 2009, we started that blood group incompatible transplant. But we don't do that anymore. For now, if we have pairs who are blood group incompatible or HLA incompatible, the first, we advise them or we educate them, told them about the kidney sharing scheme or the swapping of kidneys. I'll give you more information on that in a minute. We also enter patients for kidney sharing scheme, not just because they're blood group or HLA incompatible. We have some patients that say, for example, the age match, they are, let's say, blood compatible, but the age difference is quite wide. Say, for example, the recipient is 25 years old and the person donating may be an aunt who is 65, so you've got that big of age gap, and we can enter them on the kidney sharing scheme to see if they will be matched to a younger, so say for example, if this recipient will get a kidney from, let's say, 30, 40-year-old donor, and so is the other one for the donor donating to an older person. So we can use that for a better match. Same thing as well for the HLA, even if they are compatible HLA-wise, but the DR or the number at the end is 2. Remember the 2-2 mismatch and so on. So the DR, they can get better HLA match on the kidney sharing scheme. So the KSS, that's the kidney sharing scheme. It's run every quarter. These are the months that we do it. What we do is we enter the pairs who are, let's say, blood group incompatible onto the screening. So this time, October, the living donor coordinator is registering the pairs that we have. I think so far there are 10 to be entered into the sharing scheme. And it could be live pairs or altruistic donors. So altruistic donors are individuals who come forward wanting to donate the kidney to anyone, even if they don't know. Do you have that here? Altruistic donation? Okay.
So yeah, we call them altruistic donors. And for this KSS, we aim to transplant if they get a match. So say for example, the October run. With a click of a button, we've got a date. The whole UK transplant team knows when the matching run is. Once we've entered the pairs, click of a button, ding, 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 it's like a lottery, and then they can match. I'll show you what it looks like. But when they do get a match, the aim is to transplant those pairs within 12 weeks. Why? Because the next run is in 3 months' time, so that if this is not going to go ahead, we can enter that pair again on the next run in January to be entered and see if they will get a match and get transplant this time. So the let's start off with the altruistic donor. So we mentioned anyone comes forward, knows no one with kidney failure, then they will be matched to a tier A, or high-risk patients who are, let's say, have been waiting on the list for over 10 years, or with a matchability score of 10 and a CRF. That's CRF 100, so that means that patient is so difficult to get a match because of their antibody levels that's too high. Why? It could be that they've had previous transplant, or they've had numerous blood transfusion, or for female, if you had pregnancy, then you can develop antibody levels as well. Okay, so this is the diagram. Let's now look at the simple one. Say, for example, you've got a pair, a donor and a recipient, and then they got a match with another pair. Say, for example, this is our hospital in London, and this is in Coventry. So the donor in St. George's will donate to the recipient in Coventry, and the donor from Coventry will donate to the recipient in St. George's. An easy swap. Let's make it complicated. Let's say they have 3 different centers involved, or 3 pairs. So the first pair, again, the St. George's, and this is the Coventry, and let's say this is Glasgow. So the donor from St. George's will donate to Coventry, the donor from Coventry will donate to Glasgow, and the donor from Glasgow will donate to St. George's. How it happens, it's very complex. It's a lot of coordination, contacting the different centers that you're matched with, arranging for the cross-match test on the days. We have the initial and then the final, and also agreeing to a date of transplant. Some hospital, like for us, we do the live donor transplant on a Wednesday, but other hospitals, they don't do it on a Wednesday. They either do it on Friday or Monday. So they will say, we don't have a list, and so is the others. But for St. George's, we try to obviously offer first our Wednesday, but if they can't do it, then we'll accept whatever dates, and then we'll request a different day for theater. And again, it enables us because we have good relationship with the MDT, with the theater people, and they always accommodate if the patients are for KSS. We mentioned about altruistic earlier. So say, for example, that altruistic donor was not matched to the complex recipient, then they will be entered into the KSS. So this is the short altruistic chain where it involves a pair. So what happens, this very kind individual is donating, say for example, to the St. George's recipient, and the St. George's donor will be matched to someone on the transplant waiting list. So he's very lucky. He's on the transplant waiting list, but he's getting a kidney from a live donor. The long altruistic donor chain, involves 2 pairs from the kidney sharing scheme. So again, the live donor donating to St. George's recipient, St. George's donor will donate to, what did we say earlier, Coventry, and then the Coventry donor will donate to someone on the transplant waiting list.
And it's all done like, the matching is done electronically. Just to give you okay, I'll just run this very quickly. Just to give you an idea, this is the audit we've done for the kidney sharing scheme for 2024. In 2024, we have entered 34 pairs for KSS during these different months. Oh, look, October last year we entered 14. This year we're going to be entering 10. These centers here, because we do transplant for 2 referring centers, St. Helier's and Brighton, so they are part of our program. And we can see that for last year, out of the 34, 16 got matched. And we have transplanted 15. So you say, what happened to the one? One collapsed. Because it's not always guaranteed until they're being put to sleep, the donors are put to sleep, because when we do the transplant, we do it simultaneously. Say, for example, the 3 centers agreed for 1st of October. So in that morning, the coordinators will be contacting each other. Okay, are you ready? Yes, everything good? We're going to go to theater now, or to operating OR, operating theater. So now, before they put all the 3 donors to sleep, the coordinators, yes, are you ready? Yes, okay, they're going to be put to sleep. So that's, so that it's not unfair on one when one says, oh, I don't want to do it. What are you going to do? And the rest are, so, you know, that coordination. But what happens is that 2 days before the transplant, during the pre-admission, one patient from another, you know, that complex matching, one of the patient was unwell. So obviously, the transplant did not happen. So, and the reason for not proceeding is obviously that we cannot proceed giving this and then the other one will not get anything. So it's been stopped. But and what they've done is re-enter to the next scheme. You see the word embedded here, so we can see here that out of 4, 1 proceeded but embedded. So what it means is that if I go back, so say for example this one, they're meant to, let's say the 2 pairs. Okay, so say for example one of them become ill or pulled out for any reason. So let's say the donor got COVID, so they cannot proceed until, because they need to have, like for us, like 6 weeks before they proceed. So they're out, but if they given us like the embedded to see if these 2 can go ahead, we can do that test and we can proceed. So that's what happened here. So one of the exchange proceeded as a backup. Let's use the word backup for the embedded. So that's good. Oh. Okay, donor follow-up. Okay, that's it. Okay, so now we're proceeding on to donor follow-up. We've operated the donor, and now we don't just take the kidney and say goodbye. We do follow them up in the clinic. So the first appointment after 2 weeks of their surgery, they get to see the surgeon, and then 3, 6, 12 months, they see the nurse, and then yearly. So it's a nurse-led clinic. That's it for the workup. Any question? Sorry?
So what's the time?
What is the average timeline or time taken for a donor or a recipient for completing the workup, pre-transplant workup?
Okay, so for the recipient, the aim is 18, recipient and donor is an 18-week pathway. For St. George's, average, the last time I've checked using the Tableau reporting system is 98 days. So that's within the 18 weeks pathway, like 14 weeks if we calculate it in on weeks, which is good. For the donor, even though we aim 18 weeks, it could be longer. Why? Because we cannot force the donor to come and attend their workup. It's more of like a donor-driven workup. We notice that there are some donors who will engage for the early stage of the workup, and then you give them an appointment and they're not there, they're missing out. Or say for example, they say, I've got work, I won't be able to come, and so that drags it. That's why at the moment in UK, even though that's the aim, that's not really set in stone that you have to finish in 18 weeks. There's some work that completes before that, which is good. For the recipient, what could we think the reason why for the delay? Usually it's the cardiac test. If they're complex, say for example a high cardiac risk where they have to have an DSE, but then the DSE is positive, so they need to have coronary angiogram, and that process takes quite a bit of a time for them to get that card. Or if they've got other medical condition that needs clearance before the surgeons and the nephrologists will be happy for them to be transplanted, and we have to wait until that's cleared or resolved.
Any other questions?
Just with the interest of time, I know some of you needs to go. Do you have any questions?
No. I think everybody wants to go home.
Yeah, let them go.
Call it a day now. So thank you all very much for coming. I think stay up. Oh, we need a group photo. Yes. Can you all come forward here, please? All of you. We need a photo with everybody.
Once more, please. Thank you.
Thank you very much.